Device Update 2021, and we have the masters speaking on cardiac devices in next 6 hours. And I hope it will be extremely educating and a learning session for all the participants, including all of us. So it will be an interactive session. So without wasting time, let's get started. So I invite the chairperson of the first session, Dr. Debabrata Rai, to take on with the further proceedings. And the first speaker is Dr. Sanjeev Mukherjee. Debabrata sir.
Yeah, thank you, Dilip. So it has been a wonderful initiative on part of Dr. Dilip Kumar to organize such scientific seminars. And without wasting any time, I would request Dr. Sanjeev Mukherjee. You all know Dr. Sanjeev Mukherjee doesn't need any introduction. He is a well-known electrophysiologist, senior cardiologist attached with Medica Hospital. And I invite Sanjeev to start his presentation on abnormal venous connections, which will be relevant for pacemaker or other device implantation. And I can promise, as usual, it would be an excellent academic feast for you all. Sanjeev, up to you.
Thank you, sir. I will.
Sorry to interrupt. One more thing I want to tell. We have got 24 topics today. So we have to be having a 10-minute session with 5 minutes of discussion. So we will have to stick with the time. And with this, we can start. So Sanjeev, over to you.
Yeah, sure. So I will be quick. And in the next 10 minutes, I'll be on my talk. So respected chairpersons, my dear friends, good evening. I thank Boston, Abbott, and Medtronic for organizing this. So in the next 10 minutes, this is the topic. I apologize for taking liberty to cut short my topic. I have taken off some part of the topic. The topic now is abnormal anatomy and associated challenges in pacing. I'll discuss quickly a few cases as we had planned. So starting with my first case, this was a 50-year-old lady who was referred to us with the intermittent symptomatic 2:1 AV block. Her echo showed, a baseline echo showed dilated coronary sinus. So we expected persistent left SVC. And therefore, the plan was very clear that we will go and put the device on the right side. And so went ahead and before draping, we took a right venogram. And this is what we got. The right there was absent right superior vena cava. The right brachiocephalic was connecting straight with the left brachiocephalic, and as expected, there was a left persistent SVC which drained into coronary sinus. Now, so obviously we did the define the anatomy better by a left venogram, and it was well seen. So options were 3. We could have asked the patient to go for an IVC approach, where we put the device on the pulsator on the anterior abdominal wall that we normally do with all post-Glenn. Micra was an option, and also epicardial pacemaker. So all that was discussed, but obviously patient's relative wished for device from the LSVC, as we discussed with them. Now, in these cases, just for relevance, we must remember that any complication will not be tolerated well, because here the entire venous upper system venous drainage is going through the LSVC. So we should be quite delicate in our handling of wires and sheaths. So we took a Thermoglide wire and were able to cross into the RA, and we took our sheath down. Remember, in these cases of LSVC, getting your RV lead is most important, because that is what is a bit difficult. So we were able to get somewhere around the septal part, infratricuspid, that region, we were able to get our lead, which was more stable. And the right atrial lead was not very difficult, and it was done in a standard way. So the RV lead is something that we need to know and discuss. How do we put the RV lead? Remember, the coronary sinus os, is very close to the tricuspid inlet, and therefore your wire, whenever you'll try to push your lead, it will get deflected on the RA wall. That is what will always happen. So what you do is you take your stylet and you make the stylet, you give a curve, what we call as Bond's curve, a large C curve you make, and make a small secondary curve on the distal end. And with that long curve, you will be able to get into the tricuspid valve. And once you are in, pull back your stellate and allow the lead to fall in, and then you can take it to the apex or septal part wherever you are planning to put the lead. Now, that is the only challenge that will happen in these cases of LSVC when you are putting your RV lead. And so once your RV lead is in, the LA lead normally in a standard way will go and fall in the lateral wall. If you want to get it into the appendage, you will have to do a slight clockwise torque. So you will get the RA lead will not be very difficult in these cases. If we discuss of epidemiology, it's this particular case. I mean, normally LSVC will have, it's about 0.5, but isolated LSVC is very, very rare. It's about 0.07 to 0.13% in general population. And it is basically because of failure to regression of the left anterior cardinal vein, as we all know. And most of the time it will be draining through the CS into RA. Rarely will have an LA drainage where the patient will present with cyanosis. So it will not be a great difficult. I think in today's world, LSVC pacing is more or less a standard accepted norm, and we should be able to handle it. The only thing is it presents without telling us. So that is the time we should be mentally ready. Next case, a 79-year-old lady, known case of chronic obstructive pulmonary disease, a lean thin lady, BMI of 20, presented with symptoms of complete heart block. She underwent a dual chamber permanent pacemaker, and 3 hours later, she started having central chest pain and an unwell feeling. So obviously an X-ray was done, and this is what we noticed on the X-ray. As you can see very clearly, what was noticed on the X-ray was that she had a pneumothorax more on the left and also a small on the right. So she had bilateral pneumothorax. And why I brought in this case is because there are certain high-risk features when we take patients for pacing, which is more or less a very standard and safe procedure. But if a patient, female gender, BMI less than 20, elderly, more than 80, patients who have got chronic obstructive lung disease with inflated lungs, somebody who has already shown a bullous emphysema, patients on blood thinners, emergency procedures, restless patients, these are all very high-risk subsets. And in these cases, when we go ahead with a subclavian or axillary puncture, we must maintain some caution, try to do venography, use fluoroscopy guidance, and if cephalic cut down can be done, then that's definitely a very good option. The most interesting thing in this case was bilateral pneumothorax. Now, left we can explain probably while the subclavian puncture was attempted, it would have caused trauma to the pleura and would have caused the left pneumothorax. This expanded, she was given an ICD. But right-sided pneumothorax, which had the contralateral pneumothorax, was probably because of right atrial lead. Now, the possible mechanisms are one, many a times the right atrial lead will perforate the RA wall, which is very, very thin. And very rarely, the entire Seldinger set, when we take down, can cause injury to the SVC in its extra, in the extrapericardial part of SVC, you can sometimes cause injury and cause these kind of contralateral pneumothorax. CT scan is the best way to diagnose, confirm the findings. Most of the time, you won't have to do anything. They resolve, they heal spontaneously, and nothing else is required. But this is something which should be kept in mind in such cases. The last case, a 65-year-old male, known diabetic and hypertensive, who presented to us with history of presyncope and exertional dyspnea. And the Holter showed very, very long pauses, which correlated with his symptoms. So more of a symptomatic sick sinus individual. And his echo showed a situs inversus dextrocardia with no other structural heart disease. So it was a standard mirror image kind of dextrocardia, but there was nothing else other than that, no shunt lesions, nothing else. His coronary angiogram did not show any critical stenosis and showed a plan for a pacemaker in a conventional way. Now, we thought we'll also do some amount of basic EP, and so we took our catheters up, but unfortunately we were not able to move our catheters. So I have put on the right the image, and this is probably what the anatomy was. So what we did was to define the anatomy well. We took a Terumo wire and defined the anatomy. So probably he had an inferior vena cava, which was probably double inferior vena cava. There was discontinuation of IVC, and it was an azygous continuation, which went up and connected with the right brachiocephalic. And that is how the anatomy was. So, so the decision was obviously, a device has to be put. So dextrocardia, we all know, means their entire cardiac mass is in the right hemithorax. And this patient had a mirror image, normal vestibular arrangement, and without much of an intracardiac defects. And statistically, they have about 23 to 70% of patients may have defects. Now, in this case, we decided to go from right side because there is a small case registry from our very own Jayadeva Institute, which was published in Europace in 2014, where they have implanted pacemakers all from the right side. So based on their experience, we went ahead with the right-sided implant. And I was lucky in this case because TPI was not required. He was more of a 6 sinus. But if you have to put a TPI, you need to have a barred lead, which is 110 centimeter balloon tipped, a long lead, which you can take and manipulate into the RV in these kind of anatomies. So obviously, any such kind of an anatomy, you need to define the anatomy well. We have shown with the Terumo wire, and we took 2 check angiograms, kind of venograms, and it more or less was what we have seen before itself. So this was from the brachiocephalic, and this is what we have seen with the Terumo wire. So the anatomy was more or less clear. So we went ahead with the right-sided approach, and we did not have much of a difficulty while manipulating lead. Only thing is that, remember, when you put your RV lead, make sure that in RAO 40, it should look towards the spine, and in LAO 30, it should look towards the apex, just reverse to what we normally do in our other cases. And right atrial lead position is confirmed by to and fro movement of the lead tip and by the anterior position of the lead in LAO view. So this is what we got, and the leads parameters were pretty well, and we accepted that, and the patient is doing well. So I think I'll end here. Thank you.
Yeah, Sanjeev, as usual, excellent exposition of some clinical cases. So I think we have another 5 minutes time. So any quick comment or any question from anyone in the audience?
Sanjeev, I have a comment on that.
Yeah.
We shouldn't be that harsh on an operator that he caused pneumothorax left and also right through right atrial lead. So there can be one possibility as well.
Yeah.
That is, once you do a hemothorax on the left side, so the left lung function goes down, right function goes up, and if the patient has a bulla in the right, so it can also rupture. So that could be another explanation of a bilateral pneumothorax in a patient with left-sided procedure. So
yeah, I agree. Possible. Yeah, definitely. So.
Sanjeev,
yes,
in your registry, you are taking up the dextrocardia cases with the for the pacemaker with the right-sided approach. Is there any particular reason for choosing the right side for the dextrocardia?
Right, sir. No, I was quoting a paper from Jayadeva, sir. They have published a case series of 6 cases in Europace in 2014.
Okay.
And in that, they have implanted all the devices from right side, though no logic was given. But that being an electrophysiology center, we all electrophysiologists like putting from the left, but they have put everything from right. So I just followed their approach because I didn't want to try something new here. That is what I said. So I followed the right, but I don't think there is any reason for it. Maybe from the left, you might require sometimes a longer lead, probably because the course, if you look like it has got some tortuosities, and probably that might be the reason.
Another question is sometime with the dextrocardia, if you reverse the image in the intensifier, then possibly you can do the same thing like in the levocardia. So
true.
Do you agree with that?
Yeah. So that is how we do all the angiograms. In this case, also the angiogram was done similarly. But the interesting thing was here discontinuation of the IVC, which I was not expecting. The IVC was interrupted, and there was a azygous continuation. So that the TPI lead didn't go, and there the whole kind of confusion started. So what I wanted to convey was that these kind of things can happen in a patient where you're not expecting such things, and there I think a mental preparation is what we should have. That's the only thing. So once I was not able to take my TPI up, then the whole thinking process started, how and what, whether I should come from left, because normally I put my devices from left. So that is the thing. But I agree to your point. If you reverse, yes, it will be like a normal case.
Yeah, Sanjeev,
yes,
I know you had very less time for showing your cases, but any quick comment on your cephaloaxillary confluence you faced any in your experience?
Yeah. The first case in the persistent LSVC, the initial wire
for the fellows who are attending this program, right, how to overcome this. Just a quick comment.
True. So in the first case, LSVC, I would say, yes, there was initial resistance, and that is why a Terumo wire was taken. And I had some slight resistance in the movement. And that is why I said, please maintain caution, because that is the only venous confluence you have. Your right SVC is also not there. So go gently, and normally a thermowire makes its way. Once it is done, then you take down your sheet, which might show some resistance, but most of the time you'll be able to take it down, sir. So not much of a problem, but there was some initial resistance. That's it. Yes.
Dr. Anup Gupta was giving some comment.
Case, like, means normally we don't switch over to right side if it is a left persistent left SVC. Probably we have done more than 20-25 cases now. In fact, we have put a lot of CRTDs and CRTPs also from left SVC. So things like, you have to make a curve in your sheath, and your regular wire, that should be fine, because when you are dealing with the left SVC is so much so dilated. In fact, you can put 7, 8, 9, 10 leads, whatever amount of lead you really want to put. The other comment, Dr. Das has already said, like, you can make a mirror image for dextrocardia, things become very easy. And again, if you're doing for a dextrocarditis versus choosing a site right versus left, it's all up to the operator, but it doesn't really matter from which side you really want to put. And venogram upfront is always good for axillary vein puncture. There's no question about it.
Okay. Sanjeev, thank you very much for your excellent presentation. And over to you, Dilip.
Thank you, sir. And it was a great opening of the day. And the second session is by Dr. Anup Gupta, difficult decisions in AICD cases. We have Dr. Arup Das Biswas as the chairperson and Dr. Ashish Haldar as moderator. So over to Dr. Ashish and Dr. Arup Das Biswas. Dr. Das Biswas, sir? We can't hear you.
I think he is there, sir.
He is on mute. So Ashish, you can.
Okay. Good afternoon, everyone. We are just about to begin another session after an excellent talk of Dr. Sanjeev S. Mukherjee. So we have with us two eminent cardiologists of India, Dr. Professor Arup Das Biswas to chair the session, and Dr. Anup Gupta, who will be talking on difficult decisions in AICD cases. So over to you, sir.
Yeah, thank you very much. And thank you, Dr. Dilip, for inviting me. Am I audible?
Yeah.
Yes, sir. You're perfectly audible.
Okay. So in fact, I was wondering, like, what should I show for a difficult decision in AICD cases? And when Dr. Dilip said, like, most of the audience is a cardiologist, fellow and cardiologist. So I think it should be quite appropriate, because nowadays what I'm going to show is, like, it's a forgotten thing inside the cath lab, and we don't often perform the same thing. So this was a very young guy, 30 years, had an episode of VF, and who underwent CRT-D implantation for heart failure, and as well as ventricular tachyarrhythmia as a bridge therapy, because the family was counseled, like, it's a very sick heart, probably he will down the line, he will require a transplant. But for the transplant to survive, we wanted to give him a CRT-D implant. The LV ejection fraction was very, very less, 10-15%. In fact, I remember, like, when he was admitted, it took almost 3-4 days to make him settle down so that he can undergo the procedure. And since he had 2-3 episodes of sudden cardiac arrest, so he was on Amiodarone for last 3 months. So the implant was pretty good. And this is what the topic, like, which I'm going to focus. So defibrillation threshold testing was not performed in view of good lead impedance and good lead parameters at the time of implant. And to our surprise, the patient, though the LV was quite dilated, he improved remarkably after CRT-D. And from NYHA class 4, he came to class 2. And LV function also improves remarkably at 35%. And he came for a follow-up. And, after 2 days, like, after 3 months, when he came for a follow-up, after 2 days, I got a call, like, he has become unresponsive at home. So he had a sudden cardiac death after 3 months at home. So this was the initial implant. And if you see the lead position, pretty good. In fact, you can make out like the heart is too big, very big heart. And that is the reason, the family was counseled, like, probably he's going to require a transplant for sure in future. So now the thing is, like, why this thing happened and what is exactly it is. So, if you go through all the studies, and which has been shown, like 32% of cardiac death seen in ICD could be due to sudden cardiac arrest. So all the studies, like, if you take EVIT, CASH, SIDS, MEDIT1, CABG patch, MEDIT2, DEFINITE, DYNAMITE, ERSCA-DEFT, whether it is for primary or for secondary prevention, if you see the percentage of sudden cardiac death is almost like 30%. So 31.9%, if you see here. So the combined percentage is almost 32% of sudden cardiac arrest. So this is one thing which really bothers, and, means I'm quite sure, like, most of the cardiologists who are attending, they must have heard about the same thing, like, after giving an ICD also, patient had a sudden death. And to explain the family, sometimes it becomes very, very difficult for us to explain, like, what exactly has happened, why it happened. So sudden death, in spite of ICD therapy, we know if the patient is in STORM, 16% of patient, or it could be primary no electrical activity, so pulseless electrical activity, that is almost like 20%. But most common, which are rectifiable thing, is the post-shock pulseless electrical activity, which is almost like 35%, and shock failure, that is again 30%. So these are the two subset, like, where you really want to work out and see how you can improve the thing, because these are treatable by improving the safety margin. And one of the reason, like, is patient dying is they remain in VF despite getting many shocks, and then finally it becomes a pulseless electrical activity. So 65% of sudden cardiac death in ICD could be avoided by improving the shock effectiveness, because if you see here 30 and 35%, so almost 2/3 of the patient, you can definitely do that thing. Now, retrospectively, we were wondering, like, we should have done, because the factors which really have been associated with high DFTs, low ejection fraction, so it does fit into that thing. In NYHA class, he was class 4. Again, it fits into that. He was on amiodarone, and we know that amiodarone increases the DFT level, threshold level. So, and he was on amiodarone for more than 3 months, I would say. And again, he had history of ventricular fibrillation also. These are the subset where, high DFTs are expected. And in fact, sometimes you perform a DFT during the implant and it can change over a period of time also. So there are no perfect predictors of high DFT. And I believe me, like, 90% of time we are not performing any DFTs nowadays, because the lead parameters, if we are happy with the thing, we are happy with the fluoroscopic imaging of the lead, we don't perform DFT. Many times, if the patient is very sick, we are quite reluctant performing DFT. And in this case, probably that was my mistake, because, I thought that patient is too sick to perform a DFT. I wanted to avoid performing a DFT. So if the scenario is a high DFT, so what are the approaches, what you can do? The most important thing is the RV coil polarity. So if it is positive and the anode thing in the coil, that is very, very important. So it can lower or equal the DFT in 88% of patient. 12% what is not done is probably because of noise. Must be changed in the same modes, and there is no side effect. Again, coming to single coil versus dual coil. So, nowadays preference is always single coil. We don't go for dual coil. The reason is because if the patient has got some kind of infection, or suppose patient need any upgradation, or suppose some lead malfunction and you want to expand the lead, so single coil is much easier to remove. So that is why, and in this patient, we went for dual coil. The reason was because we knew that it's a big heart, probably will require a dual coil. And that is what we call as a cold can. If you have a high voltage devices, so, you can reduce the DFT by 25%. Again, that's very, very important. So, selecting patient with a big heart, with a severe LV dysfunction, if you can get a high voltage devices, again, make a lot of sense. The other thing is, if you have got a function of programming the pulse width, so certainly you can again reduce the DFT by 40%. This, when I was in US, because the patient used to be like 400 pounds, 350 pounds. So, we used to put a lot of subcutaneous array at the time of implant, suppose the DFT is high. But again, believe me, this is a very tedious job. You need to call a surgeon, and then the placing all the 3 arrays in the subcutaneous part took a long time, and sometimes patient used to complain a lot of pain in that thing. The other thing, like, what, if it's a high thing, if you have got azagus, it's a blessing in disguise for ICD. So you can put an additional lead in the azagus vein. So, it is a very, very good vector conductor. So, you can reduce the DFT, though it's difficult to implant. But if you have an azagus, you can certainly put a additional lead in the azagus vein. So when we are talking about the RV coil polarity, so all the meta-analysis, it has shown, like, if you have a positive right ventricle, it is almost like 46% is better than the negative polarity. And this is what I said, like, 88% of time, you can optimally get down the DFT level, 12%, mostly the statistical noise. And the polarity, the most important thing, polarity should be set at RV and node, and it should never be reversed. That's very important. So coming to single coil versus dual coil, again, if you are putting 2 coils and you are making the SVC coil on, so you can have from the RV coil to the SVC coil, it could be 1 vector, or from the RV coil to the can, it could be second 2 vectors. So if the can is off, then we call it a cold can. And if the can is on and it's a single lead, like, you don't have a SVC coil and you're doing only from RV coil to the can, so we call it a hot can. So the difference between the two is the defibrillation energy travels to the can in single coil, and in dual coil it can go either to SVC or as well as to the can. So the studies, what has been shown, and it was done way back in 1999. That time, there were a lot of things coming, whether you really want to have a cold can or not. So what it showed, like, hot can was better than the cold on the right side implant, only on the right side implant. So the defibrillation threshold was lesser for the hot can in comparison to the cold can. And cold can was worse, 27% worse than the hot can. The other important thing, if suppose you are implanting ICD from the right side for any reason, like, suppose you have got a left persistent LFCC and you don't want to put a ICD lead from the left SVC, or you have got an occluded vein, or you have got an infection on the left side, always perform a DFT from the right side, because the DFT from the right sides are 50% higher in comparison to the left side. So if you see here, the DFT 17 versus 11 in the study by Friedman et al. So right side always perform DFT because the DFTs are high, and hot cans can be better than cold on the right side. So this is what I was saying, like, putting a subcutaneous array, and this is how it looks. So, means you have got a device, so you have a connection for the subacute array. So these subacute arrays should be separated apart, and they give, additional safety for the shock. So this is how it looks in a PA view, and this is how it looks in a lateral view. The other thing, what I said, like the previous speaker's case, where there was a persistent aegis, if you have a big heart and you have got an aegis vein, so in that case, you can put an additional lead in the aegis vein, and the aegis veins are always posterior, always posterior. So, the best view to see it on the lateral aspect. So inside the cath lab, you do a lateral aspect, see whether you have placed the lead very well in the aegis or not, and then you can test the threshold level there. Certain patient in which that the transvenous threshold is pretty high and patient is undergoing for surgery, this has become very obsolete, but the defibrillation patches, the epicardial patches are still available. You can order those things. These patches are sewn directly to the outside of the heart, placed maximally across the heart mass. So one is in the RV anteriorly, the other one is laterally to the posterior part of the left ventricle, and these are made of a titanium mesh, and the Dacron, it reinforces the rubber. So this is how it looks. If you see the patches, this is how it looks. And you can put the patch across anterior and posterior in the RV and LV. And there's a schematic diagram you can make out. You can see here, this is the RV and this is the LV one. And again, the fluoroscopy or the X-ray shows the patch like this. So epicardial system, the patient who has got infection, this is the only indication nowadays. If the patient has got an infection both sides, and his patient is not affording the subacute ICD, because now the subacute ICD has taken care of this thing. So, the epicardial system and the patches have become very, very less. Or else the patient is undergoing a CABG surgery and the patient needs an ICD as a secondary prevention, and you want to put a surgical patch. In that case, you can think about it doing the thing. The other thing, how you can reduce the DFT is biphasic shock and membrane burping response. So this is very important. The shake, if you see the shock waveform, and the membrane response. So the first phase, it charges the cell membrane. And when the second phase comes, it removes the residual charge on the borderline, and return the cell membrane to the baseline. So the waveform truncation should occur when the cell is most responsive. And here you really want to give the shock. So, it can reduce the DFT level by giving biphasic shock. And what I said, like the newer generator, they have got a programmable pulse width. So it can allow the energy to be delivered more efficiently, matching the waveform. So whatever the waveform, if it is a large waveform, so you can have a pulse with a 4.5. It is short, it can have 2.5. So the shock truncation is there, and you can really help the patient to do that thing. And this is what it showed, like it could be slow conduction, it could be medium, or it could be fast. So it could be slow, so slope is going to be very, very long. It could be medium, that is what you normally see, and it could be fast. And according to that, you set the pulse width, could be 3, could be 3.5, could be 4. And according to that, you set it so that the depolarization time matches the impedance value, and the appropriateness of the shock is very, very high. So this guy was when he came to the hospital, he was in incessant VT at the time of admission, which was reverted by external DC shock. The hemodynamics improved immediately, and patient, even the cardiac function, everything's fine. But by the time you reach hospital in Indian subset, the patient doesn't reach in 10 minutes, 15 minutes, and that's a quite a long time. So he was brain dead after 3 days. We, the family said we don't want to continue. And that's how it So conclusion, DFT is a very debatable issue. You really need to, it's a clinical judgment in each cases when you want to perform DFT or not. And most of the time you should find out what are the reversible causes of high DFT and which can be corrected. Most important thing, if the patient is on chronic amiodarone therapy, that is one thing you should think about it. If it is a large heart, always think about putting a high voltage device in those situations. I'll stop here and take your question. Thank you very much.
Thank you, sir, sir, for a great presentation. Any question from any participants?
I think with this devices we can give high voltage, and increasing capacity of delivering high volts, the requirement of arrays and the additional leads are gone. And so as the epicardial, we don't think, and it's a kind of a at this present juncture, maybe it is obsolete. What's your idea? And besides a large heart or maybe a chronic amiodarone therapy, which are other cases where you would like to go for a kind of DFT testing?
See, that is the most important decision when you're implanting an ICD nowadays. Means I would say like 10 years back, 15 years back, when we were implanting ICDs, we were doing DFT in probably each and every cases. Now for less 10 years, because two different schools of theory, like, people say now you don't need DFT. DFT doesn't help because over a period of time, it keeps on changing. So we don't know. But in my clinical practice, if I'm doing any implant for a secondary prophylaxis, one thing, if the patient NYHA class is high, if heart is big, or patient is on antiarrhythmic medication for a longer time, certainly I do a DFT. Till now, I do all DFTs, because the thing is that, if you do a DFT inside the cath lab and the DFT is high, you can try and rectify the things. The important thing is, if suppose you don't perform a DFT and patient gets an event at home, many times we are not able to make the patient survive. So, you cannot rectify those things. So that is the reason I said it's a very, very debatable thing, very, very debatable thing. I really don't know. Primary prevention, I don't perform any DFTs, because if the lead parameters are fine, I don't perform any, because see, in any case, we are giving an ICD for a primary prevention, but secondary prevention, I do. And what you said, like, array and these things have become absolutely obsolete, because now you've got a subcute ICD implant. So, subcute ICD will solve that problem. And now, fortunately, you have got 40 joules, 41 joules devices. So that again takes care of the things.
But I am surprised to hear from you that you are still going in 100% secondary prevention patients are going for DFT. So now there are operators which are, besides the primary, secondary also they are.
Yes, that is what I said. Like, majorities are not doing. I still perform.
Great. Dr. Das Biswas, sir.
So this is Dr. Pandey. I have a small question. So to you, what exactly, in which situation you choose a subcutaneous ICD apart from very young individual will require for the future recurrent replacement of the device? Apart from that, is there any other indication, infection and young individual apart from that?
See, again, like, many times it's a venous anomalies. See, if suppose you have got a venous anomalies, or suppose the patient has got an infection in the prior devices, one thing. And second thing, if you are doing for channelopathies where that you don't require pacing, so probably I would go for subcute ICDs in those patients. I agree with you.
So we have we are running out of time. We are 2 minutes, late already. So we can move on with the next presentation. Thank you, Dr. Gupta.
Thank you.
For the terrific presentation. So Dr. R.D. Yadav will join in next 10-15 minutes. So we have Anunay speaking now on EGMs and troubleshooting in AICD. And to chair this session, we have Dr. Raja Nag, and moderator is Dr. Smith Srivastava. I request Dr. M.K. Das to chair this particular session as well, sir.
Is Dr. Rajanag is the chairperson. Is he present here?
He was there, I think. Yeah.
Okay. I think let us start the session right now. Dr. Sanjeev Kathuria, you start your proceeding with EGMs and troubleshooting in pacemaker.
Anunay Gupta, sir. Anunay Gupta. Anunay is
Yeah, sir, I am there, sir. Are you able to hear me,
Okay,
sir?
Anunay Gupta. Okay.
Dilip, sir, I am audible now?
yes. Go ahead.
First of all, I would like to thank Dr. Dilip for inviting me for the talk. And at the first instance, I would like to say that to cover troubleshooting in ICD in 10 to 15 minutes is extremely difficult. But still, I will try to do justice and try to finish my talk in 10 to 15 minutes and discuss few important cases. So first and foremost, as we should all know that ICD detects tachycardias imperfectly and they also classify tachycardias imperfectly. So thereafter, there is the importance of stored ICD EGMs. It's extremely important that how we interpret them because they help us in detecting SVTs, VT, and VF episodes. And the annotation which is present there is of also of extreme importance. So a few points about primary and secondary prevention. We all know that in primary, we program our device in two zones. With 2 zones of VT and VF, while in secondary we are programming 3 zones, VT1, VT2. VT1 is less than 20 beats per minute compared to the clinical VT, and VT2 and followed by VF zone of more than 20 beats per minute. First of all, we have to understand what is the ICD-C. So it depends which type of ICD we are implanting, but for all the standard ICDs, there are 2 EGMs. One is the far field EGMs, which is between the ICD can and the RB coil. And this EGM is predominantly used for the morphology analysis. Will help in differentiating SVTs and VTs. And the second one is the near field, which is the sensing EGMs, and which is between the RP tip and the ring, and is used being sensed on the marker channel. As if there is a atrial lead, you will see AS also, and there is a VS. If there is a dual coil ICD, if there is a proximal coil, and with the ICD can, we can see at a larger area of the heart, and even it can give us a proper ECG with a proper P wave and QRS, and many a time a small T wave also. So whenever a patient comes to us with a shock, first of all, thing which we have to see is the clinical scenario, and then we have to ask for stored EGMs. Then if we found there's a tachyarrhythmias, so it can be either a SVT which has been inappropriately detected as SVT, or if there is a VT-VF which has been appropriate detection. So in that case, what we have to do is stop the arrhythmias. And while if the case in this, there is no tachyarrhythmias, so likely due to oversensing, we are having patient is receiving inappropriate shocks. So it can be either due to an intracardiac signal and extracardiac signals. So in those cases, we have to stop those extracardiac signal or intracardiac signals to happen, and even the device can require repair. So ventricular oversensing in ICD is an important issue, and it can be either cyclical or non-cyclical. Cyclically extracardiac predominant one is the myopotential and EMIs. Myopotentials are physiological and non-physiological are lead and connector issues and EMI. Intracardiac non-physiological can be lead failure. While the cyclical ones which we see are usually when there are more than one or more than one oversense events likely due to lead failure. While if it is a one oversensed event per cycle, it can be either due to P wave oversensing or T wave oversensing or R wave double counting. So this schematic diagram making us understand where all the problem can happen. In the lead, it can be either due to a lead fracture or a loose set screw, or if there is presence of air bubble in the header. EMI can interfere both the high frequency far field and near field. And even the intrinsic cardiac events can be missensed as and happened as a noise and lead to oversensing. 3 important oversensing issues which we encounter in our ICDs which lead to inappropriate shocks are diaphragmatic and pectoral myopotentials. And second one is the EMI, and third one is the lead fracture. So myopotential have a classical presentation. They usually present on the near bipolar. If it is from diaphragm, you will predominantly find on them on the RV, and if then pectorals, you can find them on the shock also. So, but it's very uncommon to see them on the shock, and their pattern is not a stable one. It's a variable pattern, and even the cycle length is also variable. What we will see if we do an interrogation, there will not be any change in the RV lead impedance. While in case of EMI, you can see there's a consistent pattern which we are seeing, and it's been seen on RV, atrium, and also on the shock AGM. And even in this case, the lead impedance will be normal and the cycle length will be significantly variable. The third one which we encounter is a lead problem. Rarely lead problem can lead to a no change in impedance, but in a usual scenario, it leads to a change in impedance. And it is also reproducible if we ask the patient to take a deep breath or push his hands against the wall and make the lead more stressful. So as you can see here, it's not follow a consistent pattern, and there's a different amplitudes and morphology, and the cycle length is also very variable. Lead failure can happen either due to a patience conductor fracture or even a loose set screw. So they both present in the same way, and it is extremely difficult to identify them on the ECM and will require fluoroscopy and further interrogation. A classical this conductor fracture and lead header connection problem presents as an intermittent problem, intermittent high frequency oversensing, and it can lead to amplified saturation. So which are the classical feature is there's amplitude and morphology and frequency is very variable. It makes it non-cyclical, and the intervals are very short. So for ranging from 110, 120, 140. So a classical oversensing issue of lead conductor fracture or a loose set screw. With this background knowledge, I will discuss few cases. First of all, this is a case of ICD, which was implanted around 4 years ago, and the patient received a shock while he was sitting in the chair. A chest X-ray done in the emergency department was normal. So based on this, what is the most likely diagnosis? There will be a zoom pole in front of you, and I will give, due to lack of time, I will give you around 10 to 15 seconds to answer. So let's see what are the answers. So I will request everyone to answer if they're able to see the poll on their screen.
Please show the ECG. Please fix your slide on the tracing.
Sure. So this is the tracing. You can see here there's the annotated marker channel. This is the far field left, and this is the ventricular near field. This is the shock which has been delivered of 40 joule, and later on again you can see some high frequency signals on the V field. So in this case, the likely diagnosis is lead fracture, as it is happening after 4 years ago. After the 4 years of implantation, it can be related to loose set screw also, but it usually happens for within the hospital stay. And you can see here these are the variable frequency signals of different morphology and amplitude. The cycle length is also very not seen on the far field, only seen on the V channel.
And one very important thing, Ananya, is that they're high amplitude,
Yes.
which is very characteristic of a lead fracture.
Yes.
They're high amplitude, low frequency. The frequency is not high, but they're very high amplitude.
Yes. Thank you, Dr. Katuria. This is the second case. Here we have to apply our EP knowledge also. So this is a dual chamber ICD. It was implanted 4 years ago, and patient came for routine follow-up, and the patient is doing fine, and he don't even remember that he received a shock or not. So this is the EGM. This is the continuation of the same EGMs. So what is the likely diagnosis? Options are atrial tachycardia, AVNRT, AVRT, and VT, and then I will focus on annotated EGMs. These are the 1, 2, and 3, which will help you in diagnosing. So if we can have the zoom poll, and then you can see this. So the options are atrial tachycardia, AVNRT, and VT. And we have to focus here on this ventricular EGM, and then this second one, and then what are this T. So this is a episode of ventricular tachycardia, which was non-sustained and with 1:1 VA conduction. But we see here that there is a ventricular sense event happening. It's likely a ventricular premature beat, which is happening very early, at around 47 millisecond after the sense, unlikely to be a normally conducted beat. And device basically compares it with the normal beat, which is, you can see here, this beat, which a normal V sense is different from this one. And then again, a ventricular premature beats happen and the tachycardia starts. And this is also different from this beat, and this is a sinus beat. And then there is a morphology match which says that this is tachycardia is not matching the sinus template and it's been diagnosed as a ventricular tachycardia. Patient received an appropriate ATP and the tachycardia terminated. So all ICD works on have a morphology algorithm. So it's every manufacturer has a different way to do it, and but there's some basic knowledge which is same in everyone. So what happens that in the sinus EGM is made for template and it used with the CAN and the IRV coil rather than the near field one. And then it is being stored in the device, and later on what we see when a patient develops tachycardia, there is a threshold of 70%. So if it is a match of more than 70%, it's diagnosed as a sinus beat or supraventricular tachycardia. Whenever the threshold is less than 70%, is diagnosed as a ventricular tachycardia. Morphology algorithm is not 100% safe, and there are many times and we encountered that the morphology discriminator fail. What happens that it's due to an accurate template, because as we can see that patient sinus beats and it can vary over the time of the from the date of implantation. So that can happen. Even alignment errors can happen because if they are not directly aligned with the time, and if there are EGM truncation, the EGMs are clipped, so they will vary between the sinus and the tachycardia beat. And one of the important condition when the morphology discriminator will fail when the patient develops rate-related aberrancy, because in that case, the template will be exclusively different from the sinus template, and patient will receive an inappropriate shock. And as I've discussed about the interfering potentials, they can also lead to a problem in the matching. A few examples here, as you can see here, this is a sinus beat, which is being matched as 88, 91%. But if we don't align the time marker correctly, suddenly it becomes a 0%, while even the beat is EVGMs are absolutely similar. Similarly, some interfering potential can lead to a poor matching of 34%. And if the EGM is truncated, so it will not match properly and will be misclassified as a ventricular event.
Ananda, you have to little quick.
Yeah, could you go to the last slide and just have one or two comments from the audience, please?
So this is a
you can show these cases. I think 2 cases. Yeah.
Yes. So this is a EGM of an event, the classical dot plot where you can see that there's a tram track appearance, and it's a classical of T wave oversensing. So here you can see that the T wave which are so tall are being sensed on the marker, and it says BF, EF, EF, and the patient repeats multiple inappropriate shocks. And but this not classical of T wave oversensing. It can even happen with R wave double counting, and if it is C/2 block, so then there will be a tram track appearance, and even the R field oversensing can lead to a tram track appearance. So the device, this can be treated by as I've told that the auto adjusting of sensitivity which happens in the device, you can delay the decay, and even the threshold start rate can be increased. And in this case, you can see here, this T wave is not oversensed in V tip to high voltage B. It's only being sensed on V tip to V ring. So if we change from a dedicated true bipolar to integrated bipolar, we can avoid the T wave oversensing. A patient receives a shock immediately implantation after an ICD in ICU. And you can see there are multiple high frequency signals on the RV tip and RV ring, and the duration is decreasing over the time, and the patient receives shock. If it happened immediately after the implantation, the most common cause is air in the header. So what happens if we don't put our don't remove the air properly while inserting the device lead tip? So air can get entrapped, and over the time it gets released and leads to interference between the signals and lead to high frequency signal and inappropriate shock. Nothing has to be done for this, and even within 48 hours, this air gets released, and you can just off that therapy in ICD, and within 48 hours, this air will get released and nothing can be done. Nothing to be done for that. Thank you.
Yes, one or two comments. Dilip?
Yeah, I think with the newer devices, this air in pocket and air in header is almost again an obsolete thing. So this snugly fit devices are there, and it takes care that extra air is not there. And with the design of the pacemakers, air in pocket is out of question these days. But it's important to know this problem can happen.
Yeah, I think Dr. Gupta has beautifully presented the various cases with much intricacies, and EGM knowledge is very, very important to come to the real diagnosis and take the appropriate action.
Excellent presentation, Anurag.
Yes. Should we conclude?
Yes, sir.
Thank you very much.
So we will move on with the next presentation. Dr. R.D. Yadav will be presenting on difficult CS anatomy and bailout in CRTs. And the chairperson is Dr. M.K. Das, moderator is Dr. Soumya Patra. So Dr. Das, sir, again, over to you.
R.D. Yadav is a very good friend of ours, and he is an excellent operator, electrophysiologist, and a very strong speaker. So over to Dr. R.D. Yadav, please.
Thank you for the invitation. Sorry for the delay, as I was delayed because I went to do one CRT-D implantation. So this technique, tips and tricks, what I will say is all mine, how I use it. So technical challenges encounter LV lead placement, case-based discussion basically. So how I do LV lead implantation, always puncture extrathoracically or axially vein for LV lead. Always use sleeve-table braided seat. I don't use P-level seat anymore. I think last 20 years I don't use it. Enter into CS by using prefixed curved decapolar or TPI lead of Sendute, as this helps entering in CS, as due to LA and LV largeness, CS make a hockey stick like angle. 90% of time, no need to do selective CS angiography, but use levo phase of the left cornea artery angio in LAO 45 degree in AP caudal view. AP caudal LAO view is my working view, and sometimes AP view, because in AP caudal the radiation to the doctor is less. If down looking origin of the lateral vein, then the posterolateral vein, then use 4 French or 5 French IMA angiocatheter to engage the vein and use whisper extra support wire or similar plastic coated wire. Sometimes might need Grand Slam or Ironman wire or Buddy wire. 90 or 130 degree subselect should be used in difficult angulation and tortuous vessel. If stenosed vein, then do balloon angioplasty with 3 mm NC balloon or cutting balloon. ICD lead I put first, then LV lead and RA lead later on to keep, if required. RA lead sheath can be used for the snaring and holding the wire orthodromically or antidromically. So RA lead I put later on, but RV lead I put initially. So let's how to go next. Sorry, next. Okay, so this case 1 is 45-year-old male, diagnosed case of DCM, normal coronary ejection fraction 25%, means standard indication for CRT-D implantation. And so this is the anatomy. We see the levo phase of the CES, which is clearly seen. There is a lot of tortuosity. So what I do is this is LAO view where it hooked 45 degree. It showed this is the vein, very tortuous vein. How to enter into this vein? This is LV, which is severely hypokinetic and severe LV systolic dysfunction. Went there, and then it could not. So this is the vein which we are going to target. Very tortuous vein. So we took the wire. Lead didn't went. So took the subselect. Even then subselect it was not going. So there was a tight stenosis, which the angioplasty was done, and thereafter we put the subselect, and then lead goes easily, and we deliver the CRT-D without any problem. So this is second case. This is interesting case. Again, indication for CRT-D. We put the because there is no connection of the SVC with the right innominate vein. So there is a connection. LSVC, patent LSVC is there. So the major problem is to go into the RV of the ICD lead. So we took the long sheath of the ICD lead, and with that lead we put the RV lead into the septum, and then the atrial lead is very easy. Atrial lead is not a problem. Then there is a LV lead. We put a vein here on the from the LSVC to the coronary sinus, and from there the branch is there. We put the, and this is the way we put the CRTD in persistent LSVC. So it's not a big issue, you can do it. And nowadays, if you fail, you can do even left bundle pacing or his bundle pacing, depending on your need. This is how the most difficult in this case is the placement of the RV lead, where I use a long seat. So if you see the patent LSVC is rare congenital anomaly, 0.5%, but if present is of considerable technical difficulty in putting the RV lead in RV. With proper technique, successful CRTD device implantation can be done. And LV lead placement is easy if the vein is there. So case third is again classical indication for CRTD, but the access vein is blocked. I'm a peripheral angioplaster also, so crossed it, dilated with the 6 millimeter balloon, put all the wire, and then selectively hooked there is a stenosis in the posterolateral vein. And then that vein I crossed with the balloon, and then your subselect seat, and then the lead was put, quadripolar lead was put, and then the CRTD implantation was done. And you can use the different subselect, 130 degree, 90 degree, or obtuse, depending on the anatomy of the origin of the tributaries. So success CRT implantation depend on coronary sinus anatomy and left subclavian vein access. Venoplasty of brachiocephalic vein and CS tributaries and subselect catheter help in difficult anatomy. This patient has remarkable recovery. Case 4 is DCM, again class ejection fraction 30%. Classical indication for CRT implantation. Here CRTP was selected to put CRT because there was no scar in the MRI. And this is the vein where we wanted to put, just slightly bear with us. This is the vein where I wanted to put the lead, but the problem was different. Problem was the lead we put very easy, but it came out with every systole, lead was thrown out of the tributaries. So what to do? And this was not a screwing lead of because this was from St. Jude, which has no screwing lead, it's a S-separate lead. So what I have to do is that we put another, we took out this lead. Again, we two excess of the vein, one with the 2 wire with the same seat and 2 seat. One is, you see, this is multi-purpose guide catheter, standard guide catheter, 1 seat, put the lead. And then what I did is subselect. I used the subselect and I put a stent here. This is a 4 millimeter Yukon stent to entrap the lead without any problem. And it doesn't do any insulation defect or lead fracture. The only problem is when you take out the lead, there is a problem. So ideally, screwing lead is the choice in this case, but was not available at that time, or it was with Medtronic and I was putting a device of Abbott, so did not agree to give. Entrapment of the LV lead by putting stent by the side is justified in this case. Stent entrapment, in my experience, does not damage the lead. Only problem occurs when you want to extract the lead, either due to infection or malfunction of the lead. And another technique is the orthodromic and antidromic snaring approach for the LV lead. The distal end of the wire is advanced from the target vein through the collateral to an adjacent vein and back into the CS and RA. And distal end of the wire is snared and stabilized like this. I'll show you this is the stent. Usually we use 10 millimeter snare. This is called, if you cross with the wire with this same wire with this branch and take out the wire from this branch and snare it out. And if you want to put this lead through this, then it is called antidromic. If you put the lead along this, then it is called orthodromic snaring and lead implantation. So antidromic snare, already I told you. Tips and tricks is snare is always, I use 10 millimeter snare, sometimes even 5 millimeter you can use. And snaring techniques are helpful in assessing the tortuous, small, acute angle veins. Snaring techniques increases the success rate, enable LV pacing site selection. We found snaring with 2 separate seats more convenient and more flexible than a single seat approach to CRT lead implantation. So thank you. I have done even a patient who snared out from the sinus, one of the sinusoids into the LV and then the aorta, and from the femoral artery, I snared the wire and then put the lead. So although that recording is not there, and thank you.
Thank you, Dr. Yadav. It was an excellent deliberation. Over to Shomma. Shomma, you just give your comments or question.
Dr. Jadhav sir has already explained the tips and tricks in the difficult CS situation, and nowadays we have left bundle branch pacing where we get difficulties. We have to put that left bundle branch pacing we can do. Because a couple of years ago it was not there. We were thinking of surgical, and in our center, Dr. Dilip, Dr. Arindam, and all, we have published our data that if there is difficult situation, we can use the middle cardiac vein and we can do the septal pacing so that the result is also similar, and we have published that data also. Because middle cardiac vein where the CS angulation is difficult, in that situation middle cardiac vein we used to get, and we do septal pacing so that the QRS is narrower. Maybe not as like putting in the posterolateral vein and all, but even though that patient, those patients we have put improved. So snaring technique also sir told it's nicely explained by sir.
Can I
also sir told it's nicely explained by sir.
Can I come in? Dilip, can I come in?
Yes.
As sir has said about the snaring technique, a very important thing which you can do is through the vein. As sir has asked for, Dr. Yadav was talking about LV and aorta. So the sinusoids you can easily enter into the RA. That is one of the possibilities. Snare from the femoral vein, that will be much easier a technique. Once you've made a loop from the vein to vein loop, your lead tracking capability increases immensely. So the same can be done from the aorta also. But
Yes.
a vein to vein loop also helps a lot.
I have not records. I have not been able to bring that CD.
Yes,
I
sir.
did around 10 years back. I was doing in Nagpur, and I had only very difficult anatomy. So I passed the whisper wire. It entered into the LV, the aorta. I snared out from the aorta and hold it by the snare, and then put
Got
the
it,
lead.
sir. Got it. Yeah. That's what I'm saying. We can go through a sinusoids into RA also and snare it from the femoral vein, and the same
Yeah.
thing will happen because you've got a sling. So you are able to maneuver on a sling.
I think if you want to know more about the tips and tricks, there are more than 300 video from Worley Set in YouTube. You can see all those odds and evils, all type they have done very successfully. And some of 4 cases which I showed were what I did in 4 cases that you can use in your cases.
What's your experience? What's your experience with dextrocardia and CRT?
I have not used any dextrocardia with CRT, so I think Dr. Sanjeev Kathuria has done some patient with I think in patients with corrected TGA, if I'm right, and he has shown in one of the group in WhatsApp group, but I have not done.
I have one small comment. So it looks very fancy. And first of all, from where did you get all these patients? We have not encountered these kind of problems, although we have done large numbers. Second is the snaring and going through sinusoids. Where you are, placing the LV lead is very important. If it is very distal, so it can sometimes create a pericardial effusion, and that can be dangerous sometimes. So we see the kind of positive pictures only because they're rare cases. But what happens to the patient out of 3-4 patients, how many had a problem? So it's always good to have some alternatives like left bundle, his bundle, CSP, rather than going all this kind of difficult juggleries. So what is your opinion in this present moment, Yadav sir? So we go for
Actually, you
CSP,
see,
snare, and
we go with a plan. We go with a plan that we have to put CRT-D or CRT-P. Okay. Now we have to do CRT-D or CRT-P. Last 15 years, I have no failures. So, and where I want to plan to do a left bundle pacing, I will do only left bundle pacing. Okay. So this is planned device implantation most of the time. It's not like we have failed and then use the alternative. That I have not done. I have planned that what I am going to do, and I have done like that. So I have no failures for the CRT-D at the present moment. Last 15 years.
Awesome.
And all the tips and tricks I can use, so not a problem.
Thank you, sir. Awesome.
Adi, one question from my side.
Yeah.
you showed that left SVC and the venous occlusion. Any reason of putting dual coil in those two things? Because single coil would have been a better option.
No, so I always put, yeah, you see, advantage of single coil is that extraction is easy. But otherwise, I don't think I always put two coil. I have put from the right, always I put two coil. And
No. I'm talking about your
threshold is lower.
No, I'm talking about your patient, because see, in the LSVC, both the coils are almost simultaneous, one thing. And the other one, you open up the vein and you are putting a coil in the SVC, so the vein is going to get.
This was done quite long, I think 10 years back. And that time it was single coil was not available.
Okay.
Thank you, sir. Thank you. I think thanks
Thank you very much.
Patro. Sir, can we conclude the session, sir?
Yes, please.
So we move on with the next presentation by Dr. Sanjeev Katuria, EGMs and troubleshooting in pacemakers. Chairperson is Dr. Rana Rathore Roy and moderator is Dr. Subhasis Roy. So over to Dr. Rana and Dr. Subhasis.
Yeah, thank you. So the next talk is about the EGM and troubleshooting in pacemaker. And our moderator is with us, Dr. S. Rai Chaudhary, and his speaker is Dr. Sanjeev Katuria. So over to you, Dr. Sanjeev Katuria.
Am I audible?
Yes.
Yeah, so I'm going to start with the presentation. First of all, I'd really like to thank Dilip for helping me participate in this event. So the most important thing about so the outline will be, we'll have to talk about failure to pace in the appropriate temper. We'll have to talk about problem with detecting the intracardiac signals, the undersensing and the oversensing, and the pseudo malfunctions, which include the pacemaker immediate tachycardia, the mode switch, and the crosstalk. First of all, once you have implanted a pacemaker, these are the things which should baseline data you should have. An actual EGM should be recorded. At the end of the procedure, the program parameters should be recorded. A complete 12 DCG should be always available with us, and an over-penetrated PA and a lateral chest X-ray radiograph should be obtained. Let's go to the first thing, failure to pace. That means they can be because of no output or failure to capture per se. No output can be because of a depletion, a lead fracture, an insulation failure, loose set screws, or a crosstalk itself also. Now, here is an example of what Dr. Anune was also showing. Now, there is a failure output because of the fact that you have a lead fracture. The important thing in this is that these are high amplitude, low frequency signals. So you're able to identify the high amplitude, low frequency signals. The loss of capture per se can be because of lead dislodgement, insulation failure, conductor failure, loose set screws, RV perforation, functional non-capture. An important point to remember in these is that your impedance is decreased if you have an insulation failure. There is one place where you can recognize from the parameters itself that this could be a likely cause. Now let's take this example. This is a 64-year female who came for a device check. Just see when you're doing a threshold testing for atria, at a high threshold, the atrial pacing has introduced, the atrial spike has introduced the ventricular pacing. So what has happened in this case is that you have an atrial lead which has fallen into the ventricle. So there is a loss of capture because the atrial lead is in the ventricle. So these disadjustment is a very, very important component of capture, failure to capture, and you must review the recorded electrograms from the implants, from the initial implant. Absence of degree of current of injury is a very important sign which leads to more of lead dislodgement. So that means you must look for a current of injury. Anchoring sleeve for adequate fixation at the time of reoperation and correction is the only thing which is to be done if you have such a lead dislodgement. But take this as an example. This is a failure of capture. What you can appreciate in this is the perforation. The lead has perforated. The RV lead is perforated, and so you have a failure of capture. There can be reasons, but there can be high thresholds in chronic leads, like hyperkalemia, acidemia, if the patient is taking flecainide, myocardial fibrosis, myocardial infarction. Now, this is an example of, classical example of failure to capture, atrial capture. What you can appreciate is that you have atrial spike, but there is no depolarization of the atria. In the same vein, in this case, you have a problem with the loss of ventricular capture because you have a spike, but you have no depolarization of the ventricles. The other problem which you're talking about as the cause of valvular fracture is oversensing. Now, this can be because, once again, because of EMIs, sensing of the TP waves, biopotential sensing, or air in the header. What you need to do about sensing it can be either non-physiological, physiological, which Dr. Anunya had already touched upon. It can be from the skeletal muscle potentials, from the strong electrical fields around you, or the native signals, which are the T and the V waves only. The cheat sheet is very, very important. You'll have to understand if it's a high amplitude, low frequency, make and break signal, your differentials are lead, fracture, and loose set screw. If it's a high frequency, low amplitude signals, you can have EMI, muscle potentials, and ASI. There are ways to differentiate them also. So this is a classical example where you can see that there are high frequency, low amplitude signals, which is basically a myopotential oversensing resulting in a pacemaker inhibition. So what can be done to correct it? You decrease the ventricular sensitivity. That means you increase the number, and the problem can go. Now this is an example of an EMI. Why this is an EMI? This is also high frequency signals, low amplitude signals, but this is present both in the atrial and the ventricular lead. So the EMIs will present in both the leads. This is extraneous noise because of EMI. This is an example of air in the header. So these are the two classical examples I wanted to share. A lead fracture has a high amplitude, low frequency, while a electromechanical interference will be low amplitude, high frequency, and present in both the channels. Now, this is an ECG of we're just concentrating on sensing those are the physiological causes. But if you think of this ECG of AI pacemaker, what you can appreciate is that on the atrial channel, the ventricular signal is being sensed. So this is an example of a far field sensing of the channel on the atrial channel. And what can be again done is to have to decrease the sensitivity of the atrial lead. This is another example of a ventricular sensing again over sensing, and if the pacemaker has got inhibited on its own, though there is no depolarization, even then the no spike has come and you're not able to see both the intrinsic event as well as the spike. This is again an example of the phenomenon of undersensing now. What you can see here is that was till now we were talking about oversensing. Now you can see that there's a P wave and still a spike has come. This is a classical example of an atrial undersensing. So what you need to do is that you need to increase your atrial sensitivity by decreasing the number. The same happens in this case. And a VVI pacemaker, you have a QRS present, but you still have a spike which is present. Again, intermittent ventricular undersensing, you increase the ventricular sensitivity by decreasing the number. So this is a very, very simple way of seeing it. When you see an evidence of over-pacing, that is, pacing is there despite the intrinsic activity. This is undersensing. And when you see evidence of under-pacing, that means pauses without pacing. That's example of that's the consideration of oversensing. Now, this is a very classical example of a crosstalk. What you can appreciate here is that the atrial impulse, because of atrial undersensing, an atrial impulse has inhibited the ventricular channel. What is important to note in this is, though this atrial impulse has inhibited the ventricular channel, probably the ventricular safety pacing is off in this patient. So you have a drop in the ventricular beat. So it was an intermittent atrial sensing leading to inappropriate atrial pacing in an intermittent crosstalk. The important thing to know is that is VPS slightly off. There are two zones of VP after the pacing, which are the noise window and the alert window. If this comes in the noise window itself, you'll have a ventricular safety pacing. But if it comes in the alert window, your ventricular safety pacing is unlikely to work. Now, this is a PMT. As we can see, there is a VPC. As we can see that there is a VPC which has come and which has initiated an ASVP. And you can appreciate an ASVP, but there are DDs to it. It can in fact be an atrial tachycardia. So how do you differentiate that? You do a PVARP extension intervention or a ASense pass intervention. If it doesn't break, it is likely to be an atrial tachycardia. Because if you do a pace in the PMT, a true PMT will break. This is the basic circuit of a PMT, which you all must understand. A PVC which starts. So a basic prerequisite for a PMT is that you should have intact retro PA conduction. So you have a PVC which initiates a retro PA conduction. The retro P wave reaches the atrial channel, the sense, and the circuit is established. There is another problem, which is the automatic mode switching. This will occur when the atrial rate becomes too high. So the AMS will turn off the atrial tracking instrument rate. So this will stop the rapid ventricular pacing to occur, and the pacemaker will switch on to a VVI mode. This will, of course, you'll have to remember that this will occur once the upper rate, the TARC rate, both are crossed. Only then this pacemaker will go into an automatic mode switch. Now, this is an example of a patient with a pseudo-ventricular because of the upper rate behavior. As you can see, that you have a group beating phenomenon. So the PR, if you measure the PR is gradually increasing, and one of the P waves it does is dropped. So what happens? This is the place where you have approached beyond your upper tracking rate, but you are below the TARC rate. So the pacemaker is giving you a signal that it is in between these two. So the piggybacking is occurring. What you can do to correct it? You can either increase the upper tracking rate itself, or you can decrease the TARC by decreasing the PVAR. So all the P waves are sensed, and none of them goes to the PVAR. Or you can even do an adaptive AV so that the AV interval is decreased. Basically, you'll have to make sure that the TARC changes. You will have to decrease the AV delay or decrease the PVAR. So your TARC becomes less, and the P wave is sensed. Each and every P wave is sensed. If you don't do it, the rate goes further up. What you'll have is a 2-to-1 operation block. And this now you have gone beyond the TARC rate. So you'll have every other second P wave being dropped. So you'll have a sudden drop in the ventricular rate and the patient can become symptomatic. So these are some examples. If you want the poll to be there, it's a very simple example. You'll have to decide what it is actually showing. You have regular ventricular pacing, but suddenly you have a drop. So what do you think it is? You can show a poll, or otherwise I'll show the answer if the time is less. So basically, this is an example. This is an example of an oversensing, because you see, as I told you, there is no intrinsic beat which has come, and there is no pace rhythm which has also come. So the pacemaker is not inhibited because of oversensing by some extrinsic phenomenon. Now this is opposite. Here you see there is a QRS which has come, and despite the QRS which has come, the spike has come. So this is basically an example of failure to sense. Now this is an example of patient who has a spike, but there is no QRS which is coming after the spike. So there is an example of a failure to. Simply an example of failure to capture. There is a spike, but no QRS to follow. Now, this is an important example you must know. We see the pacemaker has a VVIR mode, very characteristically a VVIR mode. But if you see the bar chart, what it is showing, that it's remaining in between a rate of 60 to 75 all through. So what it shows is the R function of the pacemaker is not functioning. So you have a poor rate response in a patient who has a VVIR pacemaker. So how do you go about the differential diagnosis of pacing system malformation? First of all, you must see whether the pacing stimuli is there or not. So you'll have to know whether it's a failure of output or a failure of capture. If the pacing stimuli is there, is it capturing or not capturing? And then you try to compare the native depolarization. Is it properly timed? Is it sensing well or not? So you'll be able to correctly know whether the native beats, what is the relation to the pace complex. If they're related well, that means every beat where the native complex comes, it has inhibited itself. So the sensing function is also good. And all the native beats being sensed correctly. And then we'll have to know whether it is inhibiting or triggering the next complex. So the 4 solutions which one can have for pacemaker problem are: you reprogram the device if it's required, depending on decrease the sensitivity, increase the sensitivity, decrease or increase your amplitudes. Replace the system if there is a problem with the component. The important thing, which is actually standard of pacemaker, is the leads. If the lead has got fracture or insulation break, or it has dislodged, you'll have to reposition required, or you have to change them. And if all the functions are coming normal, then you retreat, do nothing, because nothing is wrong with the pacemaker. Thank you.
Thank you, Dr. Sanjeev, for such a nice deliberation about this troubleshooting in the pacemaker. We have Dr. Sanjeev, Dr. Suvasis. Any comments, Dr. Suvasis?
I think that was an excellent presentation. I just wanted to know about any of the common drugs that we use which can affect our pacing thresholds. If Dr. Sanjeev can enlighten us.
This is I just said it's not one of the common drugs which you're using which can change. If you're using a drug like lecanemab, a 1C drug, that has an impact on the thresholds which can increase. Our commonly used drugs don't affect the pacemaker thresholds much.
Right.
Yeah, I think it was a brilliant presentation, Dr. Sanjeev. And we often see, in our, cases, just after implantation, you see the pacemaker, the upper rate behavior and the heart rate has gone down, and you see what has happened, and then you integrate thoroughly and you come to know. So these are very, very important tips and tricks you have shown. And thanks again. And please stay there with us. You will be needing our inputs in coming sessions.
I think the most important thing in the pacemaker will come out to be the AV delay and the PVAR. You see, your PMTs, your pseudo, your Wenke backing, as well as your 2:1 phenomenon. All are depending on the PVARs and the AV delays more. So these two are the most important components. Maneuvering these two components can solve a lot of problems if you have.
So auto PVAR, they have kind of.
Yes, that is a very important thing.
Much of the problems. So PVC response and then PMT is less seen nowadays. So we can move on with the next presentation. Sanjeev Bose, you please stay there.
Yeah, I'm there.
And we will be having talk by Dr. Amit Malviya. He will be speaking on EGMs and troubleshootings in CRT. Dr. Sumit Shankar is the moderator and chairperson is Dr. Lipika Adhikari. So over to Dr. Sumit and Dr. Lipika.
Good afternoon, everyone. We'll be having a talk about troubleshooting in CRT. It will be done by Dr. Amit Malviya. He's an assistant professor of cardiology in Ingrims Hospital, Shillong. And the chairperson is Ms. Malviya. So over to you, sir, Dr. Amit Malviya.
Thank you very much. Am I audible?
Yes, sir, you are audible.
Thank you very much. First of all, I'll thank Dr. Dilip for giving me opportunity to speak on this topic. And previously we had two talks about troubleshooting in ICD and troubleshooting in pacemaker. So most of the basics have been covered. So meanwhile,
full screen your PPT.
It's full screen. Can you see full screen?
No, sir.
Slideshow mode. Okay.
Slideshow. Now it's full screen.
No, sir. You stop sharing and then share again.
Okay.
Yes.
Is it okay now?
Not yet, sir.
No, I have stopped and again I have done. I have stopped sharing now. Again, I'll share again.
That way, Amit, if it is not happening.
Is it okay now?
It's okay. Continue.
Okay. So I'll be just tackling few very important points which are related to CRT troubleshooting. So issues in CRT can be, pre-implantation, like site selection, which site, which vein to choose. During implant, there are some issues which need troubleshooting, and there are issues post-implant in follow-up. So I will touch upon the issues which are usually during the implant time and post-implant follow-up time. Most important of all, implant time is, getting correct RVN activation, LV activation time measurements. Because as we know, for a proper CRT benefit to the patient, we need to stimulate both right ventricle and the left ventricle. And ideally, the position between the leads should be as far away as possible, because if the leads are too close, the electromechanical effects are such that it results in a clinical impact almost similar to a worsening heart failure. So a proper positioning and separation of leads is very important. So that is a part of pre-op evaluation and intra-op during. But one thing, as I said, if biventricular pacing at the site of late activation is done, the hemodynamic response is much, much better. Almost a 22% difference between, if the leads are placed at the site of late electrical activation as compared to lead of earliest activation. So normally we would select a vein and the location pre-op using imaging. But once you have done it, suppose because of some reason you have placed a lead, and there are some softwares and multi-vector testing algorithms are available, which you can use intra-op to select the proper lead polarity and links, especially these days when we have quadripolar leads and you have so many options to choose the ring and can site and the vectors of CRT delivery. So in this VEC select multi-vector testing, there is an automatic LV-RV conduction times is calculated, and these times identify the latest site of electrical activation on the quadripolar lead, which gives you additional information for optimizing the pacing locations and thus improving the clinical outcomes. So the results of this test is something like this. You will get a measured time of activation, and accordingly it can be selected so that the LV-RV conduction times are most optimal.
Sir, slides are not moving. Yeah,
slides are not moving, sir.
But in my, it's moving. It's not moving. Again, I'll
So you share the whole screen instead of sharing the PPT.
I will share the screen. Is it okay now?
Yes.
Absolutely correct, sir.
Perfectly.
All right. So I think there was nothing much in the previous slides. But so now I'll come to the second part, which is the most important part. What are the troubleshooting of CRT during follow-up? Normally, as we know, 30% of the patients of CRT, which has been the data from the last decade, that they don't respond to CRT as well as they should have responded to. So once you have such a patient, what should be done? First is to evaluate for exacerbating factors or factors which could lead to loss of CRT response, even if the CRT delivery is good. And most important them of are atrial fibrillation, renal failure, volume overload, or persistent ischemia. Once you take care of these factors and even then the patient is not responding to CRT, a proper device interrogation is needed to see if there is a loss of capture either on the left ventricle side or on the right ventricle side. If there is a loss of capture and CRT is not being delivered, then it has to be reprogrammed or revision of a device has to be done. In case there is no loss of capture, still there is the problem persists, we have to optimize the AV delay and the VV delay. If after optimizing this AV delay and VV delay, the patient improves, well and good. If patient does not improve, then we have to do further echocardiographic and dysynchronous studies to look for the possibility of re-evaluating the lead position, either transvenous or epicardial, or in case we don't find any dyssynchrony, still there is evidence of mitral regurgitation, then patient may go for mitral valve surgery or other options like LVAD and heart transplant, etc. So this is the basic model of CRT non-responders on follow-up. There are 4 important issues which should be discussed while discussing CRT troubleshooting, and which can be the common reasons for patient not responding to CRT therapy, despite the absence of above factors which I discussed as atrial fibrillation, renal failure, etc., etc. So the 4 main reasons are how much time the patient is getting CRT, that is the percentage of biventricular pacing, whether there is a proper capture or not, whether there is a phrenic nerve stimulation, or whether the CRT is optimized in terms of VV and AV delay. So these 4 things I'll just cover quickly. So percentage of biventricular pacing is a very, very crux of giving a CRT therapy. Whenever we put a CRT, we want the patient to be paced maximally. Ideal is 100%, but what is the actual benchmark which you can accept in your clinical practice? As we know from the previous trials that these 30% patients which I talked about who don't respond, the major cause is that there is a loss of consistent pacing, means they are not getting CRT all the time and thus leading to a poor response. So how much pacing they should get so that they get the best response? Ideal, as I said, is 100%, but an acceptable threshold of 93% of CRT pacing out of all pacing is required for patients to get a benefit of CRT. So once you see that the patient percentage pacing of CRT is less than 93%, you should always look for the causes. What are the causes? Most common causes are either abnormal rates or abnormal device function. If there is atrial fibrillation, sinus tachycardia, ventricular tachycardia, ectopics, abnormal device function could be oversensing or undersensing, inappropriate settings in the device, loss of capture, T-wave undersensing, far field sensing, or P-wave undersensing. So if there is an abnormal rate, you treat for atrial fibrillation, either pharmacologically or through a device therapy by either cardioversion or using special algorithms which are present in all companies these days, or we can go for RF ablation or AV junction ablation for a better response to CRT so that patients can have full CRT. If it is an abnormal device function, suppose it's a T-wave oversensing or far field oversensing, then it has to address by the pacemaker programming. Atrial oversensing, usually what it causes mode switching. So once there is a mode switching, there is no tracking. And when there is no tracking, it inhibits the CRT therapy. Similarly, ventricular oversensing, it causes inhibition of ventricular pacing and loss of CRT therapy. So these things have to be taken care of to give patient the threshold of at least 93% of CRT pacing, biventricular pacing all the time. This is a case example. As you can see that there is a T-wave oversensing which leads to inhibition of biventricular pacing in every alternate beat. And that is why the response to CRT is not there. Once it is corrected, T-wave oversensing problem by reprogramming, the patient is getting full 100% biventricular pacing. So these are very simple things which can be done in follow-up and ensure that patient gets a complete biventricular pacing and benefits of CRT. Similarly, this is an example of far field oversensing, and patient is not getting proper CRT. Once you have corrected the atrial sensitivity and ventricular atrial blanking periods, the patient starts getting full CRT again. Second point is capture assessment. Once a patient comes with a CRT follow-up, capture assessment is a must. And important thing is you assess for the capture of RV, LV, atrial captures, and what is the biventricular capture thresholds, and if at all there is a phrenic stimulation or diaphragmatic pacing. If it is there, we have to, because we cannot manipulate the lead at the follow-up time, we have to find a suitable alternative in between where the device voltage between diaphragmatic stimulation and pacing threshold, and keep it at that level. Sometimes we may have to do, some maneuvers to elicit it. If patient complains of intermittent jerks in abdomen or so, you have to suspect and correct it. So as I said, these days the LV leads have different configuration programming. You can program by trial and error method, LV to ring, LV ring to ring, tip to ring, can to ring, and so many. I mean, in quadripolars, there are more than 10 programming configurations available, and it usually leads to elimination of phrenic nerve stimulation. Third point is CRT optimization. Now, CRT optimization, one of the important causes, apart from loss of capture or loss of biventricular pacing, is non-optimal AV and VV delays. And once AV and VV delays are optimized, the response to CRT is tremendous. And now, ideally, this CRT optimization should be done using echocardiography by Doppler using the VTI method, but it is time consuming and clinicians don't have much time. Ideally, it should be done using echo and Doppler. And once you are using A-pace, V-pace or A-sense V-pace configuration, ensure that where you get the highest VTI and optimal VV delay, you will get the highest VTI, and separation of E and A wave on the color Doppler. That is the time and the intervals which are optimized for that particular patient. Otherwise, some companies have, like Medtronic, St. Jude, they have got a separate algorithm. In St. Jude, there's a quick opt. In Medtronic, they have adaptive CRT, which optimizes the physiologic pacing by reducing RV pacing up to the tune of 44%. And they have shown that these algorithms really help in optimization of CRT. The last and the most recent one is device diagnostic. Means you can help and predict heart failure events in the patients who have been implanted CRT based on impedance and heart rate variations and activity assessment. As we know, once the patients start developing LA hypertension, pulmonary edema, impedance changes are one of the earliest changes to occur before the clinical symptoms. And these devices, they have a lot of information on this impedance values, as well as the heart rate and activity levels. So some algorithms, they measure the intrathoracic impedance, and as it goes down, you can see the lungs might be becoming the wet and the impedance is going low. And you can get a trigger from the device itself, and that is the time you may either change your medical therapy, increase diuretics, or admit the patient for further evaluation, so on and so forth. Important similar algorithm is available from Medtronic, which is Optival, and it has been shown in clinical studies that it has almost 80% sensitivity and positive predictive value of 12% to predict recurrent heart failure hospitalization even before the patient develops clinical symptoms. And another important thing which can be done through these devices is exercise and activity trend. The daily exercise trend is the patient's actual heart rate, and therefore represent the actual time spent at various heart rate responses to activity, whereas total daily activity, it blends the mechanical, I mean the sensors information as well as the physiological heart rate information, and indicates the amount of time the patient is active in each day. And by assessing these data, you can easily make out many things. Like for example, in this patient, you can see both are going down, the daily exercise training as well as total daily activity, which means the patient has become sedentary. So once you pick up, patient may or may not tell you, you can counsel the patient, and cardiac rehabilitation therapies, everything can be initiated before the patient lands up in a heart failure event. Similarly, here you can see that the patient has improved over a period of time, and both parameters are improving. So that makes you happy that CRT is working and your pharmacological therapy is optimized. For example, in this patient, as you can see, there is a mismatch. While the daily exercise heart rate responses are low, the total daily activity is high, which means that it indicates that there's a poor rate response from the pacemaker side, CRT side, and you need to readjust the parameters for improving the rate response. So all in all, basically CRT follow-up is a dedicated procedure, and various algorithms these days are available for optimizing the CRT delivery. And we should always take the opportunity whenever the patient comes to interrogate the device in full and retrieve these informations for better delivery of the patient. And there is one more, last thing, which heart rate variability can be assessed. As you know, increased HRV is associated with reduced mortality. And this HRV can be assessed in these newer devices in a footprint graph. And you can see that these graphs gives you a very accurate information of the HRV of patients. So you have a footprint plot after a month or so of implantation, and you can see the HRV is improving, means the impact of CRT is good. And I think I'll just wind up with this. Thank you very much.
Thank you, sir. It was an excellent talk. We got a lot of information. We also got to know that with the device interrogation, we can assess the patient's effort as well. How much is his activity? How much is his heart rate variability? That will also help us in motivating the patient and do a proper follow-up. And device interrogation is very important.
Yes,
thank you. Over to you, Dilip, sir.
I think one, a comment from my side. With this LV adaptive pacing, AV sync pacing, sync AV, we have got kind of secured a lot of AV synchrony, and you don't have to bother much. But still, the problem stays with atrial fibrillation. So if there is atrial fibrillation, we still have a challenge with a kind of more than 95% pacing. So can you enlighten us, briefly on?
Sir, as I said in my presentation, once you have AF, definitely the biventricular pacing goes down unless the AF part is addressed. So AF part is to be addressed, especially those with permanent AF. It has to be addressed either pharmacologically or by electrophysiology or cardioversion. That we have to plan what is optimal for the patient, and we have to address it. We cannot leave it like that. If you leave it like that, certainly the biventricular pacing percentage will go down. It reduces almost to the tune of 34% if patient has permanent AF. So that problem has to be assessed. And most simple and the common one would be to ablate the AV junction and then do the CRT.
Right. There are some algorithms like conducted AF and effective CRT. They claim that they can increase the responder rate. But definitely,
sir, with those algorithms, the tune to which they increase the CRT percentage is actually not much. Maybe from 65%, it may go up to 72%. But aim is 93% and above. That can be done only with the procedures like ablation of AF, conversion to sinus rhythm, either or you ablate the AV junction, let the atria go away at all. No, I mean that type of thing.
I think, Dilip, the answer is very, very correct. That AV nodal ablation is the best therapy you'll have to have to disconnect the atria and the ventricle. But yes, AF conducted response, which is there with Medtronic. They claim that it does increase, but I'm not sure whether it increases or not. One important thing, Dr. Malia, one important thing, phrenic nerve stimulation on implantation side, if you get that, there are ways to tackle that. What do you recommend? If you have a phrenic nerve stimulation, even then, and you have a lead which is certainly good, it's in a good position, but you want to avoid a phrenic nerve stimulation, then there are ways.
The way I do is, sir, I reduce the pulse width, keep it to the minimum. That usually takes care of that.
No, Amit, I think it's the other way around. If you have a phrenic nerve stimulation, you tend to keep the amplitude low and go for a higher pulse width.
No,
That is one of the.
that is one way, sir, you can do it. I mean, increase the pulse width and lower the voltage, but usually
we are at 10 minutes, overshoot the time. So Amit, it was an excellent presentation. So you have given a very, very nice overview of how CRT can be optimized. So next would be, we have exchanged our timing. Dr. Shetty has a commitment in the evening, so we will be speaking next, and his topic is the future of connected health. And the moderator of this session is Dr. Dipankar Ghosh Dastidar and chairperson Dr. Anil Mishra.
Good evening, everybody. Connected health is a very important topic of medicine nowadays, and its future. We are going to hear what Dr. Shetty has got to say about it. So over to Dr. Srikanth Shetty.
Good evening, everybody, and I thank the organizers, particularly Dr. Dilip, for giving me this opportunity. And thank you, Dr. Dipankar. So I'm going to talk about future of connected health, and the last couple of years have been very, very revealing in how connected health can improve the lives of our patient and improve healthcare delivery to patients, particularly when a physical connect between the healthcare providers and patients is cut off, like how the COVID pandemic showed us. And some of these learnings during the pandemic are probably going to be permanent, because we realize that the same can also be used very well in the other situations also. We have seen over the last, I hope you're able to see my slides in the slide mode. In the last several years, we have seen so many advancements in diagnostics and monitoring that have happened, which have primarily involving miniaturization and near patient testing, like blood testing. More and more of our patients are using home monitoring of PTINR. Patients on chemo, they can monitor their WBC count. There is AliveCore ECG, multi-channel ECG that can be recorded by our patients at home. Of course, there are downsides to all this, because sometimes they can also generate false alerts. But at the same time, any new technology that comes with these disadvantages, and as we go forward, we will learn how to use it with good sensitivity and specificity by picking up the real red flags and avoiding false alerts which drive the patient to the emergency. Now we know that the newer series of Apple Watches, they can document arrhythmias, particularly atrial fibrillation, but concerns also have been raised about some noise and noise-generated false alerts. So in other disease areas like COPD, in preventing falls, and more and more so in cardiology, home monitoring for patients on implantable cardiac devices, etc. Now, blood pressure apparatus also come with Bluetooth connectivity to patients' mobile and through an app to their doctor, who can monitor the progress of the patient blood pressure trends. And there is a new BP apparatus by Omron, which also is incorporated with a ECG recording unit like AliveCore, which can also provide opportunity for documentation of otherwise subclinical atrial fibrillation episodes, which we know hypertensive patients are also at risk of subclinical AF, which increases risk of strokes and dementia. So opportunistic identification of such subclinical AF episodes can help us to modify therapy, which can prevent neurological deterioration in patients with chronic hypertension. So these are some of those areas where improving technology has empowered our patients and made it easy for us to monitor them outside of the hospital and deliver more effective care. And consumables and digital platforms which are being added every day. Hopefully, all this will get refined in a manner that they become cost effective, and also with better specificity, which is the key thing over here. Because while these devices can be useful, if they have poor specificity, they can add to the patient's problems as well. And also with the burgeoning number of patients who have had implantable cardiac devices, and with the number of cardiac clinics which may be capable of in physical evaluating these patients not really increasing, what will happen is that the clinic's capacity to evaluate those patients will approach capacity constraint. That may not be so much of a problem in India, but maybe in the West, because we are at a different part of the slope of the growth. I mean, we still are growing, whereas in the Western countries, they may have hit a plateau with respect to their the number of doctors, as well as in terms of the clinic capacity. So but we are in a different situation. Interest in remote monitoring, nevertheless, has grown significantly in the last 2 years because of the physical disconnect between patients and the care providers. So in fact, you can actually divide this into on the basis of considering this as a landmark year as after COVID 2021. So allowing patients to stay at home and have assured monitoring even when they have a high risk of sudden cardiac death or heart failure deterioration, because the devices are now capable of being remotely monitored. So consumers also are showing more and more interest in taking up telehealth, as well as providers feel there is a great opportunity to provide telehealth, and our own confidence and comfort with using digital platforms to connect with our patients has improved. So therefore, the industry also sees a great opportunity for growth in this area, and you see a lot of digital health companies wanting to invest in this segment. So a typical example of how this remote monitoring data flow has changed from the earlier point of care programmer in the clinic to remote transmitters from the patient's home, which obviate the need for the patient to come to the hospital to be checked. So it's all the same, all the parameters that are typically monitored in physical assessments, such as program parameters, system integrity, battery condition, ICD status, ineffective shock deliveries, IgM transmission, and all the components of heart failure management that were spoken about in the previous talk. Like, for example, the thoracic impedance in patients who have heart failure, and also integrating data from external sensors like weight scale, blood pressure monitor, etc. These can all be done through remote monitoring, just as well as it can be done through in-person interrogation of the devices. Parameters like heart rate, AF detection, ventricular tachycardia, IgM transmission of recorded events, and all of those. And so these alerts could manage important device-triggered alerts between follow-ups, and monitor patients' disease status and device performance daily, receive immediate notifications for urgent alerts, and these are also customizable by the patient as well as by the doctor. And this could lead to early identification of atrial fibrillation, frequent ventricular tachycardia, or loss of CRT therapy. And this is not just about convenience. As you can see over here, this leads to improvement in hard outcomes, like there is a 34% reduction in all-cause mortality over 3 years, 50% lower risk of all-cause mortality in ICD patients, and even in pacemaker patients, it leads to a 27% reduction in all-cause mortality over 3 years. And in those patients who are non-adherent with remote monitoring, the mortality, the probability of survival continues to be low, and the mortality is high. So those who have high adherence, they have 53% greater survival as compared to those who do not use remote monitoring. So these benefits are real. They cause reduction in mortality as well as a significant reduction in the device or cardiac related emergency department or urgent in-office visits. So a similar assessment of how a patient can be kept on a tailored anticoagulation therapy by taking the advantage of continuous monitoring through an implantable cardiac device so was looked at in this react.com pilot study. And using the density of atrial fibrillation events, you can decide to keep the patient on or off atrial fibrillation. This is probably a novel concept, and because AF can potentially become chronic and may expose the patient to the intercurrent stroke risk. I'm not sure whether this is going to work really well, keeping the patient on off oral anticoagulation. But anyway, as a concept, this is interesting. And the HRS also recognizes the potential for significant patient improvement by remote monitoring, and therefore recommends it as a class 1A recommendation. So this helps closer follow-up, increased survival, decreased healthcare utilization, and therefore cost, and increased clinic efficiency, and also improves patient satisfaction. There is improvement in their quality of life, as well as there is an improved sense of security because they feel connected with their care providers. Different companies have different systems which more or less work on similar algorithms and similar hardware. And this is how the typical data sheets look like: FastPath, summary page, diagnostic summary, episode summary, and EGM, and so on and so forth. So, but still there are a lot of barriers to remote monitoring, which could be technological, and also the comfort of the patient or cardiologist, or sometimes language barriers, and so on and so forth. And depending upon the system ease of use, so there may be a variability in the degree of compliance of at the patient end. So these systems mostly make use of Bluetooth wireless technology, which could be different for different companies. They all try to improve the effectiveness of the remote monitoring through better antennas, use of high power, increased sensitivity, and faster connection establishment to the app. And also the app has been continuously improved so that the patient finds it easier to use it. So on a survey of patients who were using the smartphone Bluetooth remote monitoring finds there is a high degree of satisfaction, and they feel that it is easy to interrupt and did not disrupt their daily activities, and they find their mobile app messages useful, and more confidence in the therapy with the ability of check status of the device, and they had no issues with the app communication. So there are these are examples of how the remote monitoring helps in ensuring that the patient has optimal biventricular pacing in patients with the CRT. Like this patient has a 99% biventricular pacing. This is an example of a patient who has.
Srikanth, you can make it a little quick.
Yes. We are finishing. Yeah. So almost 0% ventricular, biventricular pacing in a patient with dislodged atrial lead, and then achieved good biventricular pacing after atrial lead repositioning. A patient in whom the device detected VF episodes. Similarly, another patient where the remote monitoring helps detected ATAF detection. So identifying AF burden also becomes simpler, and reduction in hard endpoints, and significant reduction in hospitalizations of AF or stroke. So similar study which was done in the Southeast Asian region, which showed highly effective remote monitoring compliance. So technology is all around us. Advances in medicine are tightly linked to technological advancements. The future of medicine is in bringing monitoring and therapy to patients outside hospitals. This increases efficiency of care and empowers patients, and this allows patients more control over their lives and experience freedom from frequent hospital visits. Thank you.
So that was a very nice talk on the subject by Dr. Srikanth. Thank you so much. And the take-home messages, I think, would be that this technology is not distance dependent. It is available worldwide. Only it is server dependent and bandwidth dependent. So remote monitoring can be achievable if one has a good server and bandwidth connection. The other important thing is, as Dr. Srikanth highlighted, is the sense of connectivity. Patient always feels that someone is monitoring him, and all the studies, not only the Southeastern studies are there from Australia and US, which have shown improved survival with remote monitoring. So this technology is here to stay. And thank you all. And thanks, Dr. Srikanth, for giving such a nice talk. So what do you, Dilip?
Thank you, Dr. Srikanth, Dr. Gosasiddar. I think with so much of evidence that remote monitoring works, it increases the outcome and reduces the mortality. The uptake rate of remote monitoring was really pathetic, not in India, even in Europe. So maybe this BlueSync technology and this connected health can, this BlueSync based, Bluetooth based devices will change this kind of scenario. So there will be a lot of patients who will be having a default, connected health and home monitoring. So thanks again, Dr. Srikanth, and move on with the next presentation. And it will be on CRT adventures and complications. And the speaker is Dr. Ravin Chakravarti, and the chairperson of the sessions are Dr. D.P. Sinha, Dr. Sanjeev Kathuria, and moderator is Dr. Sudev Mukherjee. Over to chairpersons and moderator. Sinha sir, you have to unmute yourself, sir.
Yeah, this is an important session, and I think it will be very interesting. One of the learned expert, Professor Dr. Ravin Chakravarti, will be talking on CRT, which has been a pioneer in Calcutta at least, and I think he is also considered a pioneer in India as well. Now, over to you, Dr. Professor Ravin Chakravarti, with your talk, please.
Thank you very much. So we will start the talk straight away. Share my screen. Thank you very much. So we are going to start the talk straight away. And as it's a great session on device and in cardiology, which is clearly advancing. But as we implant more and more devices for heart failure, for certain cardiac death, we also do face a lot of challenges during such implantation procedures. And we do encounter and come across with some complications of device implantation procedure. So this evening, I'm going to focus on CRT implantations, its adventures and complications. We have data to suggest, and right from Arthur Tang and other group has already convinced us that the implant success in INSYNC study and also in Miracle study has been shown to be over 90%. And because of the advancement of the delivery tool, advancement of the hardware, and the electrophysiologist and the device specialist have overcome many hurdles, many complications, or many challenges for this implantation procedure. So the success rate is, in general, is more than 90%. And if you take it further, it has been shown that with time, the implantation. Hello?
Please make it full screen, only then it will run.
It is already full screen actually. I'm in full screen.
I think you're not full screen.
No, sir. You stop sharing, then again start sharing again. It's not showing full screen.
Sunil has to do that. Sunil, can you? What should I do?
Sir, you just stop your sharing. Just stop the sharing.
1 minute.
I think your bandwidth is not good enough, so you can stop sharing, then share again.
So I'll stop sharing.
Yes, sir.
Sorry for this, 1 minute. So I'll stop sharing now, is it?
Yes, sir. It has not been stopped, sir. Still, it's showing sharing.
Okay, again share.
Yes, sir. Now we will start sharing. Now you do the slideshow, sir.
Okay. Do you see now?
No, sir. Still not.
But I'm fully, I can hear your voice.
But we cannot see your slideshow. We are seeing only the slide shorter view.
But can you see this 1 minute? Can you see this?
We are seeing only.
We can see your 32 number slide.
Can you see this?
Yes, sir. This one we can see.
I can go this way then.
Okay, sir. Okay. Okay, then.
Yes, sir. Please carry on, sir. This only, sir.
I can go like this?
Yes, sir. Yes, sir.
Yes, sir, you go. We'll manage.
Right. As I said, there are challenges in venous access, in coronary sinus cannulation, coronary sinus dissection, or even perforation or phrenic nerve stimulation, which was partly discussed in this meeting. Let us talk about venous access. So venous access may seem to be a minor issue, but with expertise and with more experience, we are ready to sort of overcome this situation. But there are certain areas, for example, there could be very narrow space between clavicle and furstry where there may be difficulty. Subclavian stenosis is a known entity, especially patients on dialysis, those kind of things, they have problem. And another very important problem is left-sided superior vena cava. This is an example where subclavian thrombosis could be a cause of venous access, and it is difficult to advance, but there are ways to do it. You can actually progressively dilate you can go through the vein, the thrombus, and then gradually dilate it, and then and make some passage by which you can actually advance the lead. Persistence of left superior vena cava is a problem, is a challenge for this device implantation. Although at times, for example, like in this case, left-sided persistent superior vena cava, you can actually take the coronary sinus, where the lead, and you can sort of place it in the left lateral vein. And then the other one is difficult. But what is important, sometimes in this situation, you do the right-sided venogram and see that where the right side superior vena cava exists. That many people think that if left side is there, right side is not there. That is untrue. In about 50% of patients, you can actually have right side superior vena cava also. So it is important for us to recognize that. CS cannulation is again a very important issue, and that is sometimes difficult, especially in heart failure patient, when there is right atrial dilatation with distortion of coronary sinus. We need to understand if the heart is big, then we cannot take the devices through this, because it has to travel a very complex pathway. There could be angulation. There also could be an anatomical barrier, for example, the Thevesian valve or Vision's valves, and there could be wrong tool. Tool may not be adequate. For example, in this case, coronary sinus is so oblique, so complicated, may not be easy to advance the wire into the coronary sinus because of the angulation, and that could be a very potential cause of failure or a big challenge for the cannulation. Like this in this case, look at that. The small right atrium, the large right atrium. Clearly, the angle changes. Can you see that? If the angle changes, then advancing the wire, it always falls in a different area. It doesn't really follow the ostium of the coronary sinus. Sometimes the coronary sinus itself can have stenosis. We have cases where we actually came across, I'm sure many of my colleagues did come across such problem. You actually do series of dilatation with the balloon and then advance the hardware like lead, left-sided coronary sinus lead, and advance in position. And then cannulation of the high coronary sinus os, for example, like this with multi-purpose catheter. This is one such example where it can be done like this. Very large LA with high takeoff of coronary sinus may be a real challenge in some situations. Sometimes people actually feel are comfortable of cannulation with left armplat, and I was not comfortable initially, but now with experience, I'm trying to get some degree of comfort. But some of my colleagues are really good in advancing the coronary sinus cannulation by left arm clutch catheter. Then they pass a thermowire and then they get into it. But it is not that easy. It is easy to say, but it could be challenging. So sometimes you can change the catheter from, say, conventional catheter to 4 to 5 French JR4. Even people also tried with, sometimes with a Lima catheter helps in acute angulation. Sometimes very special sheath like SL3 sheath from femoral vein to cannulate coronary sinus has been used. Injection of contrast into the left coronary artery can also delineate the origin of the coronary sinus os in a much clear manner. At times, there could be prominent of eustachian ridge. That is a real problem. Eustachian ridge, we need to understand the ostium of the coronary sinus is the posterior structure. At the posterior part of the interatrial septum, anterior to it is the tricuspid annulus, and posterior is the coronary sinus. But coronary sinus can be valve, and the opening of the coronary sinus is more located anterosuperiorly. There is a valve, and this is a normal anatomy. You try to imagine in a heart failure patient, when the heart is big, the anatomy gets completely distorted. Therefore, it is very difficult to cannulate the coronary sinus in an advanced heart failure patient because of dilated heart, and the eustachian ridge and other things are so prominent, it really troubleshooting in the situation. But again, with experience and with the special skill and with the newer sort of tools, these things can be overcome. Thevesian valve is another one which I already discussed. There could be membrane, and then you can actually navigate through this valve. And after navigating through the valve, there is a very special device by which you can actually get inside the coronary sinus. So this is one such model by which you can do it. Then after that, able to put wire into the coronary sinus, but cannot advance the guiding sheath because of very acute angle or valve. For that, there are again some very special device by which you can actually get into this. Sometimes there could be tortuous vessels. Straightening of the vein is important. So sometimes you may take double wire, sometimes you take a support with the balloon and then advance the wire. There it could be a support wire, extra support wire, by which various means which comes with experience and also with more and more kind of doing procedure. If you do more and more procedure, obviously you will get more and more sort of challenges. As you face more and more challenges, you know that how to overcome those challenges, which is very important. Acute angle, like in this case, the target vessel is somewhere there. You can see very complex, sometimes the acute angle to take off of coronary sinus, then acute angle to go into the left lateral vein. So there could be some very special catheter by which you can actually get into this kind of vein and then positioning the left-sided lead. For example, direct to target placement by quick flex lead delivery through the subselector catheter, and deliver guide wires like CPS direct or CPS M can actually overcome this acute angle. Using stiff guide wire, as I said, sometimes is extremely helpful. Double guide wire technique to stabilize, and then the sheath, and then it is withdrawn to cannulate the proximally located posterolateral coronary sinus vein. While doing so, and sometimes you can actually create coronary sinus dissection, which is a real known complication. Fortunately, these days, the dissection, the frequency has significantly come down because of the advancement of the wires and tools. We can actually do procedure in a comfortable manner. But if you try to manipulate across the coronary sinus, especially if you inject forcefully, you can actually create dissection. One has to remember that. But normally, if there is a minor dissection, nothing happens. It is a very low flow area, coronary sinus, as you all know. Therefore, the dissection may sort of get sealed off on its own. But if you keep on injecting there or keep on advancing the wire and other hardware along the coronary sinus, well, there is already dissection, you can actually create more problem like perforation getting into pericardial tamponade. So coronary sinus dissection is a rare. Incidence has come down. It used to be something like more than 5% earlier. Now it has come down to less than 2%, which is important. But if there is a coronary sinus dissection or perforation, then it is important to understand the serious bleeding consequence, which could be because of the concomitant therapy, because many of these patients may have anticoagulant therapy earlier. You have to be careful about it, and that has to be known. Sometimes it is helpful to wait for some time, maybe a couple of days, and then you can redo the procedure. So there are many multiple solutions by which the coronary sinus dissection can be taken care of that. People also try to do venoplasty or even stenting in some of the dissection, but seldom we actually need such procedure nowadays. And then phrenic nerve stimulation is another thing. As you all know, the left phrenic nerve is very close to the left ventricle, and it passes over the lateral coronary vein, the vein along which the left-sided lead has to be placed. So that is a real botheration that can actually cause diaphragmatic pacing, and that is a irritation that also causes problem, and patients are extremely uncomfortable. So the phrenic nerve stimulation has to be kept in mind. Fortunately, with the new generation of lead, there are sort of multi-site pacing or multipolar lead. This kind of complication can be minimized by stimulating the proximal part of the lead. There are various algorithms which can be followed. The distal pacing can be avoided, by which you can actually work out the best algorithm by which the optimum stimulation and optimum pacing can be achieved. At the same time, the phrenic nerve stimulation can be minimized. So this is what is called phrenic nerve stimulation. So the other complication, sometimes we all know that normally when you do the procedure, you should ideally put a right ventricular pacing and then go to coronary sinus and then come to right atrium. That's what I do. Many of the operators, in fact abroad also, they do the same thing. The reason is there are some incidents where you can get complete heart block by traumatic right bundle branch block, because we have to understand that many of these patients, they got a left bundle branch block, these patients. So while fiddling with that, if you hit the right bundle, which is very discreet, and sometimes right bundle is fragile, so therefore you can actually cause complete heart block. So therefore it is appropriate to put the right RV lead. But then while doing so, patient can get into complete heart block. One has to remember that there can be lead dislodgement, coronary sinus dissection already discussed. Coronary venous perforation is important, can go to tamponade. Sometimes there could be arterial injury, particularly subclavian artery when puncturing, pneumothorax, AR embolism, and device malfunction. So this is what is a kind of a complication rate. Procedure-related death has completely reduced, less than 1% nowadays, sometimes even 0.1 to 0.2%. Dissection is around 0.3 to 0.4%. Dislodgement a little more depending upon the lead, your experience, and the patient's anatomy, which is extremely important. Perforation is again around 1 to 2%, perhaps less. Tamponade is again less, 0.3, but it is there. Infection is again a nuisance, so it is very important to take care of the pocket. Pocket has to be completely aseptic methodology is extremely important to avoid infection. Lead dislodgement is again another challenge that has to be remembered. And finally, management of post-implantation has to be done. And when you get lead dislodgement, you have to be, before you finish the procedure, when you take the sheath out, there's a technique of doing it. You have to be extremely careful. After struggling sometimes number of hours, positioning the lead into the coronary sinus, left lateral vein, or maybe the ideal vein, it is a frustration if that lead get dislodged. So you have to be really careful of removing the sheath, especially the newer sheath when you actually split it and pull it back. So it is very important. The angle of the coronary sinus opening is important. Position and type of the lead is important. So selection of the lead, and look at the anatomy of the coronary sinus, then select which lead is appropriate for that particular patient. Of course, operator's experience and skill is important, patient's anatomy is important, and finally, left ventricular lead stabilization utilizing a coronary stent is required. Many operators, they have some experience, and many such cases have been presented in international meeting and is extremely helpful. And prevention of the lead dislodgement. Nowadays, actually, sometimes the lead itself has got some special attachment by which you can actually anchor the lead in the coronary sinus so that can prevent the lead dislodgement, which is extremely important. One of those is StarFix device. So after that, management plan is important. Look out for complication related to implant, early and late complication, and good programming and atrioventricular optimization. But having said all this, the CRT procedure is gradually picking up. We are changing it. There is advancement of the tools and technology. The challenges will continue to be there, but with our skill, with our experience, and with the selection of the case, I'm sure we'll be able to overcome that. The complication is coming down. It's a good thing, and eventually heart failure patients are getting profoundly benefited. Thank you very much for your attention.
Thank you, Professor Dr. Robin Chakraborty, for an excellent overview of what's the complications that are likely to face by a CRT implanting and multiple device implanting surgeons and cardiologists, and how to overcome them. I think that will go a long way towards teaching particularly our juniors in how to go in different situations. And with that, I hand it over to Dr. Dilip Kumar. Dr. Dilip Kumar, please.
Thank you, sir. Thank you, Dr. Sinha. Thanks, Dr. Kathuria and Dr. Sudev. Thank you, Dr. Ravin. It was a terrific presentation as usual. And with the as coronary sinus is a low pressure chamber, even if we perforate with wire, nothing happens. It is totally innocuous. Even dissections are not difficult to manage. So it's a self healed and it doesn't create much of a problem, provided we are taking catheters. So once your lead is not in the pericardium or the catheter is not in the pericardium, or you are not pushing in, contrast continuously, things will be manageable. So as we are
Dilip, one thing. In fact, putting
one comment, Dr. Sanjeev.
In fact, one of the very important things is that if you introduce your wire, your guide wire into the pericardium, it in fact helps you to put your lead. Perforation by a 014 wire has no problem with the CS at all. You will seldom have a collection. If you make a loop, as you're talking with Dr. Yadav about a loop, even if you don't make a loop, if you just push it to the sinusoids, go to one of the chambers, your support for putting LV lead increases tremendously.
The lead should not go in the sinusoids or
obviously that of course is.
No, thanks. So now let's move with the next presentation by Dr. Anil Saxena. New promising algorithms in CRT. We are going to learn a lot. What are the new algorithms? And the chairperson of the session is Dr. Mantosh Panja, and moderator is Dr. Devapriya Mandal. So over to Dr. Panja and Dr. Devapriya.
So good evening, Dilip. I am very thankful to you to organize the meeting. It will be essential for the treatment of the heart failure. The device is very, very important. So Dr. Anil Saxena, everybody is the director of pacing electrology at Fortis Hospital. He's a brilliant student. I know him as an examiner at different places. And now I request Dr. Saxena to talk on the new promising algorithm in CRT. Dr. Saxena, please.
Good evening. Thank you, Dr. Panja. Good evening, everybody. I must begin by thanking Dr. Dilip for having me in this session. It's a very long topic and I will try to be as concise as possible. I had to drop in many slides about the studies and data. But it's something very interesting because we have been struggling with many non-responders in CRT. And as we know that a significant number of patients do respond to CRT. Some of them are super responders, but a lot of them do not respond. And there is always a struggle with the various AV timing and VV timing, etc. Because we have found that some patients don't even deliver CRT properly, especially those who have arrhythmia. So this is something which is most important. There was some discussion about conducted AF response. So I've added that slides also. So we know that unless CRT is delivered in more than 95% beats, patients don't respond well. So we should try to maximize CRT delivery as much as we can in every patient. And there are many studies on this, that the CRT delivery has to be upward of 95%. So one of the slightly older algorithm is conducted AF response in patients with atrial fibrillation, where whenever the pacemaker senses conduct consecutive cycles, it tends to, of course, after mode switch, it tends to increase the pacing rate so as to capture a maximum number of beats. And when there is consecutive pacing happening, then it tries to reduce the pacing rate. So that's how it works. We have seen that in many studies, it has been shown that the pacing percentage increases significantly. But there is a false side to it, that even though the pacing may be higher, but many of those paced beats may not be actually complete capture. They may be just fusion beats, with most of it being native and very less contribution from the pacing. So a very related algorithm is called ventricular sense response, where whenever the device senses a QRS complex, it delivers a biV pulse. And the basic premise of this device, of this algorithm, is that upon sensing a native QRS, which is expected to be wide in cases of CRT, somewhere as soon as it senses, it will deliver a biV pulse. So it will have produce at least a fusion complex. So a fusion is better than native complex. So it is expected to improve it. And that's what I wanted to impress upon, that in conductive response also a significant fusion takes place and we don't get a true paced complexes as we would like. Now, one of the important contributors to non-responsive suboptimal LV position and persistent mechanical dysynchrony because of a lot of scarring in the ventricle. And it has been found that on the LV side, where we pace when we pace only from one pole, often the impulse will encounter being scar tissue and then has to go around it. So that contributes to wide QRS and dysynchrony. So to overcome that, a multi-point pacing was established, designed long ago, and we have been using it for several years now. The basic idea is that we can pace from more than one point in selected cases. So it is reserved for patients who are non-responders, and where we can pace on the left ventricular side, we can pace from more than one poles. And of course, right side, in most cases, is already a fusion of the paced impulse and the native impulse. So in many of these patients, we have 4 impulses stimulating the left ventricle, 1 native and 3 paced. And this has been shown to improve the responder rate. So that's how it works. Sometimes there is a big scar tissue here, so we can pace on either side of the scar using multi-point pacing. And of course, in our third impulse is from the RV, and fourth impulse may be the native AV conduction. So we have a fusion of multiple impulses which can then be used to synchronize. And it has been shown to increase the responder rate of converting the non-responder to responder rate. And there was another trial which showed that it reduces the cumulative heart failure hospitalization and overall costs also associated with that. So as far as the battery depletion is concerned, it doesn't affect the battery much. So only half a year of battery longevity is affected. Another important development is optimization of the AV and VV timing. This is a very major contributor to non-responder state, because using the echo-guided optimization, we have seen that most of the studies have not shown a good response, and all the guidelines so far, they don't recommend echo-guided optimization of AV and VV delay. So the manufacturers have been working on automated optimization of AV and VV delay, which doesn't require human interaction and therefore is more predictive and more precise because it's not dependent on inter-observer variability. So one of the earlier we all know was QuickOpt algorithm, where it automatically measures the AV delay and VV delay by pacing in by observing the native conduction and pacing in the RV, pacing in the LV. And then it comes to, by an algorithm, it comes to a certain recommended paced AV delay, sensed AV delay, and interventricular paced delay. And we can program that. It has been shown to be similar or superior to echo-guided optimization. A further evolution of that is sync AV CRT. Basically, sync AV means that we have to, as I said earlier, normally we pace from the LV, from the RV, and then there is a native impulse through the right bundle. And that often goes wasted because RV pace and this native RV right bundle, they stimulate the ventricle at almost the same time. So it has been postulated that we can avoid unnecessary right ventricular pacing and use the native impulse, because that native impulse is always better because it goes through the native conduction tissue. So it will synchronize definitely better. So it can automatically withhold RV pacing, the algorithm, whenever native AV conduction is happening, and it can only utilize the native RV impulse. So this concept is being now implemented by almost all the manufacturers, and this is the Abbott iteration, which is called Sync AV CRT. So when enabled, it continuously monitors patients' intrinsic conduction and automatically adjusts the CRT parameters accordingly. And this delay is measured every 256 cycles in this particular manufacturer's devices. And so they looked at the program value for these cycles, and then it automatically measures the appropriate AV delay and programs it. So, and this happens continuously. It automatically calculates a sync AV CRT delta and programs the device accordingly. It has been shown to decrease the QRS duration significantly, much above the multi-point pacing or sync AV. Then there is a sync AV plus also now, which is even better. Medtronic uses a similar algorithm called adaptive CRT algorithm, where again they look at the intrinsic AV conduction, and whenever there is the presence of intrinsic AV conduction, it does adaptive LV pacing alone. And whenever AV conduction is not there, or the AV delay is very long, then of course it has to be adaptive bi-V pacing. And there is one more feature. This basically works within certain physiological limits, that the heart rate has to be less than 100 beats per minute, and the AV delay has to be less than 220. So that is something which is now the Boston Scientific also have similar algorithm of AV delay optimization, which is called smart delay, that again utilizes the same concept based on patient's own AV interval. It can calculate the interventional timing also, and LV lead location, and depending on that, it can program the AV and VV delays. And it has LV only consideration whenever AV conduction is intact. Now, the next wave of algorithm development basically involves collection of various physiological parameters, including heart sounds, including thoracic impedance, respiratory rate, activity, and heart rate. So Boston Scientific have this algorithm called HeartLogic, which is designed to detect early warning signs of worsening heart failure, because also the CRT patients, they have significant hospitalization rate. And by looking at various parameters, the device can, through artificial intelligence, it can look at the pattern of all these parameters and come to a certain predictive value that patient is worsening and patient may develop clinical heart failure. So this can be used to alert the patients. And this is happening not only with the Boston Scientific, but all the manufacturers are looking at a multi-parameter approach of algorithm development, which will guide the patients, will guide us about various developments happening inside the patient, including the sleep activity, including the physical activity, night heart rate, day heart rate, blood pressure, and all these parameters can be incorporated into a multifactorial algorithm to guide us. So this is a sensor suite which measures thoracic impedance, night heart rate, RV rate during ATF, percentage of LV paced, and sleep incline, respiratory rate, weight, blood pressure. All these parameters, ATF burden, all these parameters can be incorporated into this sensor suite, and we can take decision based on that. So I think I will stop here. It's a very extensive topic, so I think we can have some discussion here. So I'll be very happy to answer if there is any question related to CRT algorithms. Thank you so much.
Thank you on a very excellent presentations, really. And the new thing I have learned today, I am very thankful to you, and particularly how the non-responder to become a responder is a very important issue, because of multipolar and multiple very pulse point is very important. CRT optimizations, we have already spoken, very, very important issue. And SYNCAP CRT technology also in action is very important. Adaptive CRT. And finally, I have spoken the HeartLogic heart failure in device section, very, very, very newer informative to us. And finally, heart failure sensor suit, a very, very new thing we learned today. And thankful to all with the excellent presentation and brilliant explanation of work with all the review literature. Thank you once again. Dilip, any question to ask?
I have one question.
Yeah.
Yes.
Yes. We have any algorithm specially for a patient who has right bundle branch block, non-LVP pattern, white QRS? Is there any new algorithm where you can get a better response?
Yeah, so basically the responder rate is less in right bundle branch block because not everybody has left ventricular dysynchrony. Some of the patients with right bundle branch block, they also have a left ventricular conduction delay, which is not manifest on surface ECG, and they can be picked up before CRT. Nowadays, there is if we do put a lead in the coronary sinus and we measure the QLV delay, that is, we measure from the onset of QRS to the terminal portion of the distal coronary sinus. If we measure the electrical delay, we can identify patients who can benefit. But I don't think post CRT, if there is any algorithm which will look at particularly beneficial for these patients. Thank you.
Excellent presentation, sir. I have two questions to ask. One is, how's your your experience with multi-site pacing? Because it came with a bang and a lot of literature, and then started coming some mixed results, and it's quite intuitively it should be beneficial, multiple segments you are pacing, but the results have so far been not quite very encouraging.
I agree. It is basically only of marginal benefit, and that too in patients who are non-responders, and the non-response appears to be because of a big scar in the left ventricle, which is not allowing the synchronization to happen, and some parts of the left ventricle are still very showing very delayed activation. So it's a very small number of patients who might benefit from this. So, but nowadays most of the devices most of us are utilizing quadrupolar leads. So, but still not everybody is opting for the high-end device which has multi-point pacing. But I completely agree with you that it has only marginal benefit. So it's not something that we really press upon. When I talk to the patients, I say that quadrupolar lead as such is very important. MRI compatibility is very important. But when it comes to multi-point pacing, I tend to look at the cost effectiveness, and I don't see it so cost effective. I say if you don't have an issue, you can go for it, but I won't feel bad if you're not able to buy it. But quadrupolar,
Dr. Saxena, one of the question, when we cannot enter the upper coronary left coronary sinus, but at present, if you directly stimulate the left anterior fasciculus, so we activate the left ventricle. What is the current position at present?
Yeah, so again, basically, it is very difficult to directly stimulate it, but there are some papers coming, very few case reports and all that, which have shown this, that if you directly stimulate even fascicles, then you can create dyssynchrony, you can abolish dyssynchrony. But in patients who have CRT, I don't think there is any paper where they have compared left anterior fascicle stimulation directly with the conventional CRT. But there are a lot of papers with his bundle pacing or left bundle branch pacing coming up to compare with CRT, but not left. There are some case reports only.
We have sessions on especially like debate and kind of present status of CSP, whether the enthusiasm is fading or it's it is a plateau or increasing. So thank you so much, sir.
So I have
yeah.
Dr. Philip.
We are 15 minutes.
So yeah.
Okay.
Yeah. So as you mentioned, different algorithm from different provider industry. So we are not much accustomed with Boston, but we are mostly using Medtronic and St. Jude devices. So one end there is SYNC-AV and there is adaptive CRT. So delta in SYNC-AV you can actually modify, you can change delta, you can program, but in adaptive you do not have that option. So in your practice, what do you find? Do you find any kind of difference in the algorithm from the different provider, or all of them are actually kind of same?
Very difficult to say, because unless one does a study with large number of patients, randomizing them, it's very difficult to answer this question.
Thank you, sir. Yes. So thanks, Dr. Panja, Dr. Saxena, sir, and we can move on with the next presentation by Devavruto. Dr. Devavruto Bera, and chairperson of the session is Dr. Sunip Banerjee, and moderator is Dr. Anjan Sevatia. So over to Dr. Sunip and Dr. Sevatia.
No, I have nothing to say. If Anjan has something to say, otherwise, Devavruto, you can start your deliberation.
Sir, am I audible, sir?
Yes. Audible, visible. Okay. Please make it full screen.
Sure, sir. Just a moment, sir. Thank you, Dilip, for having me here. Respected moderator and chairpersons, in next 10 minutes, we'll be discussing about a few lead extraction cases. So I have kept it the heading as challenges and tricks because as such, there are no tricks, I would believe, in my short number of or short series of cases. So if you look at the lead extraction complications, actually there are many more, but this is the major or minor complications which commonly occurs you will be hardly tending to do any lead extraction cases. But let's say if you go into doing few cases, it becomes that it is not that challenging, but at the same time, you have to be very, very careful. So when you take up in this 10 minutes, I'll be a little brief about few of the things. So if you take up any lead extraction cases, except those are very recent implants of 2-3 months old lead, or which are screwing leads, which are reasonably easy to extract, you need two tools which are very, very useful. One of that is shown in this picture, which is called lead locking device. In Western countries, they call it, in a different manufacturers call it like lead locking stylet as well. So what it is like, it's like a normal stylet, but it has this kind of extra gel kind of things, which when you deploy the device, it is like you go through and through the lead, and when you deploy the device, it attaches whole length of the lead, and then you have more control on the lead to pull and extract it. So this is one of the device which is very, very useful. In my short experience, around let's say 10 of the difficult extraction cases where normal or simple leads did not work, this worked in 70% of the patients, 7 out of 10 patients. And rest of the patients, you need something called a tight rail, which I'll be showing. There are some telescoping sheets as well. The only prerequisite for using a LLD is a patent lead lumen. That's why it's very, very important, not whenever you are doing a case of lead extraction, or whenever you have a patient where you have a pocket infection and you don't want to take out the lead, please do not cut the lead. You take out the PG. If you don't want to take out the lead, you just coil it and put a cap, lead cap of plastic, and put it inside the pocket if you are not planning to take out the lead. Because if in future you want to take out the lead, we need a patent lumen. During cutting, if the lumen is crushed, this using of these advanced devices will be very, very difficult, almost impossible. And the only option left is surgical exploration. The percutaneous lead extraction becomes extremely difficult. The other tool is something like this, which is called tight rail. So in India, it is marketed by Spectranetics. So what it is like a gun-like device, and there are some kind of small blades in front of the sheath, and when you put like your gun-like movement with hand, the blades come out of the sheath. They are although efficient enough to cut the adhesions, they are generally not very sharp. So even if you put it on your finger and try to cut it, it generally doesn't cut your gloves. So this is very, very safe, but you have to be very, very careful. I'll show you a few of case examples. So the most important thing when using both of this is mostly the tight rail is you have to be coaxial to the lead. I'll give you some case examples where you use it coaxially, you will be successful. When you don't use it coaxially, you might land up in problems. So this is one of my case. He's a 40-year-old gentleman with hypertrophic cardiomyopathy. He had a ICD implanted just 3 months back and was infected. And in the center where it was implanted, the device was taken out and the lead end was cut. As I was telling, that better to avoid this cutting technique, because later on, like this patient, the wound did not heal with the device in the lead in situ. Even if the PG was taken out, finally you had to extract this lead. So I was very confident this is just a 3-month-old lead, but it gave a lot of trouble. I'll show you what happened. So this is when you use the LLD. Initially, the problem becomes when you have a dual coil lead. As you know, these dual coil leads are more prone to have adhesions, and that is the major reason why all of us has moved away from using a dual coil lead. But this patient unfortunately had a dual coil lead, and when it was pulled, you can see the spring was decoiling here. That means you have some adhesion starting somewhere here. And so this part was getting pulled and we are unable to extract the lead. Then one of the important step before you take the tight rail is always try to put 3-5 wire into the, it is preferable to put into the SVC. So once you put it in the SVC, even if you have a superior vena cava coil, a superior vena cava tear, you can have some kind of backup balloon occlusion if there is any such kind of complications is encountered. So before you start, you always use a 3-5 wire, and then you start taking your tight rail, which I'll be showing. So once this tight rail was taken, it was, I am not showing the whole because it will be a long video clip. So gradually you go cut, and thing. The thing is you have to be little coaxial with the lead. And if you are coaxial, gradually this you can engulf whole of the lead and you can take it out. So, so this is the way this patient was successfully, the lead was taken out. And this was a successful procedure percutaneously and the patient recovered. So going to a second case, this is a 65-year-old gentleman who had a permanent pacemaker for AV block 2 years back. Although this was not a difficult implant, I'm just talking in terms of a clinical perspective. So this patient, after 2 years of pacemaker implant, had a fever of unknown origin, and he was extensively investigated. No focus was found. One of the blood culture grew a Staph aureus. Now, his pocket was although completely normal, and there was nothing, no tenderness, nothing. So what to do? Echo was done initially, which was normal, but later on, echo showed a possible vegetation. We thought we might do a transesophageal echo, but we thought of doing a PET CT as well. Why we did PET CT, will come to that. So this is although not this patient's PET CT. When you have a suspicion that the pacemaker system has an infection, but you are not very sure about it, you can do a PET scan. It can show you a hot spot when you are having a pacemaker infection. So this is, unfortunately, I do not have the PET scan of this patient. So I'm showing another patient's PET scan. So this patient had a hot spot in the RA as well as in the pocket, but it was not evident on the inspection of this patient's superficial pocket. So when he did a TEE, it was very glaring to see such a big vegetation, which was also suspicious on the PET scan. And this also helped in the decision making, because as you see the size of the vegetation, it is generally said that if it is more than 10 millimeter, you try to avoid transcutaneous explantation of the leads, because these vegetations may dislodge, they can go into or embolize into the pulmonary or systemic embolism can happen. And if it is more than 25 millimeter, it is a contraindication for percutaneous lead extraction as per guideline. So this patient, we referred the patient for surgical exploration, and this whole of the lead and the vegetation was uneventfully explanted. So these are the other things before you take up a patient for lead extraction, you should be careful about. Now coming to my last case, this 63-year-old lady who had a pacemaker implant 8 years back and now had a recent PG change, but unfortunately the PG change was not very uneventful, and she developed a recent pocket infection. Now, unfortunately, this patient had tine leads. As I was telling, that because it's tine leads and it was implanted 8 years back, it becomes a difficult explantation. You have to be anticipating that there might be a problem during the procedure. So, as I said, that lead locking device we used upfront, unfortunately, it was not successful enough to take out either of the leads. And then we thought of taking the tight rail, as I have shown this patient. Although this patient had a lot of adhesions, although it was a just simple dual chamber pacemaker, not even ICD, it was difficult to introduce the tight rail. Now, finally, fortunately, could introduce. This was just showing the situation when you're trying to pull with the lead locking device, which was unsuccessful. Then we took the tight rail. As you can see, there is little progression of the tight rail. So in the next sequence, you see that the tight rail is progressing. This is an important sequence. You see the sheath and the lead are not coaxial. So, and as you see at the end of the clip, this end of this blade from the tight rail is probably hitting this lead, which is the ventricular lead at the moment we are trying. And something unexpected thing happens. As you see, the outer layer of the pacemaker ventricular lead has been cut off. I think this we are a little unsure what has happened, but as we see here, the inner metallic thinner lumen is still intact and it is connected to the lead, but the outer whole of the insulation and the plastic thing has come out. So then we tried many other things. We took a MPA catheter through the tight rail to get more support, but it did not work. We tried a 3-5 wire through the sheath, which also did not work, because we have lost the whole assembly and support and many things because of the outer insulation has been damaged by the tight rail. Another important thing that the sizing of the tight rail is important, because this was a Oxford tight rail, and this was a bigger 13 French tight rail. So for 13 French tight rails are generally used for ICDs, but it is better to use for pacemaker leads. There are 8 and 11 French tight rail. It is much better to use them if possible, because the ease, maneuverability, and the coaxiality are very much better when you have a smaller tight rails. So finally, this patient had to be sent. Although with a lot of maneuveration, we could almost reach up to this place. Somehow that support was not enough, and this lead could not be taken out even with the use of tight rail. So finally, we had to send this patient for surgery, and finally all the things could be taken out for this patient who had a infected pacemaker. So just one penultimate slide from my side. This is one of the important technique described by one of the group from France, that when you have or you are expecting such kind of difficulty, you can use a technique of counter traction from the femoral side, because anyway you have a femoral side where you have putting the wear. You can use a counter traction. You can just focus on this. Sorry for the image clarity. You can just focus on this part, because whenever you are using, let's say it's a left-sided implant, you are using a tight rail. If you drag the lead from below, it becomes like this. The SVC becomes a little tented. And as you progress with the tight rail, it becomes more of coaxial. So the chances of hitting this lead and the SVC, both the lead and SVC damage, becomes lesser. The chances of damaging both of them becomes much lesser when you have a traction from the below. Either, I haven't done it personally, you either can drag with some kind of snare or wear, and that gives you a lot of flexibility to move around this lead. So to conclude my session, generally we use lead extraction for infection in India, but also sometimes we have to use when there are multiple leads and you need to take out any malfunctional lead in spite of no infection. So TEE and PET can be useful for decision making. LLD often helps. I would say 70 to 80% chances LLD will give you success. I'm talking about the difficult extraction which you cannot take out just with your simple leads. And use tight rail carefully, choose the size, because sizing becomes a very, very important issue. Keep your OT ready, and preferably if possible you do it in hybrid OR. If you think that you can manage with C-arm, just arrange a C-arm in the operation theater with the CTVA surgeons ready in difficult implants. We have done a couple of cases like that, and always use intraoperative TEE. 3-5 wear has to be kept from the groin up to superior vena cava, so that if there is any inadvertent SVC tear, you can use a bridge balloon kind of thing, and you can take the patient to OT. Right-sided implants are very, very tricky, as I say in my personal experience. You have to be coaxial and always keep the surgical options open. Thank you. I'll stop here and I'll be happy to take up any questions at there.
Great. Great talk. Congrats. Thanks. We learned a lot of things. Is Anjan there with me? No.
I have one or two questions.
Yes, please.
Number one is like when we are extracting, for ICD, it is very clear that maybe a tight rail kind of thing, we have to upfront take a strategy. But when we are going for a pacemaker lead explantation, I have done around multiple, more than 25, 30, of more than 3 years, 4 years lead. So the crux is when you take the stylus down till the tip, then the support is very high and you'll be able to extract it. So I have a simple question, like after what interval, like duration, maybe 2 years, 3 years, 4 years, in pacemaker leads, you will think of going for a tight rail upfront strategy, or you will try for with a stylus once, or and then if you fail, then you can think of tight rail. So any time duration, 1 year, 2 years, 3 years?
Yes. So there are literature which have looked into this also. So they find that any lead more than 3 years, especially if it is tined lead, there is a very high chance that your usual stillet will not work. So better to anticipate that you might need LLD or tight rail. Generally, if it is screwing lead, even if it is 5, 6, 7 years, you have done multiple extraction procedures, they are even come out without using any of these advanced tools. But tined leads are little tricky. So in my experience, whatever leads has been less than 3 to 4 years, even in, let's say, even in if it is a tine leads, they come out with normal stylet, or you use LLD, they generally come out. About ICDs, as you said, you have to have a little more of anticipation that it might require a tight rail. About pacemaker leads requiring tight rail, I would say if it is more than 4 or 5 years implant and you have a tine lead, you still have to keep tight rail in hand. There are something like telescoping kind of sheaths, which I have not personally used, but many people use. I would like to expect anyone can share their experience of.
I have used that, but that is far inferior. I have used that, but that is far inferior. So either you use the stylus based,
There's no point of
there's no point
going LLD and then you go over to tight rail.
So
one important thing is that a meticulous dissection of the adhesion in the areas of the infraclavicular area where the pacemaker is being implanted, that is the most important primary step. I think that we know all the basics.
Yeah, no, definitely. That is the primary step.
I am just reminding all of us. Thank you.
Thank you. So thank you, Dr. Sunil. Thank you, Debabrata.
Thank you. Thank you.
And now we move on with the next presentation, ECGs from cardiac resynchronization therapy devices. Arindam Pandey is going to speak, and the chairperson is Dr. Biswajit Majumdar, and the moderator is Dr. Silanjan Roy. So over to Silanjan and Dr. Biswajit Majumdar.
Yes. Arindam, you start your lecture, then after completion we will discuss.
Okay, sir. Thank you very much. So at the outset, I would like to thank Dr. Dilip Kumar, the course director, for giving me the opportunity to deliver my lecture. I was listening to the lecture. Last talk was from Dr. Debabrata, which was excellent. So ECG from cardiac resynchronization therapy devices. So what I basically will discuss, what are the ideal things, what are the parameters we must see before taking the patient for CRT. At the same time, after CRT, how could I understand that the patient will respond? What are the parameters to be seen? So the principle of cardiac resynchronization therapy, as we all know, there can be 3 types of dysynchrony, which can be corrected by CRT: AV dysynchrony, interventricular dysynchrony, and intraventricular dysynchrony. Though by this time we know probably the intraventricular dysynchrony is the most important factor for proper improvement of the LV function. But AV dysynchrony as well as AV timing plays a very, very vital role in the programming post-CRT implant, and same is true for VV dysynchrony and VV timing. So we all know there are some factors which favors a positive response with CRT and some factors which favors negative response. Now, out of these different factors, we can see there are something like sex of the patient. Women, they respond better. Non-ischemic etiology, the patient actually responds better. But most importantly, these are the ECG parameters which determines a proper response. We all know a proper and true left bundle branch block as well as the QRS duration are the most important factor for a proper CRT response. So highest chance of response is with wider QRS, left bundle branch block, which are actually true left bundle branch block. I'll briefly discuss that. Female sex and non-ischemic cardiomyopathy, whereas narrow QRS, non-LVB pattern of QRS actually a predictor of non-response. Now, how to assess a typical LVB pattern? And I also want to mention that there can be, deviation from this if there are presence of scar in the place where I am actually putting the LV lid. Now, what exactly is true LVB? As we all know, in normal conduction, this is the left picture which shows that normal conduction, how it happens. Initially in the septum, then gradually it goes away. Whereas in presence of left bundle branch block, we can see from the picture how initially the right ventricle is getting activated, followed by in a longer pathway which activates the left lateral wall of the left ventricle. So during LVB development, QRS duration prolonged by more than 40 milliseconds and initial electrical force, QRS must change. And this actually indicates the activation of the septum. So here comes the importance of understanding the LV activation time. Now, what exactly is the criteria of left bundle branch block? Now, different society, they have their own different definition and criteria. Say, for example, ESC, AHA, and different trials, different randomized control trials also, they have differences in terms of definition of left bundle branch block. But one thing is very obvious by this time. So if the LV activation time is higher, then the chance of success, chance of response with CRT will be definitely better. Now, these are actually very ideal left bundle branch block. By looking into this kind of 12-lead ECG, we can delineate that, we can understand probably this patient will respond very nicely. So what are the factors we can clearly see? There is something called mid-QRS notching in lead 1. It is very, very obvious. At the same time, we can see the discordant T wave. So T wave is negative in lead 1. Similarly, if we look at AVR, we'll find a QS, capital Q, capital S pattern with positive T wave. And the QRS duration has to be more than equal to 130. All the guideline, all the bodies, they have understood that more than 130 QRS actually is basic requirement. Now look at the V1, lead V1. We can delineate the R, small r, capital S pattern in the V1. And V6, there should not be any Q wave, no Q wave. And we can see the ID of more than equal to 60 milliseconds. So basically, ID means intrinsic deflection defined as time from start of QRS to the R peak. So that has to be more than equal to 60 milliseconds. Now, this is another ECG. Again, this is also a left bundle branch block. We can see mid QRS slurring, but no discordant T wave. You can see in lead 1, T wave is positive. Again, if we look at the AVR, the T wave is actually negative. So it is showing that no QS pattern with positive T wave. So that also indicates probably this is not that ideal left bundle branch block as the first picture. Though the QRS is more than equal to 160, ID is more than equal to 60, there is no Q wave in the initial part of the V1 QRS complex. But this is a pattern of ECG, which is also, as by definition, is left bundle branch block, but they actually is less likely to be responding. Now, this is the third pattern. This still again a left bundle branch block. We can see no mid QRS notching, no discordant T wave, no QS pattern with positive T wave in AVR, as well as we can see the activation time is also not very long. So ID is not more than equal to 60 milliseconds. So this is ECG in spite of QRS more than 130, left bundle branch pattern. This ECG, by just looking into this kind of ECG, you can understand probably this patient may not respond that nicely. So there had been multiple trials which found out that 1/3 of patients, they did not have significant delay between the start of activation of right ventricular endocardium and the start of activation of the LV endocardium. So we need to be very, very choosy in picking our patient, because preoperative evaluation, I think, is most important. So a proper notched LVVB, as per different, many of the body, they have made it mandatory to see AHF. They have given a slurring of R is actually mandatory for someone to be called a true LVVB. Now, why this notch happens? As I mentioned, notch, there will be first and second notch. So first notch is the time when the electrical depolarization wavefront reaches the endocardium of the left ventricle. Now, second notch occurs when the depolarization wavefront begins to reach the epicardium of the posterolateral wall. And these notches are best seen in lead 1, AVL, V1, V2, V5, V6. So if we find this kind of notched LVVB and a wide, longer the QRS, better is the response, then this patient actually is a very good candidate for a response. So we can see the ECG, true left bundle branch block, non-true left bundle branch block in the mid, and the last ECG actually is showing merely IVCD, interventricular conduction defect. So That is how we should actually pick up a proper QRS pattern. Otherwise, it will be difficult for response. Now, if I proceed further, so analyzing the ventricular activation using ECG, this is another also important. I already mentioned it. The right ventricular activation and left ventricular activation both can be analyzed from just merely looking into the ECG. And there is something called QRS scoring for LV scar. So though in our practice, day-to-day practice, we do not go for this kind of scoring, but if someone is doing in a dedicated center, then it is not bad. It can give you further information. And in studies, it has been found that probably this kind of scoring, if we follow, so it can actually delineate the response of the patient as well. Now, there are also concept of identification of the LV lead position by LV paste QRS morphology. So this is the distribution of LV lead. As we all know, this is from AHA, standardized 17-segment model. So looking at the vector from the ECG, 12-lead ECG, you can understand where exactly is your LV lead position. And just looking at V1, V2, AVF, just looking to the vector, we can understand whether your LV lead positioning is good or not. So both avoidance of the fractionation and large QRS width can be an indirect tool to prevent LV pacing in region of poor conduction due to scar or fibrosis, because many a time it may not be possible for us to subject all the patient for cardiac MRI. So cardiac MRI is a tool which can actually identify the scarring, but may not be possible. So after you have implanted the lead, looking into the paste QRS, you can understand whether your lead has fallen into some scar or not. So AV delay, as I mentioned, is very, very important. Optimization nowadays, there had been algorithm, as Dr. Saxena was mentioning, St. Jude, Abbott, Boston, they have different algorithm for which actually can calculate the AV delay of their own. So the concept is actually, this is the normal left side picture is normal conduction. The LVB, it is happening, traversing a longer duration. So what biventricular pacing is doing, left ventricular, so biventricular pacing is actually giving some stimulus on the left side, and the modern concept of all this algorithm is to utilize the natural conduction, whichever is available. So creating a fusion bit actually helps. And as Dr. Saxena clearly mentioned, this is the very important difference between a Brady pacing and CRT pacing. In CRT, we want that 100% of the ventricular pacing to be should be dependent on the device, whereas for Brady, we try to reduce the pacing of the ventricles. So in study, it has been found if the pacing is more than equal to 98.47%, then the response is far superior. So we always try to program the AV delay and VV delay in such a way that the maximum pacing is seen. Now, simple method of providing 30 to 40 millisecond separation between the end of P wave and ventricular pacing pulse for optimal AV delay. This is, I think this has been already properly discussed by Dr. Saxena. I'm not going to detail. VB interval optimization using biventricular paced ECG is also very important. So simultaneous biventricular pacing don't always result in paced synchronization, though by definition we are actually pacing both the ventricle together. But to be honest, for a proper response, we need to do some delay. And how we can understand whether the things are working, we can actually see it while we are programming the device. And best predictor was an increase in the R wave amplitude in the V1 and V2. You can see in the first picture. The V wave is very, very tall and very positive deflection, which indicates the LV component of the device is there, which predicts a long-term outcome. So greater changes in the R wave amplitude after CRT indicative of wavefront fusion, which predicts higher probability of response. So that is how we are doing actually. So vector, how we should do, we must understand the vector of 12-lead ECG. QRS vector reflect electrical desynchrony, and QRS vector amplitude halfway in between RV and LV pacing, and minimal QRS vector area both reflect optimal resynchronization and timing of stimulation interval in CRT. So this is how we are doing. I think I have taken a lot of, so I think I'm done. we should finish. So last few slides. So how we should actually see the ECG before and after. Perform baseline ECG before CRT implantation. Evaluate proper or true LVVB, LV activation. In some of the cases, you can go for a QRS scoring. So after that, a proper positioning of the LV lead, then paste QRS. You need to see the QLV as well. Then paste QRS. You need to reevaluate again, followed by identification of the onset of intrinsic ventricular activation. Since AV delay, I already mentioned paste AV delay, how you need to actually program. Then ideally, QRS amplitude in the lead V1 and V3 halfway in between RV and LV pacing is a preferred option. And thus you can actually create a fusion. I think I should stop here. Thank you very much.
Thank you, Dr. Arindam Pandey, for your excellent talk. Dr. Shilanjan?
Yes, sir.
You can ask any question.
The talk was excellent and enlightening, though last part I would love to hear more elaborated presentation that how fusion bit is being created. If Dr. Dilip Kumar allows a couple of minutes to explain that how exact positioning and how R-wave, this fusion R-wave creation between V1 and V3 and how to evaluate that what is the exact AV and VV delay optimization. If Dr. Pandey can please briefly elaborate.
So basic thing is lead V1 in LVV is actually negative. So by putting a LV lead in CRT, what you are doing, you are actually pacing the left ventricle from the lateral side. So that will show a positive deflection in the V1 to V3. More the positive R wave. So as we all know, QRS duration is very important. Multiple studies has clearly shown baseline QRS, narrower you make after CRT implantation, better is the long-term outcome. At the same time, the positive R wave in V1 to V3 is also something which tells you that there is good contribution of the LV activation from the left ventricular lead. And just by looking into this, as well as narrowing the QRS and how you are going to do it, you can just change the VV delay. You can start from one point, gradually reduce it by millisecond, and on the 12 lead ECG, you can find out more positive deflection in the V1 to V3, narrower the QRS, and by that actually you can program the device in a way so the long-term prognosis, long-term outcome, ejection fraction improvement, and clinical improvement will be there.
Excellent. Pandey, Dilip, I will ask you one question. That is according to guideline, when the no LVB, but QRS complex of wide, that is 150 milliseconds, and the class 2 symptomatic, okay, and ejection fraction 30 to 35. There is the class 2B indications. Why interventricular conduction of wide one in absence of LVB? How it happened? QRS complex wide, in absence of LVB.
Yes, sir. They are actually never a class 1 indication. As I mentioned,
class 2B, class 2B,
class 2B indication, and you are never sure that after implanting CRT, this kind of patient will improve or not. But yes, if the patient is symptomatic, all the medical therapy is not failing, because even if there is no left bundle branch block, I mentioned intraventricular desynchrony. It can be there even without manifested LVVB. As Dr. Saxena also mentioned, non-LVVB or RVVB kind of situation with a very wide QRS, many a time this desynchrony is not manifested in the surface 12 lead ECG. So you can give it a try. Many of these patients will definitely respond, but you can never be sure. You need to counsel the patient beforehand.
Thank you, Arindam. Thank you, Dr. Panja, Dr. Shilanjan, and Dr. Visijit. We can move on with the next presentation, and it was an excellent talk, Arindam. So we can move on with the Dr. Lawrence Jesuraj talk and real life ICD case interactive quiz. So Lawrence and the chairperson of the session is Dr. PC Mandal. Moderator is Dr. Suvendu Chatterjee. So Dr. Mandal, over to you, sir.
I think we should go directly to the lecture of Dr. Jesuraj so that we can get time to discuss afterwards. Please, Dr. Jesuraj, I will request you to finish in time so that we can get time to have some questions.
Yeah, I think it was mentioned interactive. I'm not sure how we are going to interact. So anyway, I'll drop a few questions during the presentation itself. It's a very short presentation. We can have a discussion during the presentation itself. I'm fine with that. So the first case of mine is a 61-year-old man hypertensive for more than 25 years, is a smoker and alcoholic, had a history of recurrent palpitations, now had a palpitation with an ear syncope. He went to a local hospital. This was a ECG taken at a local hospital, very clearly shown that's a white QRS tachycardia, most probably a ventricular tachycardia. So he was cardioverted twice outside with 200 joules. He was shifted to our center with amiodarone infusion, was managed medically. He was VT free for 2 days of amiodarone infusion. This is the sinus rhythm ECG. Any comments on that, sir? So far in the case, we had a VT, and this is the baseline ECG of this particular patient. So it was diagnosed acute coronary syndrome outside and had a septal and apical hypokinesia. That's what mentioned in the outside ECG. And cardiac enzymes were negative, and CAG showed normal epicardial coronaries.
What was the QT in this case?
ECG wise, what are the background idea of what we can get it from this ECG regarding VT? What are the substrate, ECG substrate of VT? One is definitely QRS duration, and second is QT interval. What is the QT here?
It's a prolonged QT, but I think it's very difficult to interfere in this patient because we have
already amiodarone infusion.
Yeah, 2 grams of amiodrones per day. That was the dose he got it. So it's very difficult to comment on the QT. Anything else which is striking in the ECG, which is putting towards some diagnosis?
The morphology of QRS also.
V1 looks like, and also Dr. Anup Gupta writes memory changes after VT.
Hypertrophic cardiomyopathy can be one possibility.
Yeah, it's definitely there is some form of myocardial disease which is running. We can see a lot of fractionation. So these kind of fractionations definitely point towards myocardial scar. This is definitely, I think, although there is a gross ST changes, we all of us know this is not an acute coronary syndrome.
What is the LV ejection fraction?
Sarcoidosis should be excluded.
Yeah.
Yes.
Yeah. So this ejection fraction is, I'll show. The patient was a cardiac enzymes negative, and CAG showed normal epicardial coronaries as expected. This was a ECG which was taken few years back. Patient had this ECG with him, which was taken some years back. So any thought process on this ECG?
To rule out any pre-excitation there?
No, I think
lead to.
There is a short PR, but I think there is no definite delta wave here. There is definitely a wider QRS with
short PR, yes.
It's a splintered QRS. Again, I think one thing we can observe is definitely the QRS morphology has changed. Not only that, there is a significant loss in the R wave amplitude also.
Yes.
Definitely he's losing a lot of myocardium here. He had no history of syncope in the past. He's an active businessman for the past 25 years. No previous echo available. His father died of SCD at 40 years of age. No details available. As usual, it was told that it was a heart attack.
Any cardiac MRI available?
Yeah, this is the next one. We have done an echo. Echo showed hypertrophied LV. It's already been pointed out. He had an ASH, asymmetric hypertrophy. He had a mid-cavity obstruction, which was mild. He had an apical ballooning with nearly akinetic apex, which is not very uncommon with a hypertrophic cardiomyopathy, we know. I think this was the one which was picked up in the earlier center as a regional wall motion abnormality. He had a mild to moderate LV systolic dysfunction, and EF was 40 to 45%. What next?
I think cardiac MRI available, cardiac MRI.
I don't think I did a cardiac MRI, no. I don't think I have done a cardiac MRI on this patient.
What's an AICD?
AICD should be.
Yes.
I think AICD is a straightaway option. Any thought process on which one you are going to choose, single or dual, on this particular patient?
Dual lead.
Dual.
Because we have to take care of obstruction as well if there is some.
Definitely. If there is structural substrate is there, it is definitely a dual.
See, when you are looking at a dual chamber ICD system versus single chamber ICD system, there are two things you have to basically look at. Single chamber ICDs of present generation are reasonably have a good algorithms to identify most of the arrhythmias. So whenever you are going for a dual chamber ICD, particularly you have to be worried about if the patient needs an atrial pacing. That's the one thing where you will look at a dual chamber ICD. Second, if the patient has a significant risk for an atrial arrhythmias. As we know, hypertrophic cardiomyopathy is one of the structural heart disease where incidence of atrial arrhythmias is also very high. So hypertrophic cardiomyopathy is a one subset where you have to think about dual chamber ICDs most of the times. Even though if it is a younger patient also, you have to look at dual chamber ICD as an option because these patients have a significant atrial arrhythmia burden. And ICDs, although they have excellent algorithms, they tend to give an inappropriate shocks for a AF with fast ventricular response. So this is one patient whom dual chamber ICDs are very useful. Second one, whenever you see a patient who is a candidate for an ICD and has a baseline sinus rate which are on the lower side, it's always better to go for a dual chamber ICD because you may occur an atrial pacing, particularly if you are going to load these patients with amiodarone or beta blockers. Radiofrequency ablations in hypertrophic cardiomyopathy does not have a lot of success because most of the scars are mid-myocardial. So this patient has undergone a dual chamber ICD and post-op 2 days were really uneventful. We were planning to shift him to room. Third day he had a VT storm. Basically a VT storm, which I think went to around 18 to 20 cardioversions a day he was requiring. And he was started on a very high dose amiodarone. He was on nearly a very steep dose. I think the largest amount of amiodarone ever used in my EP practice was on this patient. It was around 2 gram amiodarone per day of dose. When you go very high on amiodarone, only thing to be worried is hypotension. Fortunately, this patient had a really good blood pressure, so I could go on very high amiodarone. He was on xylocaine infusions and beta blockers, and he required phenytoin also, like I use on VT storms. One thing on beta blockers, I prefer propranolol on most of the patients who have VT storm. This propranolol has very good data on VT storms particularly. More than all other beta blockers, propranolol have been shown to have very good control over VT storms. VT settled in 2 days, was kept on low rate of 90. I had to pace him pretty fast to suppress ventricular tachycardia. He was only pacing atrium. So I had no problem of pacing the atrium. Patient became dependent on atrial pacing on 100%. This again confirmed that I have to put a dual chamber ICD on this patient. PR interval was on longer side. That was fine. I was thinking about radiofrequency ablation, but they were not keen. Now the patient is on close to 4 years follow-up doing well. So another case is a 50-year-old man had a VSD Eisenmenger.
Friends, I have one comment. There is another condition where we would like to go for dual chamber ICD is a long QT syndrome, where you need a atrial pacing to keep a high rate with high beta blockers. And then if the patient develops a VTVF, then the ICD will take care, the RV lead will take care, shock lead will take care. So the third condition where besides the pacing backup, secondary HCM and third is long, where you go for prefer dual chamber.
Dual chamber ICD, yes.
Whenever you see a patient who has a stormy course during his VT, I always prefer a dual chamber because you will end up putting a single chamber. Your lower rates will be 40, 45. You are not very keen on pacing the ventricle because it will worsen your LV function. But you have an atrial lead there. You can just pace the atrium and keep the patient at a 50 rate. In the second case, 52-year-old man had a VSD Eisenmenger, had a recurrent palpitations, had a documented supraventricular tachycardia, was ablated elsewhere as a right atrial tachycardia, had a recurrence within a month. I took him, this is a baseline ECG. He had a typical AV nodal re-entry. Although I was looking at VSD Eisenmenger and all that, I thought he's going to have a very complex arrhythmia. He had an AV nodal re-entry. We ablated, I think, successfully. When I was testing post-op with an isoprolol, he had a recurrent episodes of non-sustained ventricular tachycardia. One of the episodes sustained more than 5 seconds, and it was self-terminating in this patient. This was a VT which was getting induced whenever I am trying to induce the tachycardia. I ablated AV successfully. Post RFA, I could not induce any SVTs, but still I was able to induce monomorphic ventricular tachycardia in this patient. So what next? What do you want me to do? Can I send the patient on beta blockers, or you want me to do an ICD, or just follow up with the patient?
A trial of beta blocker, I think, can be a good thing for 6 to 8 weeks. If it recurs, then we have to go for a AICD, because chance of success with AICD in a Eisenmenger is not so well. And guideline also tells that AICD as a primary therapy in Eisenmenger is not there.
See, this is a man around, I think, 50 plus years of age, doing extremely well. I think he's a very successful businessman close to my town. And that is no problem with his survival. So we need not worry about it. Only problem you are worried when you put a ICD in Eisenmenger is you are exposing the ICD lead to a systemic circulation. So the lead is in the systemic circulation. So open to the systemic circulation, the thromboembolism risk is very high.
Very high.
So when you are going to put a ICD lead in the RV here, you are basically it's a open system. The thromboembolism goes elsewhere, and we know these patients are hypercoagulable to start with. And beta blockers are effective. One thing I would have done now, I think it was a case done some 7 years back. One thing I would have done earlier would have been a cardiac MRI to look at the scar. But if you look at the prognosis in Eisenmenger patients with VTs, they can develop a scar in the right ventricle and can have a VT. And there are cases where they put an ICDs also. But looking at this case, I was not very keen because the patient had no clinical VT documented before, never had a syncope before. So I was not very keen. I just put a event recorder for 2 weeks, no documented ventricular tachycardia. I just kept him on beta blocker and left him alone. But story continues. At 6 months follow-up, no issues. But now he has 2 episodes of syncope preceded by palpitations. Holter was done. Holter shows multiple episodes of NSVT, nearly more than 50 episodes during the monitored period. This was a Holter, multiple episodes of NSVTs. And now what we are going to do? There are 2 episodes of syncope.
I think clinically significant VT, you have to go with ASCD with counseling that you need some anticoagulation lifelong. And chance of success with anticoagulation is also a bit less. And they are also prone to have more bleeding. With this counseling of 3 things, that success rate is a bit low, one. And second thing, chance of bleeding and chance of embolism, both will be there, even with good amount of anticoagulation. With that, we have to proceed because it will be a life-saving thing now.
Yeah. So I had 3 options. Radiofrequency ablation, I was not very much keen on it because I know the success is not going to be great. So he has undergone a single ICD. He had basically post-op hematoma, has to be managed well. And he had 2 monitored VTs. I think around 5 years now, he's kept on warfarin, doing well. No further episodes, no SVTs, or only 1 episode got treated in the last 5 years. Other than that, he is doing extremely well on a very high dose, stiff dose of beta blocker. He's on 5 mg, I think 10 mg of bisoprolol right now. So doing well. I have not kept him on amiodarone, and beta blockers he's doing well. I think with these 2 cases, what I would try to insist on is there are whenever you are looking at devices, ICDs as a treatment for these kind of complex scenarios. I think definitely if you have to be little more, as already been told, counsel the patients well. You can do on these kind of a complex patient subset also. Whenever you are going to put an ICD, particularly on these group of patients, there's one big problem is a VT storm. We know very well in ischemic cardiac myopathy, we put a VT and we get a VT storm. One big advantage for the electrophysiologist, you can always go in and ablate. But these are the group of patients where ablation therapy is also not very effective. So I was successful. I was lucky to be able to come out of both these cases. I think if there are any more questions or discussion, I'll be happy to answer. I'll just add on one thing. I think last case, Devrata's thing, I was very happy to see that. Being my interest being lead extraction, one thing to add on, there are the sheets which we talked about, the sheets, slide rail which comes from Spectronics. Right now, unfortunately, we don't have Cook sheets. Cook sheets supposed to be very good. I've used Cook sheet before. They are really good. You may not require in every patient the cutting sheet, which is a tight rail with Spectronics, the Philips one, but you can use the sheet. One of the largest centers for lead extraction, which exists in Pisa, they don't use this mechanical devices or laser extractions for leads. They just use the sheets and pull out the leads. Another thing about lead extraction, I always say that more than lead extraction, what everyone who implants the lead should know is what all you should do during an implantation to avoid a lead extraction in future. I always say prefer left-sided implantations, prefer screwing leads, particularly in the atrial position. Atrial tine leads are a lead extractor's nightmare. It's very difficult to extract tine leads from the appendage. So always try to put screwing leads as much as possible in atrial positions, particularly in younger patients, and try to avoid too many leads inside and be careful about post-op wound management. Thank you.
Just one comment regarding VT storm. There is no actually regarding clinical pointer for VT storm in patient with when we are going for ICD implantation. Actually, basically no clinical pointer. substrate is not an issue. Any patient can develop VT storm after post-procedure also. But only one correlation is there if the patient presented acutely. Suppose there is no history, but presented with recurrent VT, that means presentation, acute recurrent VT, that presentation is a guide that this patient may develop VT storm in future. That means in post-procedure, either within days or weeks. That's a possibility. Otherwise, there is no clinical correlate, whether it be ACM, DCM, by ischemic cardiomyopathy, there is no correlation of regarding VT storm. Only one thing, that is clinical presentation of acute presentation, is a strong correlate for VT storm post-procedure.
Thank you, Prakash Da. Thanks, Lawrence. It was brilliant 2 cases, and you have really given good points in lead extraction. I have used Spectronics sheet, extraction device, which was not. I didn't feel it good.
They are not very comfortable. They are very stiff. They are not to be used. Yep.
So thanks again, Lawrence, for being here, and hopefully next year you will be again invited.
Thank you.
Thank you. So we'll move on with the next presentation. Suchit is going to talk on how to avoid inappropriate shocks. Suchit, and the chairperson is Dr. Lipika Adhikari, and Anunay, I would like you to moderate the session. Anu, you are there?
So I would like to invite Dr. Suchit sir. He's a brilliant electrophysiologist and device specialist. Suchit da, please.
Yeah, can you hear me?
Yes, Dada, you are very clear.
Okay. So thank you, Dilip da, for inviting me. Thank you, Onunay, and chairpersons and moderators for giving me the opportunity to present. So my talk is a bit theoretical maybe, but I will like to discuss some important points about how to avoid inappropriate shocks in ICD. It's a common topic, but just I want to highlight some points here. So I will make it full screen first. Okay. So as we know that shocks are always bad. We don't want ICDs to shock unless it is absolutely necessary. So they are poorly tolerated by the patients and the families. They can create a fear and distrust of the ICD, which can be long lasting and sometimes may require professional help and even psychiatric counseling. They even can lead to VT storms on the medical side, and unless addressed can lead to myocardial dysfunction, LVF, and even mortality. An occurrence of repetitive shock for whatever reason presents a medical emergency and needs patient admission with the concurrent increase in the cost of hospitalizations and testing sessions. So we don't want shocks. So let's just clarify the therapy classifications which we call as an appropriate and inappropriate. The appropriate is a response to a sustained VT-VF or a hemodynamically poorly tolerated arrhythmia. It can be a ventricular or even a supraventricular. Inappropriate shock is a response to signal generated by something other than sustained ventricular arrhythmia or hemodynamically poorly tolerated arrhythmia. There is another category called as an avoidable therapy. This is programming of detection and therapy parameters and algorithms so that shock or ATP therapy is withheld from arrhythmia that would be expected to self-terminate. Also here we can put the role of VT ablation prior to means after putting the ICD to avoid shocks. That is also an avoidable mechanism. So inappropriate therapies, these therapies are due to supraventricular rhythms like sinus tachycardia, atrial fibrillation, atrial flutter, reentrant SVT, and atrial tachycardia. Or it can be due to a signal misinterpretation like a multiple counting of single events, environmental signals, non-sustained VT, extracardiac physiological signal like myopotentials, other interfering electronic devices like LV assist devices and nerve stimulators, inappropriate lead placement or dislodgement, and conductor or insulation fracture, header conduction instability, or pulse generation failure. So how common are these therapies? Depends on the patient's characteristic, including the indication for device, concomitant medical therapies, including antiarrhythmic medication, programming of the ICD, and duration of the follow-up. For primary prevention ICD, it is about 30% of the shocks which are given are inappropriate. So it comes out to be around 10% of the patient having a primary prevention ICD have inappropriate shocks. And there is a cascade of events leading to ICD shock. So one is a heart rate threshold for giving a shock. So there's a role to ignore the slow rhythms, that is even a slow VT or an SVT. There's a duration count upon which the shock is given. There we have the role of ignoring the non-sustained arrhythmias. There can be discrimination enhancements to ignore the SVT. And finally, we always try to terminate with an ATP. And when ATP fails, then only the question of shock comes. So we intervene at each of the steps. That is, I have already discussed in all these things, and deliver shocks of sufficient energy when it is needed to deliver to ensure that the first shock succeeds, and minimize ventricular pacing in non-CRT devices to avoid congestive heart failure, exacerbation, and atrial fibrillation. Now, duration criteria, there are different trials which has looked at duration criteria, because even VTs which are slightly longer also can self-terminate, and this strategy is important to set the prolonged detection settings. There are different trials and even meta-analysis of the trials like Relevant, Merit-Rarity, Advance-C, and Provide showed a reduction of overall burden of therapies by 50% of reduction of inappropriate ATPs and shocks. Now, what are the limitations of increasing the detection interval? Evidence in patients in secondary prevention ICD is lesser, because most of these trials are done in primary prevention. The Merit, RIT, and Relevant did not include a single chamber ICD, and Merit, RIT excluded patients with permanent AF. Now, rate criteria for ventricular arrhythmia detection, that is the second intervening point. The heart rates can be extremely rapid during ventricular tachyarrhythmia, and it is less likely that such rates are achieved during SVT, thus making rate a powerful component of arrhythmia discrimination. However, VT can also present with slow rate, while SVT can also present with a faster rates also. So rate cutoff will be a trade-off between maximizing sensitivity of ventricular tachyarrhythmia detection and maximizing specificity at the expense of some slow VT going undetected. Now, evidence of primary prevention trials have shown that conventional therapy was compared with a higher grade group, where the higher grade group was cutoff of 200, while conventional therapy was less than 170. So the primary endpoint of first occurrence of inappropriate therapy was observed in 20% of conventional therapy, while 4% in the high rate group. So definitely in the high rate group, there is definite reduction of the inappropriate therapy. Also, there is a significant decrease in the mortality in the high rate group than the conventional group. And it has been shown that majority of inappropriate shocks occurred at rate between 181 and 230. While these are all important, keeping a high rate is important in case of primary prevention. The secondary prevention, usually we have to keep a rate which is 10 to 20 less than the documented VT rate. So single versus multi-zone programming, there is no trial that keeps a head-to-head study of those. But we see that using more than one detection zone can be useful for modern ICD programming. Now coming to SVT, VT discrimination. This provides a sequence of sensed electrogram that satisfied rate and duration criteria as either SVT or VT-VF, and discrimination algorithm combine individual component discriminators to provide a final diagnosis. And discrimination components, their individual discriminator components is considered in relation to the EGMs analyzed as ventricular only or in a dual chamber ICD atrial and ventricular, also by the rhythm that they identify, that is AF, sinus tachycardia, VT, or by the type of EGM information analyzed, that is the intervals versus morphology. Now, these are the things which are very important in case of single chamber ICD, that is the onset. So onset is very important in diagnosing diagnosing whether it is a sinus tachycardia or not. In sinus tachycardia is usually a gradual onset. In VT is usually taken as an abrupt onset. So sudden abrupt onset was one of the first single chamber interval based discriminators, and it can be applied only once. Now, whenever there is a redetection, this onset cannot be applied. Now, there is another thing called the chamber of onset. Chamber of onset is a related interval-based dual chamber discriminator that classifies a 1:1 tachycardia as SVT if the atrial rhythm accelerates at the device-defined onset. So onset, which rhythm accelerates, atrial or ventricular? So that is the criteria for the chamber of onset. Interval stability is important when we are going to detect atrial fibrillation and not shocking them. So It is an explicit single chamber interval based discriminator that classifies the rhythm as atrial fibrillation if the ventricular intervals are sufficiently irregular. But this discriminatory capacity reduces when the atrial fibrillation is fast, above 170 beats per minute. Interval stability also fails in the presence of drug, reduces the rate of VT. Most important is a morphology match. Morphology match is a single chamber discriminator, which is the only algorithm component that does not depend on rate. It classifies tachycardia as SVT if the morphology of the ventricular regime is sufficiently similar to the morphology during a conducted baseline rhythm. And it analyzes EGMs from the shock electrodes, which record a larger field of view than EGMs from the near field EGMs. The first common step is the acquisition of a baseline template by mathematically extracting EGM features, and both acquisition and subsequent template updating are now automated in today's ICDs. So now coming to the dual chamber components, when you have a dual chamber component, the first is a rate branching, that is atrial rate and ventricular rate are compared to diagnose whether it is a VT or not. If the ventricular rate is more than atrial rate, it is diagnosed as VT. Second, AV dissociation identifies isorhythmic VT during sinus tachycardia, and AV association discriminator diagnoses SVT in the presence of 2:1 or 4:1 AV association consistent with atrial flutter with a fixed conduction ratio. Now there are different discrimination algorithms. So most importantly, the primary discriminator is a morphology discriminator, which forms the primary component of a single chamber algorithm. And stability and onset comes later. Stability is the second one, and onset used sparingly. In contrast, in case of dual chamber, the rate branching or comparison of the rate algorithms comes first. And if it can diagnose a VT more than 80% of the cases, because in 80% of the VTs, the ventricular rate is more than atrial rate. And in 20% of the cases, you need the other things, that is the morphology, then these things, the onset and stability for diagnosis. Stability is applied only if AF is confirmed by direct calculation of rate, and sudden onset, chamber of onset, or 1:1 AV association is applied only if the atrial rate equals the ventricular rate. Now, who benefit from discrimination when both the rate of VT and SVT overlap? The benefit is less for primary prevention patient, and patients with CHB who do not have any conducted rate from above do not benefit from discrimination algorithms. Another important thing is the SVT limit. SVT limit is the highest rate at which the SVT-VT discrimination is applied. Above that rate, it is always taken as VF, and there is no discrimination applied. So it is usually kept at 230. Another is that duration-based safety net features, that is called timeout. Whenever you are treating arrhythmia as SVT initially, and then after some time the arrhythmia is continuing, so it can be also a VT missed. So that's why they have kept a timeout, maybe 3 minutes, maybe 5 minutes, to override that thing and give a VT appropriate therapy. Usually it is recommended to off because SVT is much more common than VT. Programming and override duration results primarily or solely in inappropriate SVT therapy. So dual chamber versus single chamber, this has been already discussed before also. This meta-analysis found no superiority of dual chamber ICD in terms of mortality or inappropriate therapies. Even in a dual chamber ICD, even after implantation, the dual chamber discrimination should be programmed only if the atrial lead becomes chronic, if atrial sensing is, or if the atrial sensing is reliable. Atrial lead dislodgement, oversensing of far field R waves, or the undersensing due to low amplitude atrial signals can cause misclassification of VT or SVT. So this is an example. Here, the device classified this as VT based on the morphology match, SVT based on morphology match, because there were significant morphology match comparable to the sinus rhythm. And then because of also the interval irregularities, this was classified as SVT. Finally, it changed to its classification to VT because there was a change in the score of the morphology match, maybe related to the rate-related aberrancy. Also, at high ventricular rate, more than 170, interval stability criteria doesn't work. So it diagnosed as VT, and then it gave ATP, which failed, and finally it was shocked. But initially, it was an atrial fibrillation, and finally it was diagnosed as VT because of change of morphology match due to rate-related aberrancy. So coming to the ventricular oversensing in ICD, oversensing, excluding recall leads, ventricular oversensing accounts for less than 10% of inappropriate shock, but it often results in repetitive shock and severe symptoms. I'm not going into details. So this is one of the example where we have the EMI, where we have myopotentials detected because of the lead insulation break, and these are characterized. These are diagnosed as VF if it is faster enough. Another is a lead fracture where we have an intermittent, saturated, non-cyclical, variable amplitude artifacts, and these can result in tachysensing and inappropriate therapy. So present algorithms have three features. If intervals are non-physiological, these give an alarm, and such short intervals are often transient and can be repetitive. In true bipolar lead, oversense signals are absent on shock EGM. The last one is used for withholding shock, because if you don't have any shock EGM, this counter, and you have a near field EGM, that means this is something abnormal. Now coming to T-wave oversensing, usually results in a rail track appearance. They have alternating intervals. And
pretty quick,
yeah. Okay. So we'll finish quickly. These are all algorithms for preventing T-wave oversensing. I'm not going into details. There are 3 times you can change the vector. You can change the algorithm, and you can change the signal filtering by decreasing sensitivity. So guidelines, what does the guideline say? I will just end with these slides. For primary prevention ICD, tachyarrhythmia detection duration criteria should be programmed to require the tachycardia to continue at least 30 intervals before completing detection to reduce the total number of therapies. For primary ICD patients, the slowest tachycardia limit should be programmed between 185 to 200 to reduce the total therapies. For secondary prevention ICD patient, tachyarrhythmia detection duration criteria should be programmed again to 30 intervals before completing detection to reduce the total therapies. Discrimination algorithm to distinguish SVT from VT should be programmed to include rhythms with rate faster than 200 and up to 230 to reduce the inappropriate therapies, not over 230. It is recommended to activate lead failure alerts to detect potential lead problem. For secondary prevention ICD patient where clinical VT rate is low, known, you have to program 10 beats or 20 beats below the level. Then it will be useful to program more than one tachycardia detection zone to allow effective use of tired therapy and of SVT-VT discriminator, and allow for a shorter delay in time-based detection programming for faster arrhythmia. When a morphology discriminator is activated, it is reasonable to reacquire the morphology match if the morphology match is unsatisfactory to improve the accuracy of the morphology discriminator. It is reasonable to choose single chamber ICD therapy in preference to dual chamber if the sole reason for the atrial lead is SVT discrimination, unless a known SVT exists that may enter the VT treatment zone or reduce both lead related complication and to reduce the related complication and cost of therapy. Programming a non-therapy zone for tachycardia monitoring might be considered to allow clinicians to untreated arrhythmias. Rest are all 2B indication. I'm not going into details. Thank you.
I think Suchit sir has covered the topic very well. If anyone have questions, they can ask.
Yeah, Suchit, it was a brilliant talk. And as we are running short of time, running a little late, we'll move on with the next presentation. It was a really wonderful presentation.
Thank you. Thank you very much.
Next topic is new promising algorithms in ICDs. We have just heard from Dr. Saxena, new algorithms in CRT. So it's time for new algorithms in ICDs. Dr. Swamin Devidatta is going to present, and the chairperson of the session, Dr. Sunandan Sikdar. May I ask Sunandan? Sunandan, are you there?
Yeah.
Yeah, you can
invite. So we can start the session, yeah. Oh, shall I?
Yes, please.
Yeah, good evening, everybody. And at the outset, I must thank you, Dr. Dilip, honestly, to have me here on this illustrious list. Really thank the opportunity and the industry partners as well. Get going straight away for the lack of time. Can you see my screen?
Yes.
Is it seen?
Yeah.
Okay. So again, I think it's a little difficult to cover the entire list of developments. It's been a remarkably rapidly advancing area, but I must thank Sujit. He's made my job a lot easier. So we'll get into the topic straight away. See, what's an ICD ideal? In an ideal world, an ICD should not give any inappropriate shocks, and it should not have any ventricular arrhythmia gone undetected, and should be delivering therapy for every single ventricular arrhythmia, which is appropriate therapy. It doesn't happen, and basically these advancements or these algorithms are intended, or the objective is to strive and get to this point. So I think Sujit has touched upon it already. So I'll just make a quick brief mention. 65 to 70% of the shocks or therapy is actually appropriate. The remaining are inappropriate, and again, which is what a major goal of what these newer algorithms are to minimize. It's a busy slide. I'll not allude a lot into it. Sujit has already touched upon it elegantly. So 20% of the arrhythmias, abnormal, inappropriate shocks are rather because of SVTs. And we have these host beautiful, although not very new, but they are elegant algorithms, PR logic, of course, that's with Medtronic, but each company has its own individual nomenclature for that, and all of them work on the same principles. A lot of developments actually happened on the non-arrhythmic front, where there are some intuitive newer algorithms which are elegantly now working to exclude the inappropriate therapies, especially for noise. And one of them is RV lead noise discrimination associated with an alert, which can be alarmed triggered through the remote monitoring system. The RV lead integrity alert. Now, these are Medtronic algorithms, but again, you have Secure Sense in the St. Jude in Abbott, and similar algorithms in other companies as well. And again, T-wave discrimination, also like Sujit touched upon, has also undergone a little bit of evolution in the last few years, and I'll touch upon these algorithms. Now, coming to lead noise algorithm, there's a Secure Sense. Now, that's again a proprietary algorithm with Abbott. Especially, it differentiates and does a great job. I've personally seen a few cases which does a great job in eliminating inappropriate shocks from lead noise. Now, notice it basically compares the lead signals from near field channel with a reference channel, which is nothing but a far field channel, which is called the discrimination channel. And notice here on the central part of the page, you see the noise, which is noticed as a high frequency signal in the near field channel. But then if you look at the far field channel, which is the coil to CAN EGM, it tells you the story. The Secure Sense is on, and that's why it flags it as VS2, which is V Secure Sense on. And that tells you that this is basically noise and therapy is withheld. On the other hand, if you see a genuine arrhythmia, which is threatening, if you see the arrhythmia on the right side, ventricular fibrillation, you have near field as well as the far field signals concordant, and they agree that there is an arrhythmia, and VS2 no longer holds the therapy, and the patient actually appropriately gets shock. Again, commonly the reasons why we have lead noise causing these kind of arrhythmias, or not arrhythmias, rather noise, are related to insulation breaks, or set screw issues, or lead not properly seated well in the connector, etc. Or early fracture can lead to these kind of issues. Highlighted on the right side of the screen, you can see on top you have appropriate arrhythmia appropriately dealt. You have a fibrillation which is actually sensed correctly, and then you can see the concordance between the near field and the far field EGMs, and the therapy is appropriately delivered. And then elegantly, this Secure Sense algorithm actually eliminates a potential inappropriate therapy by taking the far field EGMs into account and then holding back the therapies when it is not necessary. Again, and get the example on the left side is your lead noise, and far field is quite clear, pristine clear, and there is no therapy delivered despite fibrillation being sensed. It is over it. On the right side, you have, of course, an appropriate fibrillation which is dealt with. So basically, it goes through the steps of near field and far field, both taken together, like I said, and then finally, when it confirms that there is a discordance between near and far field, far field basically overrides the near field decision making, and then the therapies are held back. Now, not only does it act at the patient level, but it also, you have this option of kind of, it flags on your wrap-up overview. The moment you program such patients, you see on the first, the moment you see the page, and you see immediately that this has been happening. So it basically tells you that there are some issues in the lead, and not only that, in appropriate devices, patient is actually notified as well, either through a vibratory or an audible alert. And if you see in the same patients, you will actually notice that there is something wrong. There's a trend towards dropping impedance as noted here, or there is a sensory issue. Something would actually be noted there. That's quite helpful in cases. All this can be, these alert triggers that you wish to see, or whatever you want to notify the patient, can all be programmable. And it's all right in there in front of you, what you want to be a trigger as far as what you want to see on your FastPath and what you want to your patient. Again, another example, you see this non-physiological discrete signals, which can potentially continue to become inappropriate therapy, and that's warded off with a secure sense. Now, the similar algorithm in Medtronic is lead integrity alert. Now, these algorithms have come of age and really are doing a great job, and automatically are providing with a lot of lead malfunctions well before they could actually become clinical issues in time. So in Medtronic, this called lead integrity alert. Like I said, it triggers when you have 2 out of these 3 which occur, either an abnormal impedance or a sensory abnormality, which there is a abnormal sensing of the RB-EGM, or there is a very fast non-sustained ventricular tachycardia, which is happening frequently, which is often non-physiological. When you have that, there are the actions taken. Patient often hears an audible alert, which is programmable. And immediately what the device does is automatically the device changes its VF numbers. It makes the VFs a little less proactive. So it's likely that these patients are going to get inappropriate shocks in the future. So the VF number needed to detect, or intervals to detect the VF is increased to the maximum, that is 30 out of 40. And of course, the clinician is alerted through remote monitoring available. That's the Medtronic page for you, where it tells you that there is a lead integrity warning that is issued, and you notice that there are high rate non-sustained episodes which are extremely fast, less than 220 milliseconds, and there is a sensory abnormality also. So notice that you have this, this is the older device, you have these shocks. Notice on the top you have 25 joules, 35, couple of 35 joules, and you have the rate plot there. And you have the ventricular all over the place. You have fast, you have very irregular ventricular cycle length. And then if you see the EGMs actually of one of those events, you notice that actually the patient has been in silence all the time. These are inappropriate shocks. And these are nothing but noise, the high-pitched noise, that lead-related noise that we just spoke about. And if you had the secure sense or the lead integrity warning, you could have avoided those inappropriate shocks. Now this, again, I think Suchit spoke about, this is a T-wave oversensing. T-wave oversensing is not something which is new. It has been always there. It is always necessary, but it's very intuitive the way T-wave oversensing is evolving now. Earlier, it was T-wave oversensing was all about blinding the device to T-waves and trying to make the device blind to a certain voltage below which they will not see, and that's likely to be T-wave. But now devices are thinking more like humans. They are being they are use the signals, not only the amplitude, but the frequency content, the slew rate of the signals, and the pattern, the relationship with the previous, so RT and TR relationship, to determine whether the V-sense, the so-called V-sense is actually a T-wave or an R-wave. It doesn't actually completely blind the device. It actually helps the device to detect T-waves and then take a call on what is to be done. Now, this is an illustration. 6 ventricular events, whether it's an R wave or a T wave, which is decided by the device, is considered to be a window. Now, the window is either a T wave oversensed one, or it is not. Now, how does the device understand or make that decision? The device makes that decision whether it's a T wave or an R wave based on what we just saw, the amplitude, the slew, the frequency, everything. And notice at the bottom, you see it's TS, so tachycardia is being detected. But what is overriding it is the device is also at the same time analyzing the individual signals and then calling it either an R wave or an T wave, and most of it is accurate, as you can see. And it keeps looking at these 6 ventricular events windows, and there are about 20 windows that there is an analysis of 20 windows once the tachycardia has started to be detected. And if out of those 20 windows, 4 or more windows indicate that there is T-wave oversensing based on this, then the therapy is withheld. And that's called a T-wave discrimination or T-wave oversensing. Now, this is not an absolute one, as you can see. It also allows at the same time, it doesn't say that often you will have therapy withheld in patients who actually need them, because you can have ventricular tachycardia also having T-wave oversensing. So it allows, it goes into the odds where tachycardia is more likely to be pseudo tachycardia or T-wave oversense one, and it is more likely to be withheld. The therapy is to be withheld there. So again, it's programmable. You can program the T-wave sensing algorithm here. And again, this is one, you can see this is an illustration where T-wave oversensing was, you can see that actually the tachycardia circulation is being sensed, FS being there in the marker channel all through, but at the same time, what is overriding it is the T-wave oversensing, which is right below, and then therapy is actually being. So in a nutshell, the device quickly goes through T-wave discrimination and then noise discrimination, and if everything is negative, then the device goes about doing its job about delivering therapies for the tachycardia on their merit. Now, reducing, remember, when we implant ICDs, we all think all about shocks, and it's not all about shocks. Remember, ICDs have an equally, if not equally potent, but the potent arm with ATPs or anti-tachycardia pacing is unfortunately often underrated or underestimated. But as you can see, about 3/4 of episodes of so-called VF episodes are actually stable or fast ventricular tachycardias, and majority of them, as noted here, with the right ATPs programmed, can be successfully dealt with through ATPs, which is a much better way or much painless way of dealing with these arrhythmias. Biotronic has a very intuitive, intelligent approach to this. Well, they actually have, let's say you have 4 ATPs programmed for a VT, and you have 1, 2, 3, and 4. In one event, when the device encounters that actually the second run of ATP successfully dealt with the arrhythmia or restored sinus rhythm, next time what happens is the sequence is rearranged. So the run of ATP actually was successful is now provided first. So 2 goes in front, and the ATP 3 and 4 follow, and 1 is put to the end. And second time, suppose the tachycardia ATP 4 was successful. Now 4 is put to the front and followed by 2, and then it basically keeps jumbling with the ATPs depending on which was the most successful ATP or which was the successful ATP in the previous attempt. So that's how it tends to play with the ATPs and try to bring out the best through the ATPs. Now again, we are all familiar with this. We always had ATPs during charging, but we also now have ATPs during charging, before charging, and during charging when you have ventricular fibrillations redetected, and which is something which is programmable, and it's something which often helps avoiding shocks sometimes. So is inappropriate shock the only worry? Like I said, inappropriate shocks are a big worry, but sometimes you have the opposite. You have unstable ventricular arrhythmias which happen, and this is a very unfortunate situation where actually, despite ICD being there is a long delay in detecting an arrhythmia, which is very dangerous, which can be dangerous, and sometimes they're actually completely missed. That could be because of a combination of toggling between, now we have all these RIT and other trials. So the zones have been set a little long and higher zones, longer detection intervals. With all these, there is a bit of toggling intermittently. There is toggling between various program zones, and ultimately neither of the program zones is satisfied, and the device just keeps hanging. And often in unstable arrhythmias, you often have these R waves which are undersensed. There is not enough electrical activity in the near field channel, which leads to such delays. So long detection intervals and these this data, is it empirical and good for everybody? Yes, probably as a generic programming, it is to be done, but it's in some situations, as it is noted in this trial, in some situations, because of complex interactions of these programs and device specific algorithms, some patients have actually genuine therapy which would have been helpful has been held and can prevent therapy of VF. Now these are a couple of examples. As you can see, there is a significant delay in device detection, and on the left side you have a very long tachycardia. It's a rapid tachycardia, mind you. And because of this evidence, the zone was programmed very high. So the VF was programmed very high, and the device kept saying yes, 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 when the tachycardia actually needed therapy. And on the right side, you have again the same problem. You have a tachycardia after an ATP, it has slowed down significantly, and again, it's
Norman,
not.
you can, yeah, a little bit, quickly finish
Sir?
the presentation. Yeah.
Sorry, sir.
So you can a little bit. Can be little quick and.
Yeah. So there are a couple of examples where therapies can be delayed. So the common reasons why we have delay in therapies because inappropriately now programmed zones are very high, and then you have long detection interval. Of course, there is enough data for that, but sometimes these can cause issues. Intermediate undersensing, which can happen because during unstable arrhythmias, especially polymorphic and ventricular fibrillations. You have delay in device detection also, because sometimes you have unpinned events and the device itself confused as to where to pin the event, and that can prolong the detection and can cause a bit of delay in the diagnosis. Arrhythmia misclassification, and sometimes false episode termination, again, which is a manifestation of undersensing. Now, again, an intelligent counter to this is VF therapy assurance, which is a proprietary algorithm from Abbott, which is there in their high-end devices, where this is primarily designed to identify an undersensed, unstable ventricular arrhythmia, typically a ventricular fibrillation. And it actually takes a poor far field sensing on the discrimination channel at strategic important times and to detect and deliver this particular therapy. Now, what I'm saying is on the bottom strip, you can see there is, on the left side, you have good far field sensing. And this is where a conventional therapy would go on, and VF therapy assurance will not be called into service. But on the right side, you have poor far field sensing, and that can often lead to delay in diagnosis, and that is where VFTA will come in handy. How does it work? The algorithm uses a discrimination, the far field channel, to see whether there is undersensing, and once there is undersensing, the device actually becomes more proactive because VFTA is now triggered, and it automatically changes the parameters to some parameters, assuming that there is an unstable arrhythmia, to a much more proactive one. So usually those parameter changes are, a device becomes a single therapy zone. The VF detected rate, or the detection rate for VF is actually lowered, and the VF is now detected at a lower rate. Obviously, the device is becoming more aggressive. The number again needed to detect those that VF is decreased to 6, and the end of episode again becomes much more robust. And permanently, the previous programmed zone therapies for VF will be delivered. So this is VF therapy, which is now. So the checkpoints, what are those checkpoints where VF therapy, whenever it's available, is checked in? Is number one at detection, number two at 45 beats after the first fast interval which is detected, and then third is redetection, and fourth is within 15 cycles of so-called end of episode. I'll just brief you in next 4 slides as to how it works. Now notice this is the initial detection. And you will see that most likely what happens is when you have undersensing and unstable arrhythmia, you may have the device calling off the arrhythmia as to return to sinus prematurely, calling it sinus, because signals are poor both in near field and far field. So that is where the VF therapy assurance kicks in, and it basically looks at the far field. When it is there, it looks at the far field and says that sees the very low amplitude signals, and the pauses. When there are pauses like this, the VF therapy assurance is triggered, and once it is triggered, the changes in program, like I said in the previous slide, are kicked in, and the VF is appropriately detected and treated. Again, after
the last slide, please.
Yeah, so the same thing, sir. Every time there is a possibility of undersensing and the arrhythmia being missed, the VFTA basically checks in and makes it much more proactive, and the device delivers treats it like a VF and delivers a cardioversion. So this is an example. This is the last slide. So in the example of VFTA, where you have a ventricular fibrillation, notice on the marker channel you have gross undersensing, and there is a delay in picking up VF. By this time, it would have become clinically serious. So VFTA is triggered here because of undersensing in the far field, the discriminator channel. And once it is triggered, there is immediate, its device swings into action and delivers therapy And you can see that the patient actually receives life-saving defibrillation care, and the episode ends here. So to conclude, we know that the profound effect of shocks on patients' quality of life. Inappropriate shocks are certainly unacceptable in modern day and age with this sophisticated ICDs. These algorithms can significantly help us reduce inappropriate shocks rather whenever it's not necessary. Lead integrity alerts are pretty much a part of every device company now, and with remote transmission, they have noise. There's a very sophisticated noise discrimination which reduces inappropriate shocks. Some powerful algorithms, like I said, PF therapy assurance rather, it can detect unstable and undersensed ventricular tachycardia, especially fibrillations, and can be used in the right candidates, not for everybody. Anti-tachycardia pacing is a much underutilized tool and has a much better way of treating ventricular tachycardias and should be used proactively. Thank you for the opportunity.
Thank you, Somen, for this exhaustive and very informative session. Just one question, I think many non-EP cardiologists would like to know. That is, for these ICDs, when you go for an MRI, what are the things or what are the programming changes that should be done?
Sorry, sir, I lost you for a couple of seconds, sir. I couldn't hear you.
Go for an MRI. What are the changes or any programming things that should be done?
Yeah, great question, sir. I mean, first of all, of course, the device needs to be MRI compatible. And of course, immediately post-implantation, the next 8 to 12 weeks, we cannot get an MRI done. But if most of the times, if the patient if the patient is ICD pacing dependent, the pacing needs to be asynchronous immediately, because we can't, the MRI can interfere with the pacing and patients may get, the pacing may get inhibited. The tachycardias, also detection needs to be switched off. Now, all these modern devices have an MRI mode. So when you just put the MRI mode on, the pacing becomes asynchronous and the tachycardia detection goes off. So inside the MRI console, the device is not, pacing is not going to be affected, and the device is not going to pick up external noise, electromagnetic noise, and deliver inappropriate therapies when the patient is undergoing an MRI. I think this is in a nutshell what we need to do.
Thank you.
But these are all pretty much there as a part of a standard MRI mode.
Thank you, Surandan. Thank you, Dr. Soman. It was a brilliant.
Thank you, Dr. Dilip.
Thank you. So we move on to the next presentation, subcutaneous ICD and prevention of SCD, Dr. N.K. Mahesh. Dr. Nayak is chairing the session, and Dr. Tapobrata Dey is moderator. Over to Dr. Nayak, sir.
Thank you, Dilip. Thank you. Thank you. So good evening to all of our viewers and participants. So let's go to start this session. Please start.
Dr. Mahesh.
Our presenter is there, Dr. Dilip.
Yes,
Let's start this.
He's sharing the screen, yes.
Yeah, Dr. Mahesh, I think you have to unmute. We're not hearing your voice.
Yeah, thank you. Am I audible now?
Yeah.
My screen visible?
Quite well. Yeah, of course.
Yeah, thank you. At the outset, I'd like to thank Dr. Majumdar for this, Dr. Dilip for this opportunity. Great honor to be among very well read and technically very sound people. I was listening to Dr. Majumdar, Dr. Soman, Dr. Lawrence, Dr. Pandey. Excellent talks. And I learned a lot from this. And I'll just come to my topic. Please make sure that I stick to the time. So subcutaneous ICD and prevention of SCD is the topic given to me. This is from the south of India. Greetings from Kerala. This is a small institute in a village. So what is the heart and vasculature remains untouched. That's why subcutaneous ICD is so important. So why did the concept of subcutaneous ICD come about? It's because of the complications of the transvenous ICD. They are pneumothorax in point. This is yellow is female, blue is male. Hematoma, cardiac tamponade, mechanical complication, device-related infection, post-index ICD, and any complications. So 5.94 is, and the cardiac tamponade and mechanical complications are statistically very significant. Hence, people thought, why not an ICD outside the venous system?
So the study started way back in 2004, where there was a configuration determination study and the proof of concept in 78 patients, then defibrillation threshold, then initial chronic human validation study, then the CE for proof of concept, safety, performance, safety, efficacy. Basically, I want to tell you that a hell of a lot of work has gone in to get this thing into the market, like it does for any other device or any other drug. So for first optimal sensing configuration, a lot of things were thought about. This B and D, C were obviously discarded because it looks like a normal ICD, and A and D were thought about, and then we eventually settled down for A as the most optimal positioning of the lead and the CAN. So we have a CAN here. We have A top B, and these are the two lead points. You have A primary is B to CAN, then you have alternate A to B, and secondary is A to CAN. So you have three possible shock vectors. You can give 5 shocks per episode at 80 joules. Up to 128 seconds of ECG can be stored, and storage up to 44 episodes. The standard polarity shock is this, and reverse polarity shock also can be done. Once the system, like Dr. Saumen said, once the system identifies which is the shock vector most suited for this patient, it sticks to that shock vector as far as possible. So why is it so different from the normal ICD? Second thing is rhythm discrimination. So it analyzes the rhythm and identify, okay, this is the normal rhythm of this patient. This is the normal morphology of this patient. So the tachycardias can be easily identified to prevent inappropriate shocks. And here we have the surface ECG. See the difference. The surface ECG is almost like the subcutaneous ICD ECG. It's inverted, but you can see that the QRS is broad, and the nitty-gritty of the T wave and the QRS can be picked up. You see the intracardiac, it comes in as lines. That could be one of the reasons why the sensitivity, specifically of supraventricular tachycardia, being oversensed in an intracardiac ICD, is probably because of the sensing is done by straight lines and not by the ECG like a surface ECG. So the only thing you should understand is that to prevent T wave oversensing, you have to have a template, and into the template, the T wave and the QRS should fit in. So once you have identified the template and the T wave and the QRS can be fit in, this is to be done at resting and at slightly after some exercise. And if both the things that there is a template in which the QRS and the T wave fits in, then the patient can be taken. Otherwise, patient is not suitable for subcutaneous ICD. Now it's got 3 ranges. One is below 200, where it identifies with the morphology. Only the morphology is identified. And if the height is less than 0.5 also, it is identified as VF and shock. Between 200 to 220, above 220, no questions asked, you get a shock. Between 200 to 220, the morphology is analyzed extremely, and compared to the original morphology, identified as SVT or a VT, and then only shock. So it's got 3 ranges. Below 200, pure morphology, 200 to 220, morphology and the rate is being considered, and above 220, you get a shock, whatever be your morphology. So once you have dual zone programming, that's morphology and the rate programming, the oversensing has come down to 54%, and oversensing of SVT has come down by 74%. This is very, very important because SVT is the most oversensed thing in normal intracardiac ICD. So this is how the time to therapy. Another point is time to therapy. Once it detects, it is less than 12 seconds in 9.6% of the cases, where probably the rate was straight away to begin with about 220. The average is about 55.6% of the cases, it is 12 to 15 seconds. So it gives some time for the rhythm to either behave itself and go back to normal sinus rhythm, or abort itself. If it doesn't, only it shocks. So 88% of the shocks happen within less than 18 seconds, and 95% of the shock happen less than 21 seconds. So it is not that the first 3 beats are picked up and the shock is delivered. There is some time delay for morphology analysis and the rate analysis before the shock gets delivered. And this is the safety mechanism. The high HS drop I and the ejection fraction, HS drop I has been remaining dead constant, shows there is no cardiac damage. Unlike intracardiac ICD lead, where the shock is delivered from the tip, it is delivered around the heart, so there is no area of damage to the heart. So after the refinements of subcutaneous ICD detection algorithms, subcutaneous ICD is excellent at appropriately identifying AF and SVT in the conditional zone. A morphology-based algorithm demonstrated the bench instinct to decrease the T wave oversensing by as much as 40%. So this is how it stands before the new algorithms of this thing. 5.3% there was cardiac oversensing, discrimination error, non-cardiac oversensing, and SVT above the shock zone 1.5, which will remain forever. This was the 8.1% was the of the inappropriate shock therapy rate before the algorithms were put in. And then we had a morphology based algorithm. When it is switched off, you find that SVT gets shocked. When it is switched on, you find that if it is SVT, it is identified as SVT and not shocked. And once the morphology based and algorithms are put in place, the SMR8 and the smart pass with generation 3, it shows that the total number of inappropriate shocks came down to 3.8% as compared to 4.4% and 2.5% from the intracardiac ICDs. So what are the advantages? The absence of lead is the biggest advantage in the venous circulation. Patients who have no venous access, you have no options to put in a subcutaneous ICD. Limited risk of vascular injury or pneumothorax. Pocket infections can occur, but can be more successfully treated with antibiotics because there is no intracardiac leads in this case. Explanting is much easier if there is a requirement. Young patients with high lead failure rate because of extreme physical activity, they can, even if they have, the chances of lead fracture are less. Even if it fractures, it is easier to change. Simplified implant procedure. For the second and the third implant, we could finish in as much as 40 to 45 minutes. And cosmetic advantages, especially for ladies, because it goes inside below the axilla, and the ICD is not usually seen as a bulge on the chest. The device is well tolerated, and the lack of apparent myocardial damage, despite a greater shock intensity, because the shock is distributed unevenly, there is no troponin elevation. So when do I use SID-CD as a first choice? Pediatric and grown-up congenital heart disease patients with no venous access, we have no options. Acquired stenosis or obstruction of central veins. Previous endocarditis or device infection, it's not good to put another one in the vein. High risk of infection patients, endovascular risk, dialysis, immunodeficiency, cancer, and chronic indwelling catheter requirements. Patients candidates to cardiac transplantation. Reasonable choice in young patients with active lifestyle and lifelong expectancy because change of lead and the pacemaker is much easier. Inherited genetic arrhythmogenic syndrome, Brugada, long and short QT and early repolarization where there is no requirement for pacing post-shock. Prosthetic heart valves because of infection, and women because of cosmetic issue. Contraindications, if the pre-implant screening fails, you cannot put. Symptomatic bradycardia, where there is indication for CRT and recurrent sustained monomorphic VT treatable with ATP, then you should not use it. And anatomic characteristics, if you have a very bad chest wall, you cannot use it. So this is how the distribution goes. If you have a high risk patient with the risk of lead complications, high infection risk, patients with no pacing indication are the ones which are coming into class 1 and class 2A. And the other end, you have bradycardia patient who requires pacing, a CRTD indication, and need for ATP. All the others can be distributed in between. And this gives you a fair idea of where your patient is. So post-approval, post-market approval study shows complication rate is 3.7%, 98.7% success, and 52.4 patients preferred this because of the ease of carrying it around. So for the future is that chronic communication from the subcutaneous ICD to a leadless pacemaker for ATP delivery by the leadless pacemaker and post-shock pacing. If that is done, we will cover another 10% addition to this. I will come to the chart. So when do I think SID first? Is the first and only subcutaneous implanted defibrillator that leaves the heart and vasculature untouched. It's a solution for majority of the patients with risk of sudden cardiac arrest. It is no longer niche because a hell of a lot of procedures have been done, more than 1 lakh by now, and they have shown excellent results. Where does it stand in the recommendation? US recommends class 1 in patients with high risk for infection, where CRTD is not indicated. Class 2A, where there is an indication for ICD and the patient prefers this ICD in AHA and in the European Society guidelines, patient's choice. So when is the question asked is a transvenous ICD required? Yes, subcutaneous ICD. Which one? 60% of the patients go for subcutaneous ICD. What are the 40% who doesn't fit into it? Sorry, 40% of the patients go for subcutaneous ICD. Not suitable ECG, that means the morphology doesn't fit in. There is a clear-cut CRT indication. These are the 50% which we may not be able to convert into subcutaneous ICD. Pacing indication and ATP for slow maintained VT. What we find is that if we can combine it with probably a leadless pacemaker, we may still be able to get away with it. So subcutaneous ICD is a viable option for sudden cardiac death prevention in patients without pacemaker need. There is no need of a bradycardia pacing backup. SICD can successfully convert VT-VF in almost all patients with both primary and secondary prevention and regardless of the indication. The benefits of avoiding the use of intracardiac leads must be weighed against the potential need for pacing. The requirement for pacing and requirement for ATP and the requirement for CRT are the things which needs to be addressed for progression of further expanding the horizons of a subcutaneous ICD. This is the first case I had done. So the indication being this is a previously existing ICD, the veins are gone, the ICD lead couldn't be extracted, and this patient had recurrent VT. So we put him as a post-CABG patient. This is how the lead looks like. This is A, this is B, and this is the can that is used, and these are the ports. And this has been now 3 years. He's been doing very well. I had a couple of shocks, but has recovered from all of them all the time. Thank you.
Good. Excellent presentation, Dr. Mahesh. Basically, the shock is a huge shock to the patient. So does the patient complain that it's a huge jolt he gets? The patient are afraid of these big shocks.
Yeah. So
72 shock you are giving.
Yeah. The prolongation, the shock is not delivered immediately. It's take about 8 to 12 seconds before the shock gets delivered. 8 to 12 seconds, some of them be unconscious, some of them are already so discomforted that once they get the shock, they're not upset about it. But they are upset about the post-shock pacing. That's a little uncomfortable because you have regained the sinus rhythm and it takes a couple of beats before the ICD senses that, okay, this guy's got his own rhythm and there is some pacing which is little violent. So shock is definitely violent, but so far the person who got the shock didn't mind getting the shock because he was very extremely uncomfortable because of the VT and or the VF during the shock period. It is more disturbing than intracardiac ICD. But the damage to the heart is much less.
Thank you, Dr. Nayak. Thank you, Dr. Mahesh. It was in fact,
thank you, Dr. Dilip. Thank you.
Thank you.
In the interest of time, we have to move on. So debates will be, going on. We want to see ICD as a kind of anti-tachycardia pacing device. So kind of subcutaneous ICD going directly to shock. So there are different school of thoughts, and basically this ICD has got some positives, but some negatives as well. So let's see how the future unfolds. We move on with the next presentation, moving into CSP, and the presentation is going to be by Dr. Kush Bhagat. He will be showing live in-box conduction stream pacing, and it will be interesting to see if it can be shown in 10 minutes. And the chairperson of this session is Dr. Alok Singh, and the moderator is Dr. Mainak Mukhopadhyay.
I invite straight to Dr. Bhagat for his presentation because we are running short of time.
Yeah. So a very good evening to all of you, and I would like to thank Dr. Dilip for giving me an opportunity. So am I audible and are my slides visible?
Yeah, your slides are visible.
Perfect. So I'll try to present two cases if possible. The first one is the left bundle branch pacing area case. So he was a 65 years old male, diabetic, and he underwent angioplasty to LED in 2021. And he had severe LV dysfunction, EF was 25%, and he had 2:1 AV block, which was intrahazian and a history of recurrent syncope. So as far as guidelines are concerned, severe LV dysfunction, symptomatic 2:1 AV block, and history of angioplasty with sort of scarring in the distal LV territory. So he was an ideal candidate for CRT-D. But the problem was that there were financial issues with the patient, and I think he had only not much amount for CRT-D. So what was my strategy was to implant a dual chamber ICD, DF1 and 3830 lead, and use that as a CRT-D. So I'll discuss how I use that as CRT-D. But let's come to the point of how I implanted the left bundle branch lead. So this was a baseline ECG. We can see this LBBB sort of fragmented QRS and 2:1 AV block. And when I did the EP study, and this was clearly A, H, and after H there was no V, so it was an intrahazian block. And coming to the pre-plant consideration for left bundle branch area pacing, so it's always better to do an echocardiogram beforehand, always better. It gives to give us two ideas. First, the septal thickness, what's the basal septal thickness, and second, about the RA, RV, and the TR. So it will help us before the procedure. It will help us in deciding a lot of things, how deep we have to go inside the septum. Also, to place a temporary pacemaker lead if needed, and I prefer to do it with the EP system, and if not possible, then at least 12 lead ECG. Coming to the implant steps, I think we have a talk on the various types of catheters and sheets and leads which are available with us, but still we use 330 Medtronic lead, 315 His sheet, and I will not discuss in detail about this sheet because I think there's a presentation, and this was the 315 His sheet and the 3830 MRI compatible lead. Just to mention that this is 9 millimeter, this is 1.8 millimeter distance, and from here to here is 9 millimeters. So the distance, total distance is 10.8 millimeters. So this distance is important in guiding us how deep we have to go inside the septum. Again, the EP connections, I always try to put a His catheter. This is RO, LO, the temporary pacemaker is in place, the His catheter is in place, and always try to prepare the sheet. So this is the 315 His sheet, and prepare the sheet using a heparinized line, because there's a tendency of formation of the clot, and the preparation of the sheet is like conventional sheet preparation, and try to insert this sheet inside that P-Levy sheet. So use a 7-trench P-Levy sheet, and then I always use the P-Levy sheet, and inside that P-Levy sheet, I insert this 315 His sheet using a long wire. And my first strategy is always His bundle pacing. And after inserting the sheet, I try to locate I try to place the lead and the sheet at the His bundle area, and how to approach the left bundle branch area. So we already have a His catheter in place, and this is our His catheter in place. Come to the RO view. This is sort of RO view, and make a line from the tip of the catheter to the apex, and our sheet should be approx 1 to 2 centimeters below the His bundle catheter in the RO view. And in LO view, this sheet should be as perpendicular to the septum as possible, because if it is not perpendicular to the septum, then screwing the lead is not going to be an easy procedure. And yes, you have to give a slight counterclockwise rotation on the sheet to make it perpendicular to the septum. We always do the testing in a unipolar manner. And now coming to the site, what is the ideal site of on the right side of the septum where we have to screw the lead? So this was my first site. So we can see a very good notching in lead V1. So if we get a very good notch, then also we have to look for other signs, whether that is a site of screwing or not, because many times the notch we will get, and when we screw the lead, then we will not get the left bundle capture, which happened here. So we can see that lead 2 and 3 both are negative. So this lead AVR is slightly positive, negative positive, and AVR is positive, but lead 2, 3 is predominantly negative. Although we are getting a fragmentation or a notching in the QRS in lead V1. So I tried to give 10 turns, but there was no left bundle capture. Then second site I chose. So this was again notching in lead V1, but in this case, the lead 2 was clearly positive, lead 3 was negative. Again, AVR was negative and AVR was positive. So I had lead 2 through discordance, AVR discordance, and notching in lead V1, so which is an ideal. That is an ideal site of at the right side of the septum, where we have to screw the lead and go inside the left side of the septum to capture the left bundle area. 2-3 discordance is very, very important. Again, AVR is also important, and many times you will you will get 2-3 discordance, AVR discordance, but you will not get a very good notch in lead V1. Still, we can screw the lead at that site, because it's not always you will get a notching in lead V1 in all the cases. So keep on screwing, and we can see the notch is moving up, and gave one more turn, and the notch has moved up. So we look at the notching in lead V1, and we see a terminal R wave in lead V1, and the QRS has definitely become narrow. And I'll come to the next slide. This is terminal R wave in lead V1, suggestive of left bundle branch capture. And coming to the LV activation time, So again, so how we come to know that? So suppose in this step, we are getting a terminal R wave, we are getting a QR pattern, but how we will come to know whether we have to screw in more or not? So that depends on the LV activation time. LV activation time is nothing, just the duration between the stimulus to the peak of the R wave, which should be ideally less than 80-85 milliseconds. In our case, it was 65 milliseconds. But again, the important thing is that you have to pace at 1 volt and at 5 volt. And if at pacing at 1 volt and 5 volt, there is no difference in the LV activation time, then probably that is the site where you don't have to, I mean, after that, you don't have to screw much. But if on pacing at high output, there is a marked, duration of LVAC decreases, then you have to probably give half a turn or 1 turn more to reach the left bundle branch area. And as far as impedance is concerned, again, watching the impedance is very, very important, because initial impedance will rise with screwing and then it will decrease when the lead is at the left side of the septum. But we have to make sure that there is no marked decrease in the impedance. And as far as value is concerned, then definitely the impedance should not be less than 500 ohms. And if it is less than 500 ohms, or there's a marked decline in the impedance, then that means probably we have entered in the left side of the septum, in the left ventricle, and our impedance will decrease and pacing threshold will increase. That means you have to take out the lead. You don't have to just pull the lead. You have to take out the lead, choose a new site, and then screw it again. Coming to selective and non-selective left bundle branch capture. And so in non-selective left bundle, so coming to the non-selective left bundle branch capture, so this is the pacing spike, and the QRS is, there's no discrete interval between the pacing spike and the QRS. So it's a direct capture of the ventricle. As compared to this, in which we can see a discrete interval between the pacing spike and the QRS. So this is selective left bundle branch capture. This is non-selective left bundle branch capture. Sheath angiogram, it's not compulsory to do sheath angiogram, but yes, it gives us a lot of help, because we know the exact depth of the lead. And also it is very important that you give sheath angiogram and try to pull the sheath a little back before giving the sheath angiogram, because otherwise I've seen cases of septal hematoma formation if we give the contrast and the sheath is deep inside the septum. And secondly, again, as I said, that you have to use heparinized line to flush the sheath. The reason is this only, because a lot of times when the procedure takes time, then actually there is clot formation in the sheath. And if there is a clot of thrombus formation in the sheath, then better not to go for sheath angiogram. Slitting the lead is a very important step actually, because we know that it's a lumen least lead, and if we don't give adequate lead slack, then it's very, very difficult to push the lead. So just one tip, that when we slit the sheath, better to pull the sheath as far as possible from the lead, so that we can give, basically we have to give adequate slack to the lead, because pulling the lead is easy, but pushing the lead is not so easy. As far as pacing parameters are concerned, so we got a narrow QRS, LVAC was good, threshold was good, and R wave was good. And this was the final ECG. We can see a very, very narrow QRS with a terminal R wave, QR pattern. And I think probably the QRS was around 80 milliseconds. So this was the left bundle lead implantation. So again, I told that I'm using it as I used a dual chamber ICD, and I was using it as a CRBD. So I implanted the conventional RA screen lead and RV defib lead at the septum. Now, how did I get the connection? So I used a DF1 dual chamber ICD, in which we have, this is the atrial port, this is the ventricle sense and pace port, and this is, the SVC coil and the RV coil. So this was the lead basically. This was the lead. The RV coil, the SVC coil was placed at the respective ports, and the atrial lead was placed at the respective port, and the left bundle branch lead which we implanted, we placed it at the RV sense and pace port, and the ICD RV pacing and sensing lead was capped. So this was thing which was done. So basically the mode was, it was like a dual chamber pacemaker, in which we had a sense and left bundle branch area paced, and the RV defib lead was used for shock purpose, and this was the final placement of the lead. and this is the atrial lead, the left bundle lead, and the RB defib. And we always try to use a single coil, but at that time there was no single coil available, so I used a dual coil. The baseline ECG and the paced ECG just for comparison with a very narrow QRS. So this was my first case, and I think if I have time, then I can take just 3 minutes to present another case of his bundle pacing. So fine. So he was a young male, 73 years old male, and he had sinus node dysfunction with significant pause and halter. So basically, he had 6 sinus syndrome, and he underwent PTCA and CABG early 90s. He had mild LV dysfunction. EF was around 45 to 50%. Again, as far as guidelines are concerned, he was class 1, class 2A recommendation for his physiological pacing. And we used Agilus Hispro sheet because we tried to use Agilus Hispro sheet if we are planning for a His bundle pacing, because this is a very good sheet because it's a deflectable sheet, and we can place our sheet exactly at the area of concern. So this is the His catheter. This is the sheet which is going inside, and this is the sheet we have placed very near to the His catheter. This is the AP view, and now we have placed the lead at the His bundle area. So coming to the signals. So this Agilus Hispro sheet, it itself can give signal. So this is the advantage of this sheet, that it can give signal. There's no need to take the lead. So this was the His signal on the Agilus Hispro sheet. We can clearly see A wave, H and V. A very beautiful His signal which we are seeing in the Agilus Hispro sheet. So after placing the sheet at the adequate position, take the lead and just insert the lead in the Hispro sheet. So as far as possible, I try to place our lead in the distal His position, which we can come to know with the help of the A and the B signal. If the V is large, A is small, we are getting a His signal. So this is the point we have to screw the lead, screw the lead, and this was the EG, this was the ECG, and this was the pacemaker EGM A, H, and V. And after screwing the lead, the sheet was plated in the same manner as we slid the sheet, and the atrial lead was implanted. So this was the position of the atrial lead and the His bundle lead. So this was the ECG which we got after pacing at 7.5 volt. So at 7.5 volt, we are getting a non-selective His bundle capture. At 1.5 volt, we got a selective His bundle capture. Still, we are getting a His bundle capture at 1.5 volt. And at 1 volt, so still pacing was there. But we can see the QRS. The QRS is completely different. So basically, we are getting RV septal capture at 1 volt. So the threshold for His bundle capture was 1.5 volt, and the threshold for the RV septal capture was around 1 volt. So this is important because we have to have a His bundle capture, not RV septal capture, to improve the LV functions. So this was unipolar, and this was the final position of the lead in AP and in LOT. So this was the echocardiographic image. So we can see the lead very close to the annulus. So this is our lead, and we can see the lead. It is the basically 4-chamber view, very close to the annulus. We can see the dilated LV and mild LV dysfunction. And this was the X-ray. And with this, I would like to end my presentation. So it was, I did a case, but the recording the case was not so easy in this physiological pacing. Most of the times we require EGMs, ECGs, and the pacemaker, fluoro and cement. So any questions I would love to answer.
I think Dr. Bhagat have very nicely shown the conduction system pacing. I will ask to fellow moderator, if there is any comment.
Yes, sir. Even after getting a good ECG parameters of proper lead placement, do you always get LVAT less than 70 milliseconds? Because we have done quite a few cases, and sometimes we are getting LVAT something just within 70 to 80 milliseconds. So even in that case, would you like to accept that lead position, or what is your expert comment on that?
So basically, LVAT is important, and any value less than 80 milliseconds is very good enough. The important thing is to get a narrow QRS and to get a LVAT which is fixed at 5 volt and 1 volt. So if you're getting a terminal R wave in lead V1, that means you have captured the left bundle branch area. And by default, if you have captured the left bundle branch area, you will definitely get a narrow LVAT, undoubtedly. Any value less than 80 is fine. But yes, in cases of ischemic cardiomyopathy, if you're doing a case of CRT, left bundle branch CRT or hot CRT or anything like that, then definitely you can get a higher LVAT. In that case, because most of the times the LV will be scarred and the lateral wall will be scarred. But most of the times you get an LVAT less than 80 milliseconds. High output, low output, fixed LVAT, narrow QRS, terminal RBB in deep even, you are done.
Thank you, Dr. Mahesh, Dr. Mainak, and Dr. Alok. And I think there will be some repetitions. Dr. Shanmuga will speak next on CSP enthusiasm building or fading, recent evidence and trends. And Avinash is going to show some ECGs and EKGs, intracardiac EGMs for conduction system pacing, and I will show some cases. So Dr. Shanmuga, your presentation is next, and I invite Dr. Sunandan Sikdar as chair and Dr. Umesh Kohli for moderating the session.
Thank you, sir. At the outset, I'd like to thank Dilip sir for giving me this opportunity. This is my second, in fact, third device update in Kolkata. This time we have joined as virtual faculty. So I was assigned the topic of talking about the conduction system pacing's recent evidence and trends. Of course, we know what is the definition of conduction system pacing. It is nothing but the direct capture of cardiac conduction system by placing the lead either in the wrist bundle, preferably in the distal wrist bundle region, or in the left bundle branch area. Dr. Kush has elegantly described the method of implantation of both the wrist bundle and left bundle branch pacing. So I would probably go directly into the clinical implications and the recent trends and clinical evidences which is currently available for conduction system pacing. Of course, there are two important uses of doing conduction system pacing. One is the management of routine symptomatic bradyarrhythmia cases as an alternative for RV pacing, and the second one is an alternative for cardiac resynchronization therapy. Of course, when you are going to map the HIS elegantly, as Dr. Kush has done, you'll be able to regenerate a normal appearing QRS in either a sick sinus syndrome patient with an associated AV nodal disease, or in patients with an AV block, whether it can be an AV nodal block or in the HIS bundle level or in the infra-ACM block. The QRS will be absolutely normal if you're going to bypass the disease segment. And we know that a lot of limitations of HIS bundle pacing, the threshold will be high, a lot of lead disturbances tend to occur, at least 10 to 20% of the patient needs lead revision during follow-up. So left bundle branch pacing was suggested as an alternative by Dr. Huang, and he has classically described the gentle screw-in movement, gentle rotations, step-by-step approach, watching the notch to ascend up to form an R wave. So that is a classical way how we usually started doing left bundle branch pacing. But what we have started doing is giving rapid rotations, generating PVCs. The rapid rotation of the lead usually generate PVCs. So we usually monitor the PVCs, look for the morphology of PVCs. Once the PVC shows a QR pattern, we'll stop giving further rotation. We'll analyze for the left bundle branch capture. And we're surprised to see that this PVC guided, or what we have labeled a template beat guided approach, has conferred minimal myocardial injury and it avoids septal perforation. Of course, be it a sinus node dysfunction with an associated AV nodal disease or an AV nodal block or an HIS bundle disease, when you are going to pace the proximal left bundle, many times you'll be bypassing the disease segment, so you'll be able to regenerate a normal appearing QRS. So clinical evidence is as far as available. So data started pouring in from 2019. We have published our data on of initial 100 cases last year, where we could show that the success rate was close to 94%. We paid in 6 cases. The average lead depth was around 9.6 millimeter. At the end of 12 months follow-up, the pacing parameters remain stable. Needless to say, when you are capturing the cardiac conduction system, the ejection fraction is expected to go up, as seen in our case, where it increased from 44 to 53%. So not only in general population, even in octogenarians, we have shown that the procedure is relatively safe and there is not much of complications, even in those patients who are aged more than 80 years. Of course, the most important thing which was presented in this year's late-breaking clinical trial was the comparison of left bundle branch pacing with an RV pacing for patients who are required pacemaker for symptomatic bradyarrhythmia. So this was a very important study done by Dr. Parikshit and Dr. Kugulenji Vijayaraman, so that they have shown that left bundle branch pacing is associated with an improved clinical outcomes in terms of reducing the primary composite endpoints, including all-cause mortality. And the clinical results were very much obvious in those patients who require high ventricular pacing burden. So this is a very important landmark trial, which is going to be probably later replicated as a randomized control trial, which is going to show that probably even in routine bradyarrhythmia patients, if we are planning for a pacemaker, it's better to go for a conduction system pacing rather than a routine RV pacing. So second one, as an alternative for CRT. So though a lot of things have been discussed about the conduction system pacing as an alternative for CRT, the most important clinically visible thing which you're going to appreciate is the acute hemodynamic patient benefits. As early as 7 to 10 days, you can see a significant reduction in mitral regurgitation, significant improvement in LV ejection fraction, significant improvement in LV contractility. So all these things can be seen as early as 7 to 10 days after doing conduction system pacing. Of course, once your resynchronizing the heart by capturing the cardiac conduction system, definitely there will be an electrical synchrony, so there will be a synchronized contraction of all cardiac segments. Of course, this was later replicated in our international study where we could show that the left bundle branch pacing is an effective alternative for a biweek therapy, and we could show improvement in patients with an ischemic cardiomyopathy as well as in non-ischemic cardiomyopathy, and in those patients with the baseline LVV morphology and non-LVV morphology. So both the group of patients showed improvement in LV ejection fraction. Both the group of patients showed a significant LV remodeling, and they have significant reduction in NYHA functional class. So subsequently, Dr. Wang, who is considered as the father of left bundle branch pacing, has shown that in patients with a non-ischemic cardiomyopathy, almost 75% of the patient can have normalization of LV ejection fraction at the end of 12 months. This is a very important data because conventional IV therapy, though it produces excellent results in patients with a typical LVBP non-ischemic DCM, but normalization means that ejection fraction improvement of more than 50% at the end of 12 months. 75% of the patient is a huge number. So that favors probably a conduction system pacing over a biweek therapy. Of course, we have analyzed specific subset of patient we labeled it as an LVBP-induced cardiomyopathy, where LVBP alone is the sole culprit for producing cardiomyopathy. So we analyzed the data. We could show that LVBP is the sole reason for developing cardiomyopathy. We placed them in the left bundle branch area, and we could show that almost all patients showed normalization of ejection fraction at the end of 3 to 6 months. Of course, there are a certain group of patients who will not respond to biweek therapy. These include patients with a right bundle branch block with LV dysfunction, those with an abnormal QRS axis, and those with a mixed or peripheral conduction system basis. In RBBP patients, where in our cohort of 260 patients, which we have done in our hospital, almost 60 had a baseline RBBP morphology, out of which 14 had a LV dysfunction, which we defined as an EF of less than 50%. So we could show that the QRS duration, we could reduce it from 153 milliseconds to 180 milliseconds. And during follow-up of around 2 years, we could show that the LVEF improved from 36 to 56%. There was significant reduction in LV and diastolic diameter. So this is a very important thing because these are the patients whom the biweek therapy is going to offer minimal benefit, because we know that RBBP patients are poor candidates for cardiac resynchronization therapy by biweek devices. Another important group of patients for whom CRT is going to produce less response is those patients with an abnormal QRS axis. So we have analyzed those patients with a baseline LVV morphology. We divided into two groups, those with a normal axis, those with the left axis. We could see that almost 37% of the patient had an abnormal left axis at baseline. So after left bundle branch pacing, those with the normal axis, 93% had retained their axis and 7% developed left axis. And in those patients with the left axis, 75% had normalization of the QRS axis, and the remaining 25% had a persistent left axis deviation. But the most important thing which we could appreciate was, irrespective of the underlying axis, the patient responded well in terms of reduction in QRS duration, improvement in LV ejection fraction, and reduction in LV and diastolic diameter. So what we could conclude was, so left axis deviation in patients with a non-ischemic cardiomyopathy is not an unfavorable factor for a CRT by left bundle branch pacing. This is unlike your routine biweek therapy where it is going to produce less response as a CRT therapy. So this again is one step ahead for a left bundle branch pacing over biweek therapy. Of course, not all QRS can be narrowed down by our left bundle branch pacing. There are some areas where you will not be able to completely narrow down the QRS, like this case where there is a partial correction of left bundle branch block. So if you have to put one more lead in the left CS into the coronary sinus, we can fuse it together to have an optimized cardiac resynchronization therapy. So when you're going to club it together, which you are going to label it as a left bundle branch optimized cardiac resynchronization therapy, you'll be able to achieve a better resynchronization. So this was again this year's late-breaking clinical trial where we could show that when you're going to optimize the CRT with the CS lead, the response is much better as compared to a conventional biweek therapy. So in those areas where CRT by biweek therapy is going to offer less, these patients can be benefited by doing a conduction system pacing related cardiac resynchronization therapy. There are certain areas which are not being explored or not. The CRT is not going to give good results. So one such thing is the pacing-induced cardiomyopathy. This particular kid, 4 years old child, where there was a significant pacing-related LV dysfunction at the age of 4 years. The baby was weighing only 8 to 8.5 kg. So there was not much to offer for the baby. Planned for a cardiac transplant. So what we thought was we could do a left bundle branch pacing as a final rescue strategy. So surprisingly, we got a good QRS and the baby improved And the weight gained over a period of 4 or 5 months to 12.5 kg, and the EF even improved to 31%. There was no further episodes of heart failure hospitalization. Now I think it was almost 7 months after the procedure, the baby is relatively doing well. So of course, the advantages of CRT by left bundle branch, the left bundle branch spacing actually gives us an opportunity to use n number of leads for achieving a better resynchronization therapy. The first one, single lead CRT, where the patient has a baseline atrial fibrillation with the left bundle branch block. So what we have to do is just ablate the AV node, put a left bundle lead, and connect it to a single chamber pacemaker. Of course, this is what we are doing conventionally, a dual chamber pacemaker for a non-ischemic cardiomyopathy with left bundle branch block. So if it is completely corrected, you can just leave it the dual chamber pacemaker. If it is not completely corrected, then probably you may have to use a conventional triple chamber CRT device. In those patients with a non-ischemic ischemic cardiomyopathy are those patients with a significant intraventricular conduction defect, where our LVBP or a His bundle is not going to produce a complete normalization. You can use a quadruple lead CRTD to complete the procedure. Of course, there are a lot of areas of concerns in left bundle branch spacing, because people used to talk about the myocardial injury or deploying the lead deep inside the septum. So there is a significant myocardial injury by penetrating the proximal septum. So we have analyzed the myocardial troponin release in patients with undergoing left bundle branch spacing and His bundle pacing, and we have compared it with the conventional routine EP study and radiofrequency ablation. So what we could show was in patients with the His bundle pacing, the troponin release was significantly less, followed by those who are undergoing left bundle branch pacing. And when you compare the left bundle branch pacing with the conventional SVT ablation, we are surprised to see that a simple AVNRT ablation is going to release more troponin as compared to a simple left bundle branch pacing. So relatively, the procedure is simple and safe in terms of myocardial troponin release as compared to a conventional EP RF ablation. Of course, the lead dislodgement and lead extraction, which you have to always keep in mind, you're going to bury the lead deep inside the proximal septum. There is a chance that you may not be able to extract the lead in the near future, but we could extract a 2-year-old lead without any difficulty, but this is only 2 years. We don't know what will happen after 7 or 8 years, especially with the fibrosis around the lead, whether we'll be able to completely remove it or not, we are not sure. Of course, long-term safety data, the only long-term data which is available is from Dr. Wong's group, where they have published 3 years data, where we could show that a very good success rate of close to 98%. And over a period of 3 years follow-up, they could show that only 4 patients had a rise in threshold and 2 patients had a loss of left bundle capture. This is a very important study as far as the current status is available, because this is the only long-term data is available to show that left bundle branch is safe and feasible. The current trend in India, of course, it started probably 2-3 years back. So this data I got it from Medtronic. So this is based on the usage of 3830 leads. So from May 2019 to April 2020, almost 800 leads have been used. So roughly around 800 procedures were done in India. And between May 2020 to April 2021, almost 1,212 cases have been done despite the COVID surge. And in the last quarter, between May 2021 to July 2021, this is only for 3 months, almost 308 leads have been consumed. So this again is going to be probably around 1,200 to 1,300. So definitely the trend is continuing, and there is a definite enthusiasm for performing conduction system pacing, and definitely it's not going to fail. Of course, when I was talking to the Medtronic fellow, they were actually telling that every 6th implantation of a Medtronic device is associated with a 3830 lead implantation. And of course, needless to say, left bundle branch pacing is the most often preferred strategy over His bundle pacing. Of course, the most important areas of interest as far as conduction system pacing or left bundle branch pacing is concerned is one is pacing-induced cardiomyopathy, where you just have to remove the whole lead and put a lead in either His bundle or left bundle and connect it to a simple dual chamber pacemaker. And AVJ ablation. Of course, AVJ ablation was not done previously, because once you are doing AVJ ablation and doing an RV apical pacing, you are creating one disease, this pacing-induced cardiomyopathy, for treating one disease. But with the advent of conduction system pacing, you can easily do either His bundle or comfortably do a left bundle branch pacing, and you can ablate an AV node so that you can achieve a good control over the heart failure symptoms. Of course, those patients with the baseline RBBP, baseline IVCD, are very poor candidates for CRT, but this can be effectively corrected or effectively resynchronized by using either His optimized or left bundle optimized cardiac resynchronization therapy. And a lot of BIV non-responders are there because of poor venous anatomy or inadequate desynchronization. And these patients can be effectively targeted by conduction system pacing. What about the guidelines? Of course, guidelines, they've clearly stated that as far as the current evidence is concerned, those patients with a typical left bundle branch morphology with and eligible for CRT, still BIV has more solid evidence, and therefore it should remain as a first-line therapy. But Isbundle can be considered as a payload solution in patients with the baseline RBB morphology, or as an is-optimized CRT in those patients where there is insufficient reduction in QRS duration. And they have given a class 2B status for those patients who are going to have a baseline LV dysfunction and going to require a committed ventricular pacing for more than 20%, and class 2A recommendation for those patients with a CS lead failed, unsuccessful CS lead implantation. About left bundle branch pacing, they have actually commented about left bundle branch pacing. So they have clearly stated that as far as current evidence is concerned, data is very, very scarce. So they clearly stated that left bundle branch pacing as of now, but the guidelines will be revised once more solid evidence of safety and efficacy is going to be available. Of course, in the near future, we'll be getting or we'll be generating more and more data on safety and efficacy of left bundle branch pacing. So with the availability of the data, probably even the left bundle branch pacing will come into the guidelines, and with the excellent results for patients with a non-ischemic cardiomyopathy and with an LV dysfunction, this left bundle branch pacing will probably get at least class 2 or class 1 status for a replacement of cardiac desynchronization therapy. Thank you very much.
Thank you, Shanmuga. Just one question, one quick question. What do you think about the treatment of choice for pacing-induced cardiomyopathy? Suppose we have a patient who has developed LV dysfunction and he has a EF of say around 20-25%, and he has a heart failure recurrent admission. So do you think that we by default would go for conduction system pacing instead of CRT, upgradation to conduction system pacing instead of CRT?
Sir, as far as guidelines is concerned, the guidelines, they have not recommended conduction system pacing as a class 1 or class 2 indication. So if you're talking about guidelines, then obviously CRT should come first, as by a conventional BIV therapy should come first. But what we have seen is if it is a purely pacing related issue, so then probably just replacing that RV lead with a simple lead either in the Hisbundle region or left bundle region is going to solve. So we have at least 11 patients in our series where conduction system pacing was done for pacing induced cardiomyopathy, and we could show significant improvement in LV ejection fraction. Like the kid it was done in Calcutta with Dr. Mainek, so that the kid actually responded well. So it's a purely pacing induced cardiomyopathy. The VF improved and the weight of the baby improved, the heart failure symptoms settled. So I think that should be considered, though guidelines as of now is not recommended. This should be considered and discussed with the patient before considering BIV therapy.
Thank you.
Thank you. Thank you, Surendan, and thank you, Dr. Shanmuga. It was a brilliant, to have you again, I must say. And so this is a contentious issue, like if apical, pacing-induced cardiomyopathy, whether it is because of dysynchrony or it is because you are pacing the apex, it's happening. So basically the problem lies at dysynchrony. A CRT also works wonderfully. And we have seen many patients, like upgrade many patients. So maybe more and more research and more cases will tell us. So we go with the next presentation. I'm going to show some cases. We are already late, so I will be a little quick, and I will try to give more platform to Dr. Avinash. Dr. Devanu Ghoshra is there. Sir, you have to chair the session. And Dr. Kundu, if you allow, I can straight away.
Yes, sir. Dr. Dilip Kumar, sir. Please talk on this topic.
Yeah. Thank you. So, we are clear of the role and place of CSP. It's going to stay, and that's what everyone feels, and that's what the evidence which are emerging. And I will show you some cases which I did, and it was of a different type, and it was not conventional. As we talk about RBBAF and then AV junction ablation and then maybe a conduction system pacing or optimized CRT. So these are the problems with normal pacing, AF, cardiac dysfunction, heart failure, and these are not a small problem, it's a big problem. I'm not going in detail. I will straightway go to the cases. Implant technique. So if you're going for a His bundle, we have to have a good V, at least more than, twice of A to have a distal His pacing. So it is rightly addressed by Dr. Mahesh, Dr. Kush. And this is how we basically screw. And Professor Nura is very right. You should have a new glove, pair of gloves when you are going to screw it. A wet, gloves and wet hand, it is not going to be properly screwed. So this was a case which had a single chamber pacemaker initially, and then it was upgraded to CRT since the patient had a pacing induced cardiomyopathy. And unfortunately, this poor gentleman had a CRT infection. So you can appreciate here 4 leads. One was the first VVI pacemaker lead, which was not explanted. And then there are 3 leads. So this was the ECG which he was having, and he came to us. So he basically was running out of money, and he had already spent twice, and this time he was asking for economical, considerations. And there was also an infection. We wanted to have less hardware there, less number of leads there in heart, and also to be economically more viable. So we extracted all the leads, all 4 leads were extracted. And from right side, we did this left bundle pacing. And this was the ECG which we got ultimately, and the patient is still doing well. So these are the situations where there are some multiple leads, and we can't deploy more and more leads in that. And also the economic considerations where you can think of going for a left bundle pacing, physiological pacing. Another spectrum of patients, like this was an elderly female. She had right bundle branch block and persistent atrial fibrillation. Ejection fraction was 30%. Here, the patient had a normal coronaries. And this was the ECG. You can appreciate quite a broad QRS with atrial fibrillation. And this poor lady was admitted thrice in last 6 months. And she was on optimized medical therapy, but every time, in next 2-3 months, she was getting admitted. This was the echo of the patient. The LA size was 4.6. So there is a kind of a debate whether we can go for a AF ablation or not in these patients, but when the LA size is more than 4.5, it basically becomes difficult to have a prolonged sinus rhythm in these patients. So we thought of doing the AV junction ablation and LOT CRT. And so you can appreciate here 3 leads, one in the left bundle area, AV junction was ablated. And then there was a CS lead, which is through middle cardiac vein to up in the lateral part. And also there was a backup RV lead. And this ECG, which we got in this patient, it was quite remarkable. It was our first case of optimized CRT. And the patient improved, and in the next 3-4 months, rejection fraction improved to around 40%. This was another patient, 42-year male, and he had a DCM, ejection fraction of 28%. So I'm so sorry. So this was a 42-year-old male and DCM with 28% ejection fraction. QRS was 180 millisecond. And I thought, let's go with a optimized CRT here. And this, you can appreciate a left bundle lead here and a CS lead and a right atrial lead. And this was the ECG. You can't differentiate, if this ECG is given to us, that's a normal ECG or a pacing has been done. So this kind of, wonders can be done with optimized conduction system pacing. Again, a patient, 56-year-old male, NYHA class 3-4, left bundle branch block, persistent atrial fibrillation, 28% EF, normal coronaries, and can appreciate the left bundle branch LBB and atrial fibrillation. He had a normal coronaries, and again the question comes to whether they're going for junction ablation and CRT. So here we again going for AV junction ablation and optimized CRT and same combinations, and this is this kind of ECG we got. Patient improved, and you can appreciate the echo of the patient. This was the after 3 months. This was the first. Again, last 2 cases, 68-year-old lady, LBB with intermittent CHB, EF 45%. And when we took this patient for, connection system pacing, we are not aware that she had a very, very bad scoliosis of spine. And we had the entire fluoroscopic anatomy total in disarray, and we had to depend only on, EKG, intracardiac signals. This was the baseline ECG, and we finally got this CSP in this lady. So in difficult anatomy also, we can go with connection system pacing based on intracardiac signals. We can have a good final outcome. So we published this. And finally, this was with Agilis HISPRO. And this, what Dr. Kush showed, this has electrodes in tip, and you can map. And it is very, very, maneuverable. And this patient, this slitter is also, quite easy to use, new slitting system. And here we got this kind of ECG. So these are the new advances, and we have got HISPRO when we would like to go for a his bundle pacing, but definitely things are moving away from his bundle to left bundle. So we'll have discussions on this particular subject by Dr. Hajra, and I straightway invite some comments from our chairpersons and the moderator. Thank you.
Very good presentation, sir. Any question from the chairperson or any clarification? I have just one question.
Yes.
I think they were wonderful cases that you have presented, and the results were actually excellent. And you can see the ECG, they were absolutely normalized. I have just one question to you, that you are doing this procedure. Do you think in near future, even every new cases also, we should go for conduction system pacing and not wait for the patient to deteriorate after just RV pacing and then go for conduction system pacing?
So that debate is still going on. So basically the patients who are falling in block HF criteria, like 36 to 50% ejection fraction. And if someone has a 40%, 45% ejection fraction, definitely we should consider CSP, upfront. We can consider there is no harm in it. And this is also a class 2 indication. Not for left bundle, but definitely for his bundle pace.
Sir, I have a question.
Yeah.
Hello.
Yeah, Dr. Kundu, please go ahead.
Yes. Did any his bundle selective or non-selective pacing who is despite adequate by V pacing, or
we have
LVP?
So we have not done any CRT. We have done in cases where CRT have failed, or a patient had a kind of a CRT infection. So in these kind of cases we have done, but someone has been given a CRT and he's not responding. I'm yet to do such case. Shanmuga, Dr. Shanmuga, Avinash, you have an experience on that?
Yeah, so CSP lead failure, a good number of cases we have done, and CS core anatomy cases, good number of cases we have done. And as a CRT failure, we have done at least I think 3 or 4 cases, they have done reasonably well. But many of the cases I've done as a proctor elsewhere, so I just can call and ask them like what is happening. I don't have the exact follow-up. But I think these patients will reasonably do well when you are capturing the cardiac conduction system, and if you are going to retain a good CS lead at a good position, because many of these patients will have an associated peripheral conduction system disease or a mixed disease. So you may end up in putting a left bundle branch optimized or his optimized CRT. So when you have a good CS lead in a posterolateral vein or lateral vein with a good QLV distance, and you're going to put an additional lead in the cardiac conduction system, that left bundle branch optimized CRT is going to produce a better response as compared to either a left bundle branch pacing alone or a biv pacing alone. But yeah, that is the only solution which is available as far as now the current situation is concerned.
So we can move on with the, thanks Devanuda, thanks Dr. Kundu, and we can move on with the next presentation. Dr. Avinash will present on, Dr. Sanu, unmute yourself.
Yeah, it's over to Avinash. We are waiting for his talk. It's over to Avinash.
Hi, I'm back. So yeah, very nice presentation. I must congratulate all of you, and it's so nice to see you all back, after so many days of so-called lockdown. So attention required for these cases. I know after so many excellent presentations since afternoon, it's hard to concentrate on topics like EGMs and ECGs, but still some attention is required. So I would start with His bundle pacing. Now, going by the crowd that is present here, I'm not going to talk about too much about the basic, but only about what is essential in terms of EGM and why it is essential for us to see the EGM and the ECG. One of the very important reason is that unlike the conventional CRT, where we don't tend to see how we are doing on the table, rather than we are more concerned about anatomically, okay, it is a posterior lateral vein, yeah, that's the only vein we have to put it there. And are we, okay, it's apex or it's septum, that's the only place we have to put it there. We don't so much see the electrograms and the 12-lead ECGs while doing the procedure and post-op. But it is absolutely essential when we are doing any type of conduction system pacing to see that. And one of the reasons is there is so much variation in the anatomy. Like here, for example, you see there are so many branching patterns of His and left bundle that it's so difficult to know where exactly the His bundle is, particularly in a dilated, distorted heart. So unless you map it, unless you see the EGM, unless you do the pacing and see the 12-lead ECG, and you go by it, there's no surety that what you are doing. So you'll be putting the lead, but that will not be a conduction system pacing. So you have to depend on EGM and ECG rather than fluoroscopic markers. There are many types of His morphology. So I'm starting with His bundle. There are many types of His morphology, and just because of this, at times it is not possible to get selective His bundle pacing, no matter how hard you try. You must be dealing with a case of a different types of His, which is covered by a mycoidal sleeve or intramuscular His. In this case, you will not either get a big His signal, nor you will get a very, very discrete direct His bundle pacing or a selective His bundle capture. Again, just to show that the anatomy can be variable, so you have to go by the EGMs. Going by this fluoroscopy marker, it's very difficult to see where is atria, where is His bundle, and where is ventricle. I mean, it's just guesswork. But you have to rely on ECGs and EGMs. So EGMs will tell you that this is a proximal His, that you can see a big A and a small and a His. This is a more distal His. You can see that. So this is a very, very proximal site. This is, we are dealing in the atrium. This is near the CS. And as you go more distal, probably this is a distal His that we are seeing. So it's the EGM that will guide you, not the fluoroscopy. This is just to show how a distal, this is a proximal His bundle signal and how a proximal His bundle signal is required. This is where we don't want to pace, because if you pace it here, there is a chance that you will do a concurrent atrial capture, and there'll be problem while you're pacing this patient. If suppose, God forbid, this patient is dependent, the A sensing will lead to V sensing before, so it will be taken as ventricular sensing or ectopic, and there'll be failure to pace. It will not even fall in the noise sensing window, so the ventricular safety pacing can come. So even that will not save you. So that is why just totally avoid proximal His bundle pacing. Just avoid it. If you want to do His bundle pacing, it has to be as distal as possible. There is no chance, no remote chance of getting any atrial EGM. Even if it is there, it should be a non-local atrial EGM, more like a far field deflection rather than a local EGM. The A wave that should be there should definitely be more than less than 0.3, 0.2, 0.1, if at all. And there should be no capture, no atrial capture at all. So these two things are important to monitor. Another thing, so what is the importance? Why do you want the proximal versus distal His bundle? So we all know that, if you go more proximal, there's less chance for good R wave sensing. More output will be required for overcoming the block if we are dealing with a LBPP scenario. and there'll be more chance of atrial sensing and atrial pacing. So if you go distal, you avoid all that. So by going distal, you're also avoiding being too proximal to the site of block, because if you're too proximal, suppose if your HV is too high at a proximal place and your HV is lower at a distal place, your correction threshold will be much lower as compared to what it would be if you are proximal and your HV is higher. So you must map the entire His region to see which is the lowest His that you're getting, lowest HV that you're getting, and target the lowest HV. And mind you, if you are getting a wide LBBB kind of pattern with a long HV, it's a good case to pace. It's a good case to pace because you know that the disease might be in the conduction system. Whereas if you are getting a complete LBBB with a HV of completely normal, even while being distal most to the HV, then you know that it's less likely that just the His bundle pacing will be able to correct it. So this is not a good case for His bundle pacing. So it will also guide you whether to go ahead with it or not. Usually, like Dr. Shanmuga said, all of us have moved on to left bundle pacing, and many of us deliberately don't do His bundle pacing, even if some parameters are getting corrected. So, but still, it is good for knowing them, because still we get some patients in which the parameters will be absolutely fine, like 0.75 capture threshold with selective His bundle capture and very good R wave. Then why not? You can go ahead with it. Many possibilities are there with His bundle pacing. So whenever you are doing His bundle pacing and you're taking this patient for follow-up, as well as in the lab, when you're checking it, you have to check up for all this. There could be His bundle with correction or without correction, which will be selective His in some cases. There could be His bundle, which will be non-selective, that is concurrent myocardial capture, which could be with correction or without correction. Now, this could both be indirect or direct His. I'll go forward to that. Then there could be atrial capture along with selective capture of the atrium. It's less likely that you will capture both A and V along with the His. Both usually don't happen. Only atrial capture is possible. Many times you're getting His bundle, but there's not enough His tissue, or you're not being able to depolarize the His tissue, whereas the atrial is still getting captured. So that is the worst case scenario. So you please check that this is not atrial capture, because the QRS will come narrow. And if you don't see what is the pacing to the narrow QRS interval, and you'll be fooled that it's a very good 1:1 capture and a very narrow QRS. It's a His bundle. It's not His bundle. It's the atrial capture that is happening. So only atrial capture is possible, particularly if you are proximal and you're not capturing the His. Only ventricular myocardial capture is quite common, particularly when you're targeting the His bundle location. So it's all parahesian pacing that is happening. So while doing any conduction system pacing, you have to be very sure to do at least one maneuver to say that you are capturing His bundle or not. Because sometimes even the parahesian pacing will look, QRS will look narrow, and there can be no capture. So all these possibilities are there, and you have to keep in mind when you're doing your conduction system pacing regarding all this. Now, just quickly, let's define a few terms that we'll be talking about. What is a dedicated or selective capture, and what is a non-selective capture? So whenever you see a local V,
really very simple, vivid, and it gives a confidence that we can
minor points. I also rectified myself.
Can you mute? Okay. So if you're getting a selective capture, then you'll get a local V. Whereas if you're getting a non-selective capture, you'll get no local V. So that is important. So take example, for example, here, there is no local V, whereas in selective capture, there is local V. And there are other methods, other things also, that your HV will be exactly same to as what the HV was there while the sensing, and there will be an isoelectric interval. So if all these three are present, then it's a selective His bundle capture. And if there is no isoelectric interval is present, or sensing from H to end of QRS, and there is no local V, then you are dealing with a non-selective capture. So this is, you can use either of the parameters, but if they are present, then it's a non-selective His bundle capture. Now, whenever you have a selective His bundle capture, you will be dealing with either one or two thresholds. It could be just a capture threshold or a capture and correction threshold in case of bundle branch block, and then there'll be loss. So you'll be dealing with only two thresholds. Then we come to non-selective His bundle capture. Now there can be many mechanisms based on whether it is a direct His screw-in that you have done, or it's an indirect His screw-in. Indirect His screw-in, we mean that you are close to the His bundle, but not exactly in the His bundle, or maybe you are in the His bundle, but the His bundle is covered with myocardium. So you are stimulating both myocardium and His, and sometimes the threshold of myocardium is less than the threshold of His. So that's an indirect His capture. So in both these cases, you will have non-selective. So one of them will be better and one of them will be not. So this is an example of a direct His bundle capture in which you see that there is two thresholds. There's a capture threshold at high, and there is a His capture threshold at low. So this is good. Non-selective capture which is happening, and as you bring down the threshold, there is a direct His capture and a selective His capture which is happening. So at lower threshold, you are losing the myocardial capture. So the initial myocardial capture was because of increased virtual electrode, and this is a good or optimal site because you are directly in the His, and only when the pacing is quite high, the output is high, then you are capturing the myocardium. So this is good. You can accept it if rest of the parameters are fine. Indirect His bundle capture will be something like this, that you will get at higher output non-selective capture, but when you lower the output, instead of His capture, the His capture will be lost, and what you will have is a myocardial capture. So it's an indirect His capture that you are having, and this is the thing which we don't want. So this definitely do not accept. I mean, particularly now if you have left bundle pacing, we don't accept this. And mind you, these two thresholds which are possible is in case of narrow QRS, but if you're dealing with a bundle branch block, just add correction and non-correction in this. So it will be four thresholds which will be possible. Another very important thing while doing a His bundle pacing while in the lab is to see for injury current. This is a example. So right bundle branch block, long PR interval. During lab, you see that when you put the His very small a, distal His and small His, those His will be small in the distal location. In a proximal location or mid location, His might be bigger. So don't aim for the bigger, aim for the smaller, which is closer to the V. So here you can see that, you know, a nice injury current is there, and when you pace it both either unipolar or bipolar, you can correct even complete RBBB, and it's a nice correction. So I'm not going into the clinical details. If His bundle injury current is present, long-term His bundle thresholds are good. So if you are suppose accepting a His bundle for if you are doing a His bundle, suppose you are getting very nice parameters, then please see that you are getting a His bundle injury current or not. It is not advisable to accept a location with no His bundle injury current. Reason is that the late rise of threshold you might be dealing with. Again, for example, this is a poorly or a poor site for His bundle pacing. The reason is that you can see that A is too big, and while you are doing His bundle pacing, you are getting a non-selective capture, but there is no His injury current. Even this is a screw-in lead, so you have already screwed in, and still there's no His bundle injury current. So this is not a good site. This, on the other hand, is a distal His bundle location. A is small and you're getting nice His bundle injury current. And this is a nice case. You can accept this if you're getting rest of the parameters fine. So benefit of distal His bundle pacing, you have to measure HV to say that you are distal most and you're not proximal. Too big an HV at implant site may suggest a more distal disease. Even if you are at distal His bundle site, then it's better that you go for left bundle pacing. It's preferred because there's a smaller His bundle potential. There's a smaller A, less chance of safety pacing being active, or less chance of false A sensing and then pacing inhibition going on. Bigger V is there, less chance of atrial capture will be there. So all these things which are actually drawbacks of His bundle pacing can be avoided in a typical case if you are at very distal His bundle. But nowadays, more and more we have moved on to left bundle pacing. So this is my second example. This is one of the example
Vinas,
yeah,
a little quick.
Okay, so this is a CRT non-responder, and His bundle pacing was done in this case, and you can see that pacing here at lower output, it showed us the same His bundle capture with the same HV as the sense HV of 82 millisecond, whereas if you just increase the output, the corrected HV was 52 millisecond with a local V and correction. So this was a non-responder initially, but he was a super responder. After doing this, his EF became 50% after 2 months. Okay, now coming to the left bundle pacing, I'll be as quick as possible. First, number one, you have to localize the site. Where do you want to go in? Dr. Kush has already said, how do we see that? You see a notch, you see AVL-AVR discordance, negative AVR, positive AVL, and you see R wave in lead 2 should be R wave in more than R wave in lead 3. We should not go for straight away a negative in lead 3 and lead 2. These are some other examples of similar cases of good sites, what it would be. You can miss the left bundle by starting too high. So don't be too high, because it also depends upon the orientation or the angle of the sheath. So if you're suppose unable to reach that position, you can start even lower, but never start higher. So you can start lower and have a smaller R wave or somewhat flat lead 3 or maybe negative lead 3 in some case, and you orient your his bundle sheath to, let's say, 1 o'clock position. And if it goes in that, say, it's the end position which matters and not the starting position. So don't be higher, don't be at a higher position. You can start low, but if you are starting low, keep o'clock position nearly 1 o'clock or 2 o'clock. Now this has been very well shown by Dr. Shanmuga, that as you screw in the lead, the migration of the notch is present, and this you have to see while implantation. And this is how you ascertain how deep you are and how deep you have to go. Again, I will not go into the details, that you have to see impedance and rest of the things. Now, just about the electrograms. So good electrogram or left bundle potentials are important. Narrow QRS, in almost all cases, 90% of the cases, you should get left bundle potential. There's no reason not to get it. Things are different in right bundle. Right bundle, most of the cases, you should get a good left bundle potential, like in this case. We got left bundle potential. In IVCD, it's somewhat dicey. If you may have a retrograde left bundle potential, like in this case, it was a retrograde left bundle potential. And you can see that why we are seeing retrograde left bundle potential, because differential ERP was done, differential threshold testing was done with and without local V. And you can see that when a non-selective capture is there, the morphology is totally different and there is no local V, whereas when the selective capture is there, we are getting a R prime and we are getting a local V. However, this was a lot CRT case because it was a suboptimal result. So we can talk about it. So I'm not going into details about programmed deep septal pacing that we do during implant. One thing to remember, if those of you who might be aware, that type 1, type 2 responses which are there, diagnostic response and non-diagnostic response, are more of a theory, because you can get both response in the same patient. All it means that you are capturing his bundle. So if you are getting one non-selective and one selective, it doesn't matter which type of response you're getting. If you are getting a non-selective capture, even at a higher output or lower output, if it is, if non-selective is, let's say, at 1 or 1.5, you should accept that. And it's not that, it depends on the drive train, whether it is intrinsic train or a pace train. So again, I'm not going into too much detail of this. Okay, coming to another thing that you check for anodal capture. So on table, we always check anodal capture in all patients. So this is a left bundle pacing example. You can see that there was induced RBBB that happens while doing a left bundle pacing, and you can correct it by anodal capture. So we check anodal capture in all patients. So this was baseline RBBB, and the RBBB and induced RBBB was corrected by doing a bipolar high output pacing, which leads to anodal capture and correction of QRS. So what about follow-up? So during follow-up, analysis with 12 lead ECG is very important. For example, this is a his bundle case, and you see that what is happening in this case. Sometimes you are getting a non-selective his bundle capture, and sometimes you are getting a selective his bundle capture. So isoelectric interval seen in selective his bundle cases, whereas intermittent non-selective his bundle is happening in this case. So this can happen. So you have to be sure, that you're because if you're just using a programmer, you'll miss and you'll think that, it's either selective or non-selective that is happening. This is again example. What do you keep the AV delay in this case? So programmed AV delay usually always takes into account the HV interval. So if your HV interval is 50, we usually keep around AV delay, sensed AV delay of around 60 to 70. So with the sense AV delay of around 60 to 70, this is what you will get with his bundle pacing in bipolar, and this is what we get in unipolar. Now, mind you, usually unipolar, bipolar is not that big a question in case of in case of his bundle location. But this is our case example where we can show that there is a selective and non-selective cathodal capture happening with, so non-selective unipolar cathodal capturing was happening with unipolar because of large virtual electrode, whereas with RV bipolar, there was a selective cathodal capture. And you can see the difference with non-selective cathodal capture. If you see lead 2, lead 3, you can see the difference in morphology which is present, as well as you can see in lead V5, V6, there is a S wave which is there when there is a selective cathodal capture, whereas it was not present in a non-selective cathodal capture. And you can also see in AVF that there is a slurring in beginning of QRS in case of non-selective cathodal capture, whereas it is present with selective cathodal capture. Now, we might say that why not anodal capture with bipolar? Yeah, it can happen anodal capture in a His bundle case, but it's very uncommon. And in this case, because of the isoelectric interval that is present, it looks more like a selective cathodal capture rather than a anodal His bipolar capture in case of His bundle. Intermittent A wave oversensing, this is not my case, but this is just to show that what bad could happen. In this case, he presented with syncope. So please take care that your A wave is not big, and if it is happening, then change your sensitivity, and you can auto sensitivity you should turn off in this case. This is against ventricular safety pacing. So ventricular safety pacing should be turned off, particularly if you are somewhere in the middle and your His bundle electrogram is big. Your pacemaker can sense the His bundle electrogram. So in this case, it will do safety pacing. Now, safety pacing won't harm the patient. He will not complain, but battery drain will be there. So it should not be done. Now coming to the left bundle follow-up, what do you see? So this is a programmer follow-up of left bundle. You can see a nice left bundle potential. It's a narrow QRS. Left bundle potential can be seen even on a programmer, even in follow-up. So this is a follow-up case. So if it is present, then you know that you are right in the left bundle and it's good. Very important thing is unipolar to bipolar, and to see selective left bundle capture at a lower output. So at a lower output in this unipolar configuration, even in bipolar configuration lower output, you can see that you are having a selective left bundle capture. However, it becomes a non-selective left bundle capture at a higher output. Now, which one you want, it's up to you. Usually we take a non-selective output because as soon as you increase, usually the selective capture happens at 0.75, 0.1, 1.2. And at 1.2, you lose the selective and you go for non-selective. So just because the safety margin has to be kept, we accept this non-selective capture. But in a patient, non-selective capture can happen with anodal capture also. For example, if you increase the output even more, if you increase the output to 3, now in this case with a bipolar lead, we are getting 3 things. You're getting a non-selective His bundle capture, that is His left bundle capture, myocardial capture, and anodal capture at the same time. And you can see that the notching which was there in 2 and AVF in non-selective left bundle capture is completely gone if you also take care of the anodal capture.
Can you go to last slide? So we have many presenters left.
Yeah. Okay. So I'm not going into details. Yeah. So just one slide to summarize everything. What are the recommendations? Again, there are a lot of recommendations. So yeah, in conclusion, EGM's 12-lead ECG and is essential for CSP procedure and follow-up. Some form of assessment for conduction system capture should be done during the procedure. It could be differential threshold testing, it could be differential ERP, it could be left bundle, His bundle potential, or local V presence. You should use at least 1 or 2 to say that you are capture. I mean, I didn't show that. You can very well get R prime just by the septal capture and not having a left bundle capture at all. So unipolar, bipolar configuration must be tested separately in each patient. Anodal capture must be tested. AB interval timing needs to be adjusted. Proper training of staff is required because they may not do all this in all patients. And documentation is essential as there's a lot of information. Thank you.
There was an extensive review about the EGMs and ECGs of conduction system pacing. If we have time, we can have some questions or we can move on to that.
So thank you, Avinash. We are so sorry we can't allow No,
it's okay. It's okay. I understand. Yeah, it's
so
just that it's a long topic.
Narasimhan has personally requested to prepone his talk. So may I invite Dr. Narasimhan sir to give the presentation on cryoablation, an overview, and the chairperson of the session, Dr. Rabin Chakravarti and Dr. Biswajit Majumdar. Rasda, if you can, with your permission.
Thank you, Dilip. Without wasting much time already, I think we are running late in the program. So I'll request straight away my close friend, Dr. Narasimhan, as a new technology which has been evolving for, I think, maybe a number of years, nearly 22 decades, and eventually has come into clinical practice. May I therefore request Dr. Narasimhan to update us, educate us on the new concept of cryoablation, particularly in reference to atrial fibrillation. Dr. Narasimhan, please.
Thank you very much, Robin. It's really nice seeing my colleagues, all of you together. Thank you very much for this kind invitation, Dr. Dilip. As you are aware, atrial fibrillation is progressive, and over years, we have realized that persistent atrial fibrillation has poorer prognosis compared to paroxysmal atrial fibrillation. And we have also realized the burden of atrial fibrillation is tremendous in terms of increasing risk of sudden death, comorbidity, stroke, heart failure. I need not tell this to an EP audience. Over the last few decades, this rate versus rhythm conundrum has been addressed by properly designed studies, which consistently now seem to demonstrate that early rhythm control, you can see a divergence of the curve in survival as early as the first year after randomization, and it persists over 8 years of follow-up. There was a mistaken impression that there was no difference between rate versus rhythm, but all of us agree if patients are adequately anticoagulated, maintaining sinus rhythm confers 40% survival advantage compared to rhythm control alone. Now, how do we prevent the progression of atrial fibrillation? How to treat? So it has been shown that when you treat patients with catheter ablation for atrial fibrillation or cryoablation for atrial fibrillation, there is a high degree of maintaining sinus rhythm compared to patients who were on just drug therapy alone. Meager 8 to 10% of them maintain sinus rhythm at the end of 9 months compared to 70% without recurrence of atrial fibrillation. This is a very elegant paper which came out several years ago saying that if you do a catheter ablation early on, now you find that the ablation group, only the progression to persistent atrial fibrillation occurred at the rate of 0.5 to 0.6% per year, compared to a significant increase of 25% of these patients develop atrial fibrillation at the end of 5 years. This is 0.4, 0.5 per year. This is 8% per year. Let's start with a case example. This is one of our cases, 57-year-old person with recurrent atrial fibrillation was tried on sotalol, amiodarone, beta blocker, quite symptomatic, getting it almost every other day with significant limitation of symptoms. On ECG, we found that he had both flutter and fibrillation. Paroxysmal atrial fibrillation and atrial flutter, AFib burden was significant, and his Hasbled score was low. Routine lab investigations were normal, but he had a significant diastolic dysfunction, and LA size was enlarged and LA volume was slightly enlarged. This is what we generally do, or we have done now about 6 cases. Internal jugular access with CS, and we try to limit the right femoral vein for a single vessel. That is because this is a 15-French sheath. We don't want multiple sheaths, even though others do 2-3 punctures on the right side. We stick to only one sheath on the left, on the right, and the others on the left. We have learned over the last several years using ultrasound guidance is extremely important when you do a large vessel access. And I would prefer that everyone uses ultrasound to get a safe access. And single right femoral arterial pressure monitoring, this can be either radial or femoral according to your choice. Pre-procedure CT, we have been obtaining initially now for all cases, but I don't think it's mandatory. This we can discuss later. We prefer to do these patients under general anesthesia. Please speak to your anesthetist and make sure they don't give any muscle relaxants when you do this procedure. Even if they find that the muscle tone is very high and intubation, they need to use a muscle relaxant, ask them to use an extremely short-acting muscle relaxant. And so that by the time, especially when you come for right-sided veins, it's important, you shouldn't be having any paralytics on board. We have done all cases on our intracardiac echo guidance for simplicity, and all of them we have done along with 3D anatomic mapping. This is the anatomy that was obtained, more like a common trunk on the left and the individual trunks on the right with a right middle vein. Right upper with a little bit of an dilatation at the os, small veins right middle and right lower. So when you make a puncture, it's extremely important that this is the intra-atrial septum, the upper segment near the aorta. This is the inferior portion of the intra-atrial septum. You try to get the septal puncture as low as possible. In contrast to other conditions, this makes it easier for you to navigate in the LA. And second thing is, when we do conventional RF, we have been making a little posterior puncture. Here we try to make a little anterior puncture, anterior and inferior, so that you can turn around and come back to the right inferior vein. We always, it's extremely important to understand and prevent collateral damage. So this is what you're seeing is a cryo probe. The anesthetist keeps pulling the cryo probe farther and back and forth when you're freezing the vein that is very close to the esophagus. When you get a CT scan, please ask the radiologist that you're interested in knowing the position of the esophagus. Secondly, radiologically, once you put this cryo probe, that itself serves as a marker to understand which vein it's close to. And this is important. We tend to minimize fluoro. When you have a Doppler on the, after inflating the balloon, you put a Doppler and see whether the flows from the pulmonary vein is coming into the left atrium. That tells you you have not adequately sealed the pulmonary vein. So you don't need fluoroscopy for this. To get an adequate seal, you first try this. And if you get an adequate seal, you won't see any flows from that ipsilateral vein. I don't know. Okay. Okay. Now, as you can see here, this is the person is moving the probe, and through the distal lumen, you inject contrast. Now, I'll again go through this. This is important. This is how you assess the, you can see when we are injecting contrast, you can see a layering of contrast on either side. I'm sorry for the poor quality because this is done under low fluoro at 3.5 frames per second, not the conventional fluoro. That is why the quality is poor. When we inject, we see a layering of contrast here. Tells you that its adequate seal is not there. Then you move the catheter to get an adequate seal and then re-inject. When you re-inject here, you can see a meniscus sign here. I don't know, let me just go through this. Yes, you can see a meniscus sign because of a holdup of a contrast here. That tells you you got an adequate seal around the antrum of the ipsilateral pulmonary vein. Now, it's the distal catheter, they call it as an achieve catheter. This is our, most of the EPs are familiar with this lasso type of catheter. This also serves as a rail for you to advance the balloon over this. When the pulmonary vein potentials are not, this is for some of you, let me walk through this. This left-sided isolation. You can see, I'm sorry. You can see a left atrial potential followed by a sharp pulmonary vein potential, left atrial potential, pulmonary vein potential. When you don't see pulmonary vein potential, it is, you can start pacing the distal coronary sinus. That will separate out. Here, spontaneously, there was a delay between the pulmonary vein and the left atrial potential. So we did not choose to pace the distal CS. You can see with the starting of the cryo, completely the PV disappears and we look for time to isolation. In this patient, I think it took just about 20 seconds before it got isolated. Left superior pulmonary vein got isolated. And then this is left inferior pulmonary vein. You can see again a far field potential of the left atrium and a near field potential of the far field and a near field of the LA signal and the pulmonary vein signal, start RF, cryo. After a while, you get that complete abolition of these potentials. Now, this is extremely important. Once you finish the left upper and left lower, we pull the decapolar out of the CS and position it in the area of the right subclavian to SVC junction and start pacing with a wide bipole. Between the, say, the distal and pole 4, you will get a wider area of capture and ensure that the diaphragm is capturing when you want to freeze the right upper pulmonary vein. In addition, it's very useful. I don't know if you can see this. When we pace this thing at about, say, 1000 or 1500 millisecond, you are mapping the diaphragmatic complex motor action potential. So you pace the distal area and you have a ECG electrode on the xiphisternum spanning over the diaphragm. And this is the complex motor action potential, which tells you the diaphragm is contracting. You watch the amplitude of the action potential and you find a slight decrease in action potential. Immediately you come off the cryo and you need to redo it or reposition and do it. Here, for example, this is the Achieve catheter. The cryo is positioned here, more antral in location. If you slightly doubt that there is a phrenic nerve capture, counterclockwise rotate the sheath so that you move away from the phrenic, or there is something called a more antral ablation may prevent phrenic. This is one of all the complications, this is one which continues to be a problem in cryoablation. It occurs in less than about 5% of cases. And you need to be, this is one of the very useful monitoring technique. And we need to be passionate about avoiding this complication. Again, you see in this patient, the pulmonary vein potentials separating out after the third, fourth beat, it's completely gone. This is a second patient. He was a practicing surgeon, very active in his practice. And I'm sorry, this the first one is this. Again, during RSPV isolation, the whole thing, the fib terminates and sinus rhythm is restored. And we give another bonus freeze. Always in this patient, the esophagus was close to the right side. So we had the cryoprobe monitoring the right side. RAPV, again, you can see RAPV potentials which disappear with cryo. RAPV, it's you can see there is in this beat, the PV gets isolated. This you are seeing both far field LA potential and PV potential. Here it's only LA potential. So we just go into, with the same Achieve catheter, we quickly go into all the 4 veins. You can see a good electroanatomic map, a lot of good voltages around the antrum. But this is post-ablation. You can see a wide antral isolation, low voltages. So the more than compared to the RF, what we have realized is balloon is more antral, and therefore the problem of PV stenosis is very low, but we can also isolate the vein much faster. So, Chairman, ladies and gentlemen, in summary, catheter ablation with cryo energy is more effective than pharmacological rhythm control for prevention of atrial fibrillation progression. Earlier catheter ablation after AF diagnosis and antiarrhythmic therapy is associated with better outcomes in terms of recurrence of atrial fibrillation, repeat ablations, mortality, and heart failure or hospitalization. I would like to thank the organizers for the kind invitation. Thank you very much.
Thank you, Dr. Narasimhan. That's a great, wonderful talk. And I'm sure that cryoablation is going to be an important modality of treatment of atrial fibrillation, particularly permanent atrial fibrillation. The only question I have, so do you have any data at the moment, the difference between the conventional radiofrequency ablation, let us say by 3D mapping versus the cryoablation in terms of initial success, but much more than that in terms of recurrence on a long-term basis, particularly having so many substrates which are responsible for atrial fibrillation?
Thank you very much. That's a very important question. If the problem is predominantly paroxysmal atrial fibrillation, when people have done this exact, they looked at the question that Dr. Robin was asking. After initial procedure, they have taken these patients again after 9 months and looked at the pulmonary veins. The pulmonary vein remains isolated in about anywhere from 70% in one series up to 90% in another series. So that is the success rate compared to RF ablation, where almost 60% of them are isolated, 40 to 45% of them get reconnected. So that is the answer to the question. In terms of persistent atrial fibrillation, cryo is not the way to go. What we have been doing is we post even persistent atrial fibrillation because, for example, the cases I showed, both of them, one had a roof-dependent flutter in the left atrium. We isolated the roof. The second patient had a typical counterclockwise flutter that was isolated in one patient. So we do a 3D anatomic mapping mainly because it's our learning curve. We don't want any problems. But ultimately, if it's pure paroxysmal atrial fibrillation, you may not need a 3D map.
Right. I think there's a very nice answer. Just before we close the session, just a quick one. In my experience, I'm sure you also found in your experience, there are some people, some patients are really resistant to a conventional drug therapy. They require a quite good dose of beta blocker like sotalol or even amiodarone and so on and so forth. Despite that, they continue to remain in atrial fibrillation and their rate is again relatively high. Is there any particular reason of like genetic predisposition, anything else, or it is just a kind of a dose titration failure? What are your comments on that?
It's a complex question that is most likely there are patients with age. Some of us develop fibrosis of the AV node also. So these are patients where as we become older, even when we develop atrial fibrillation, the AV nodal conduction is weak, and therefore you may have a slowed down conduction. On the other hand, you have a younger patient at the age of 55, 60, where with a robust AV nodal conduction, he develops atrial fibrillation, then it's going to be extremely difficult to control with several combination of therapy. That's absolutely right. And there are other factors which we probably don't know.
Thank you. Thank you very much. So I think there's a great session. I'm sure that we have all enjoyed your talk and we'll continue to have you more with us for our own education, for more learning, and eventually for the benefit of our patients. Thank you very much.
So much, sir.
Thank you. Over to Dr. Dilip Kumar.
Thank you, sir.
Thank you.
There is a question like, do you think cryo is to be replaced by PFA, pulsed field ablation electroporation? So where the phrenic nerve injury is almost negligible and
very, very low, yes.
Kind of tissue specific,
So all of these things in small scale studies have shown exciting results, but as clinicians, we have realized we need outcome studies at the end of, say, 2 years, 3 years. It's not the isolation, but whether it helps the patient in reducing stroke rate, heart failure, hospitalization, so on and so forth. PFA is a promising technology, and the problem is titration of the thing in terms of nanoseconds of pulse energy and the waveform seems to affect the collateral damage. So we still don't know. We need to wait for the final results. It's possible. We don't know the results.
Thank you. Thank you so much.
Thank you. Thank you.
Now we move on to the next presentation by Dr. Anil Saxena. My sincere apologies to all the speakers for the delay. Dr. Saxena is going to speak on CID infections and need of an absorbable antibacterial envelope. And to chair the session, I invite Dr. Punish Sadana, and the moderator of the session is Dr. Samir Mehrotra.
Yeah, good evening, Dilip. Yeah, it's really nice seeing you after such a long time. And without wasting much more of time of everyone, so I invite Dr. Anil Saxena to speak on a very important and a very commonly faced problem for all the electrophysiologists, that is pacemaker pocket infection. Over to you, Dr. Anil Saxena, sir.
Yeah, good evening. Thank you, Dr. Sadana. I completely agree with you that pacemaker or device infection is one of the most important problem all of us implanters face in our day-to-day practice. And this is so important that about 1 to 4% of CID patients have been shown to develop infection. And a lot of patients that we are increasingly doing are considered to be at an increased risk of CID infection, because as the complexity of the devices is increasing, the size, the multiple leads are being implanted, and many patients have comorbidities, immunocompromised. So all these things, they further increase the incidence. So this is the data from a comparison between 1993 to 2008. And we can see that while the CID implants have increased by about, say, almost 100%, but the infection rate has gone up tremendously. And that is because of older age of the patients. More patients have comorbidities. As I said, procedure times are longer, particularly in the CRT devices. And patients have multiple leads, sometimes older leads, and there is more incidence of revisions and upgrades and replacements. So all these are considered risk factors for infection. So all these things are driving up the infection rate. The infection prevention practices have been very diverse. So while everybody agrees, and the guidelines are also unanimous on that, is that patients should get IV antibiotic 1 hour before the first incisions. And practically everybody is practicing it, and 100% patients receive it. The second is about the pocket irrigation. That is, a lot of implanters do this, pocket irrigation with antibiotic. And typically it's about 90% practiced. The post-operative antibiotics are more controversial, and whenever I talk to people outside also and within the country also, about 45%, the data also suggests that about half of the implanters actually give antibiotics beyond 24 hours. We practically, we give to every patient. I don't know whether it is worth it or not, but we give it for 5. We give to every patient. I don't know whether it is worth it or not, but we give it for 5 days after the implant. So there is a diversity in the practices, but despite that, as I said, a significant number of patients may develop infection, and that complicates the matter so much for the patient, because we have to completely extract all the hardware, we have to debride the pocket, allow it to heal, and the patient cannot wait for pacing. Then we have to implant a new device on the other side. And if it's a replacement case, then the leads are very old, and extraction of infected leads is again fraught with danger and huge expense to the patient. So this is something that is a disaster for the patient, and we want to avoid. And we can see that the mortality of CID infection is significant. So patient more CID infection, they have much higher mortality compared to those who don't get infection. The predisposing factors besides like comorbidities like diabetes, CKD, COPD, obesity, heart failure, all these are comorbidities. And of course, some patients may have an immunocompromised state as well. So all these things increase the infection. So my topic is about the antibiotic envelope, which is only one is available in our country, that's Tyrex, which is made from absorbable multifilament mesh, and it is impregnated with antibiotic, minocycline and rifampicin, and it liberates, it releases this antimicrobial for a minimum of 7 days, and maintains the concentration much above the MIC, and it gets absorbed completely in about 4 to 8 weeks. So that's how it looks after implantation, and after 4 weeks and within 9 weeks or so, it is completely gone from the pocket. And there's a data suggesting that it maintains the concentration of antibiotic above MIC for a period of 7 to 10 days. And one important aspect is that the combination of minocycline and rifampicin, it covers most of the organisms that are commonly involved in infection of the Staph aureus or Staph pneumoniae or E. coli, All these are, and H. influenzae, M. catarrhalis. These are the common organisms which are covered by a combination of minocycline and rifampicin. So there have been several smaller studies, but the first large study involving antimicrobial envelope was RAPID study that was published in 2019, and where they included about 7,000 patients, and about 3,500 were assigned to receive envelope, and 3,500 did not receive the envelope. And they found that the infection rate was much lower in patients who received the envelope. About the odds ratio were about 0.6, so 40% reduction in the risk. Importantly, patients who had high power devices, that is the ICDs, they had much greater benefit compared to the low power devices, that is the pacemaker. So that's the data suggesting that the high power devices, they had much more benefit compared to the pacemakers. Now the follow-up study was published recently, and it indicates that the benefit of antimicrobial envelope is sustained beyond first year. So there is continued benefit of the device. Now the envelope is basically recommended for patients according to the risk. So patients with high risk definitely should be considered for TriDect's antimicrobial envelope. And as we can see, the risk increases as the size of the device increases. So compared to pacemakers or CRTs, ICDs and CRTDs have high risk. And then there are other risk factors like replacement, revision, upgrade, patients who are immunocompromised on dialysis, or patients who have had infection. They are at a high risk. So we can always choose accordingly. And patients who have higher risk factors, they should certainly be considered. So for every patient, we can do a risk factor assessment. And this slide is from the latest guidelines from the European Society of Cardiology, and which suggests that there are modifiable and non-modifiable factor. Modifiable are fever prior to implantation, if patients who have skin disorders or heparin bridging. If there is hematoma formation, we all know that hematoma is can be a precursor to infection because it provides a nidus for infection. So that's a very important. Patients who are on temporary pacing for several days before implantation of a device, they are at a high risk. Patients with end-stage renal disease or corticosteroid use or renal failure, device infection previously, COPD, heart failure, malignancy, diabetes, they're all at high risk. And of course, the procedural factors are if the patient is going upgrade of device or replacement of device. Every replacement increases the risk of infection. Then device type, ICD or CRT, as I said, are more prone to infection. If there are more than 2 leads, they're more prone to infection. Dual chamber device is more prone to infection compared to single chamber. So all these factors should be looked at, and we can take a clinical decision to give the antibiotic envelope. So I think I would like to stop here and take any question and maybe share experience with all of you. Thank you so much for listening.
Thank you, Dr. Anil sir, for such a wonderful presentation. And at least we can prioritize our patients for this because it's a costly thing. Because the cost of implant also adds into this. So at least in a high-risk patients like elderly, patient with diabetes on dialysis, or going for high-end devices like CRT-D, we can always opt for this.
So if we look at the negatives, cost definitely is one negative. It's fairly expensive. And although the company offers some compensation in case of infection, but still the cost upfront is very high. The second negative could be that it increases the size of pocket a little bit. So when you plan to use it, you have to make a slightly bigger pocket because after you wrap the device in envelope, the size increases. So in a very frail patient, that can also be an issue.
My observation was also, sir, can we cut it like if the pacemaker, smaller pacemakers, not unlike ICD?
One can cut it, but that will really amount of antibiotic available. Unless you plan to reinsert the cuttings into the pocket, because the total dose of antibiotic will become less. That's the concern.
Thank you so much, sir. And we move on to the next presentation. And the next presentation.
Request Dr. Kathuria to mute, please. Dr. Sanjeev Kathuria, sir.
Technical team, can we mute everyone? So now I invite Dr. Hajra for the presentation. So he is going to club both his presentations on newer hardware in CSP and on AV synchrony in leadless pacemakers. And the chairperson for the session is Dr. Ranjan Sharma and Dr. Devpriya Mandal.
Welcome, Dr. Hajra. So I'll be hearing a very interesting subject on CS pacing and as well as MICRA. Dr. Hajra, please. Is he here, Prakash?
Yes, sir.
Yes, sir.
Prakash is connected, or?
Sir, he is connected. I think some technical glitch. We'll wait for a minute or so.
Yeah, now it's there.
So, friends, today I'll be covering some of the new aspects of your CSP, that conduction system pacing. And I hope you can see my screen, and I'll try to cover both the talk simultaneously, consecutively. Now, this the problem of having new hardware and difficulties is just like an elephant in the room, that this problem is being perceived by many people. But so far, we do not have much to do to overcome this drawbacks of having a lack of proper his bundle or left bundle branch block or delay left bundle branch delay. Now we call left bundle branch a delay rather than a block, because there is no block in left bundle branch. It is only all or delay, because you can correct that delay by going little distal. So to overcome that, we have help of Medtronic, and there is no stellate inside this lead. And the advantage of this hardware is that there is a protruding screw, as everybody knows. The problem is, since you do not have any stellate inside, the pushability of this lead is little bit of an issue in comparison to other leads or other hardwares. Now, once you put this device, and if you are not happy with the position, if you really want to take it out and you have come out with the sheath, it will be very difficult to position the sheath. So you have to discard this lead, and you have to go again. Now, if you lose the slackness of the sheath, slackness of the lead, there is no way you can increase the slackness of the lead inside the heart once you are taken out the sheath. So in that case, you have to shake continuously to shake the stillateless lead to increase the carb or the loop of the lead inside. So there is only one way. Now, if you have a kind of tissue resistance at the entry into the subclavian vein, you have more difficulties. So please dilate the tissue, unlike your regular pacemaker, where regular pacemaker lead, once you come out from the ventricle, it will be very difficult. So if you have luminous, no resistance, it is still possible to increase the loop when you are actually slitting the sheath out. So that is one trick. And second trick in the hardware, use very simple, the insulin syringe. Now insulin syringe or insulin needle with a 20 ml saline, you can produce a jet. So if you inject and if you put that needle tightly on your syringe, a 20 cc syringe, a Luan-Lock syringe, if you have tissue at the tip of your lead, you can use this jet therapy to remove the clot, to remove the tissue from the lead, because once you go inside your septum, definitely you'll produce a muscle biopsy when you come out. So this muscle biopsy has to be removed if you really want to go again. If your jet fails, no point using scalpel, any other things. So if you really want to use this hardware again, you can use the insulin needle to wipe out. It may take about 10 minutes to 15 minutes to prepare the lead again. Now, everything has been discussed. The metrics of your Medtronic lead is that there is a screw outside, and then this black thing you can see on the X-ray. And most of the CSP in our hospital, we have an experience around 60, almost 75% done from Medtronic house. Rest is Biotronic, rest will be Abbott, and only one case from Boston. So now in 2021, this conduction system pacing, LBB zone pacing, can be done with newer hardwares. Every lead or every hardware has got their advantage and disadvantage. So knowing the metrics is very important. And also, if you have a post-CABG patient, if you have any ICD inside, if you have any CID previously implanted in the right ventricle, it may be very difficult because your anatomy may change, the septum may change. So better to take an injection with the sheath, because these leads are costly. And once you remove the sheath and the lead from the tissue, you have to do it again. You may think the costly sheath also. So you choose your implant site. The destination can be found only after injecting through the sheath. But once you are using other varieties of hardwares like Abbott Agili sheath, be careful not to inject when I'll show you when your Agili sheath is abutting the septum. If you inject when the sheath is abutting the septum, it can produce large hematoma, and your dissection plane can go into the coronary arteries, and that may cause some problem, and that may cause hematoma. So this injection is very important. Most of the time, continuous monitoring and continuous ECG can help you to do these cases easily, even if you do not have an EP system. So by this, what I'm saying, you connect the 3-lead or 6-lead ECG with the patient with a V1, and after each and every turn, you take 12-lead ECG. You have to print the ECG. You cannot see it on monitor. You have to print the ECG all the time. You can see the morphology of RBB changing, and you can accept only when you print. That is the proof of pudding by having a surface ECG. Now, the preparation of Biotronic lead is also important. You have another hardware. So you have to protrude the screw from your lead. This is a regular lead, regular DDD pacemaker lead. There is sometimes a resistance. You can defeat this valve resistance by putting the dilator. In Medtronic, you can do it by a small RT forceps, but most of the time it goes in. So once you have prepared this lead, then with the screw protruding out, there is a green funnel separate thing. You have to make at least 12 turns, and you have to make that lead very stiff, taut, and it will work like a stillet, complete stillet rather than a floppy one. So few steps: protrude the screw, keep the stillet inside, and this funnel is very, very important to move or to rotate clockwise to make the lead stiff. If you do not make it, then it will work like any other regular pacing lead, and it may not penetrate. So once you reach the septum destination, not in the apex, you know where to go. The previous presentation has told you. Then you can push. There is a side port, and the side port you can flush, you can inject. Now, while injecting, you have to keep a finger on the entry point so that the dye actually goes inside rather than coming out. So this is the turning of your lead, making the screw out. Once you have done that, then now while you are going inside the septum, slowly the whole assembly, you have to turn slowly. Maybe you can count 1,000, 2,000, up to 10,000 for one turn, another 10,000 for two turns, another 10,000 for three turns, something like that. You have to go up to 9 to 10 turns. Sometimes you have to unturn it if you do not get it. So this hardware is very important, and this has helped in many difficult cases. And this sheath is much more flexible and much more torqueable. They have a different length, different curves from Biotronic. So little different from your Medtronic one. Now, sometimes you can penetrate quite deep if you have left ventricular hypertrophy, hypertrophic cardiomyopathy, hypertensive heart disease. So you know the septal death. And sometimes with this Biotronic lead and the sheath is so strong, you can penetrate the whole septum and you can reach up to the LV apex, which is not a welcome thing. In this case, it is very appropriately done. And this is Biotronic sheath, and this is normal pacing lead. Now, if you want to try Boston on Abbott His locator, it was available. So His locator is a little bit less bulky than Agilis sheath. The problem is, in the His locator, you can accommodate only up to 58 to 60 centimeter of your lead. If you have any lead which is shorter in length, you may not be able to manipulate that lead with Abbott's His locator. So His locator works with Abbott lead at least 58 centimeter. So if you have too many things inside, it can get a little bit of complex. And if you want to work without sheath, you can put a 5 French multipurpose there. So in multipurpose, you can inject and you can see this lead is going inside your septum. Now in Biotronic, another leadless, atrial leadless pacemaker like VDD, Biotronic LV zone spacing. It comes with the VDD ICD. So you just do the septal pacing and put the ICD lead. It will work as DDD, CRTD, or DDD His bundle pacing. Coronary penetration. Sometimes you can see these coronary arteries with this newer sheath. It is not seen with Medtronic one. So be careful. Sometimes this will be seen on the angiogram, but on the next morning, this patient did not have any consequence and she was discharged without any complications. So Abbott Locator Plus and the Agilis sheath has been mentioned. This is stylet driven, and this is Solia S lead, and this is Medtronic. Now coming back to this Agilis sheath, this is very good for His locations, and you can attach the port with your EP system. You can directly measure the His potential, but I do not use this for His because you know the lead division is very high, the lead dropping or displacement is very high in the His position. So conventional, I go for liability zone pacing or conduction system pacing below the His. Now you have to put this lead through this port, and this is torqueable. It goes clockwise. You have to unclock the whole thing once you are slitting this sheath. If you do not unclock or make it in a neutral position in Agilis sheath, you will never ever be able to remove the sheath completely. You will get stuck at the last 10 centimeter of the sheath. So it's mandatory if you're using this hardware to unturn, to make it neutral, and you can also always inject. So it works on Biotronic lead also with your Abbott lead. Now ID and OD is being mentioned here, Dr. Dilip has shown. And the problem with this system, it is so robust, so powerful, sometimes it can cause perforations. So I would suggest if you're using this hardware for locating the His or going into the left ventricular branch pacing, Do not be so hard on your injection. Keep the sheath inside the RV rather than averting the septum. So to summarize then, briefly, there are companies like Medtronic dominating the system with newer hardwares, flexible, steerable sheath. You can go from the left, you can go from the right. You have Biotronic lead, you have Abbott lead, and more and more are going to come. Life is going to be easier. Over to you. Dilip?
Thank you, sir.
You are supposed to give the second talk as well.
Yeah. See, the challenge with this Hispro is the slitting. Although the slitter system is very good, but the bulky Hispro catheter which is there, it can kind of displace the lead which has been deployed earlier, deployed at that time. So this is a real challenge.
Dilip, could you hear my talk? I was surprised.
Yes, yes.
Okay.
I heard you, sir. So
should I finish my micro talk as well so that we can come back?
Yes, sir.
Yeah.
Continue with the micro talks.
Yeah, because time is running out. So this is my one of the favorite talk, leadless pacemaker and Micra, and this Micra AV has come recently in 2020, and it senses the A4 segment of the atrial, and you know this is wireless system with the subcutaneous ICD. Micra can be implanted safely nowadays, and this is 1.7. Oh, sorry.
Brother, share this screen.
Share the screen again, no?
Yes.
Yeah. Can you see?
Yes.
Okay. So this is Micra AV. This is exactly like my ordinary Micra, and there is some improvement in the software. This upgradation of the system, and it works on top of your pre-existing pacemaker. But if you have an existing pacemaker, like you have an atrial lead, the whipping of the atrial lead may cause some problem, and it may give rise to kind of A4 segment or S4 segment in the atria. It can sense the phonocardiographic A4, which is usually atrial lead. So if you have atrial lead, it's better to remove the atrial lead or reduce the slack of the atrial lead so that it does not produce an extra sound phonocardiographically, because this Micra does not sense the electricity, but it does sense the A4 segment of the atria. Now this Micra AV or Micra, in the size is small, it can be implanted even in small young patients who are suffering from complete heart block. So this is the first lady in the world to have a Micra from the iliac vein cut down from JIPMAR, 24 kg, 9 years for complete heart block post BSD closure. Now this Micra AV goes through any large bore femoral vein device, like any large bore femoral device, like Pascal, LA closer, and this is not different from the routine Micra. A right vein is preferred. You can go to the left vein. Jugular sometimes we can do if you have interrupted aortic arch or IVC filter. It is implanted on full dose heparin and bivalodin. Entry and exit. Most of the time we exit through a manual compressions, and many times this large bore device can cause local arterial problem. So it is 27 French sheath. So puncture the vein, then you withdraw the sheath, keeping the wire inside. If you see any spot, perhaps you have gone through anteriorly placed any arterial tributaries, or you have scrapped a branch. So if you see a spot, better to abandon that puncture for any large bore femoral device, because this is very large bore, and when you withdraw on heparin, there is a chance of hematoma. So if you are not confident about the clean venous puncture, sometimes you can take help of ultrasound, but most of the time it is the simple seeing the spot. You can make sure that you have entered vein nicely. Fisherman stitch or a ProGlide sometimes is warranted in the very elderly people. I have used only on 2 cases. Stop NOAC, and you can go for smaller INR corrections. Now, as I said, it corrects the atrial sensing. Now, this Micra AV is equipped with automatic artificial intelligence. It takes almost 2 hours to have the full algorithm working. So if you are not getting proper A4, you can always change the axis, polarity, and sensitivity, the ratio between A1, A2, so many things. There are a lot of things you can do on your own on the table. But if you're not conversed with this kind of algorithmic knowledge, the machine will take care of you. Sometimes, you know, as I said, you can get the AV synchrony instantaneously on the table. If you have a patient who can cough, we can ask for the Valsalva maneuver, the abdominal pressures, and a little change of posture. These things, this AV synchrony can be achieved in 95% of cases. So no point look so hard for the AV synchrony, because most of the time the software will take care. Now, as I said, this is a movement, this is the A4 segment. Anywhere you can place, whether in the apex or in the septum, its sensing is not like a far field sensing of electricity. It usually senses the A4 segment. Like any other micra, you go into the innominal vein with this ampullary super steep wear, and now you can dilate. The micra dilator itself is the best dilator, especially elderly. But if you have some operation in the groin, you can dilate with 18 French and 14 French. Make this ring goes to the SBC-RA junction. And if you have IVC filter, you have to be careful. If you have interrupted arch, better to take a jugular route. There are reports that people have gone through the femoral vein, traversing the azygous vein, putting a sheath in the RA. But in that case, it will be much more difficult to release the micra if you have problem with the threshold. Now, as I said, it is a fall from above. You always fall from above rather than push from below. If you push from below, there may be kinking of the sheath and the mechanism may fail, and there may be a piggybacking on a temporary pacemaker. The micra knows where to go. If you face any resistance, just pull back rather than pushing too hard. Release the tension, remove your hand on the handle. The micra will negate its pressure generated. Now, as I shown on the other side, it is fall from above, and most of the time you'll be able to reach the effects. Rotate, there are 6 movements, piggybacking, and some injection previously, RA1 LAO can help you that reaching the destination. Continuous flashing. Now, slowly it flips back, and as I said, slowly you have to push and you have to produce a kind of tension on the sheath, like a swan necking, little bit of carving, but too much of carving may cause perforations. It's better to be in the lower part of the septum, because if you produce perforations, the chance of death is much less than having a perforation in the septum, because inferior surface perforation can cause devastating tamponade. There are reports of death, so be careful. And sometimes if you are not sure about the apex, you can inject, as I said, and release a recapture. This micra AV, do not pull out the cup inside the RA, because there is a thread. There is no sheath between your cup and the release micra. So if you really have to pull back because of the bad threshold, which is usually less than 0.5 in 95% of cases, unlike conventional pacemaker, even if you can reach 0.3. So keeping this micra threshold below 1 is very important, because the micra, the battery life is only 11.8 years, and you can have upgradation of this micra for developing complete heart block and ventricular dysfunction. You cannot make out which one is actually micra AV and which is simple micra. If you have a 6 sinus syndrome, you can go for a simple micra. But if you have complete heart block or advanced AV block or even paroxysmal AF, you can go for micra AV. The mechanism is same, the hooks are same, and it instantaneously it starts working, and there is no failure of micra. So there is optimal atrial sensing algorithm. So you made this patient walk immediately, and you check for this man had endocarditis, and you remove the lead, and then on the left side you have removed the lead. On the right side we have gone right femoral vein. We have, this is the first AV micra in the country, and this swan knocking is important, device positioning is important, release is important, and most of the time you'll be able to get the threshold in the first attempt. Recapture, I mentioned. Recapture, you have to take this sheath parallel, aligned to your micra. If you do not align this sheath to the micra, there may be cup deformations, and if you are not able to recapture, you just pull everything inside the RA and take the system out and reload the system. So recapturing is required in some cases, maybe up to 5 to 6 times you have to do like a regular pacemaker. It is so nice that even after recapturing 5 to 6 times, still mechanism works. One, it is you are getting all the parameters nicely. You just to cut the tether and take the micra out. And even in transplant patients, there are advantage of putting this micra, and it can be either in the concomitant procedures like subcutaneous ICD, CCM technology, VDD ICD, TAVR. Also, the concomitant ebineural ablation can be done through the sheath, and you can keep this sheath for future device retrieval like VSD device from the right side of the heart. Now, future is actually basically a biological pacemaker, a bioabsorbable pacemaker for a temporary pacemaker. With that, I'd like to thank for your attention. Thank you very much.
So it was a wonderful talk. So we have changed a lot of things in the pacing scenario. We started with the external pacemakers to temporary pacemakers to now we are going into the depth of the. And any question from someone? Just one or two.
Yeah, I think how much confidence you have, Prakash, that this AV micra is going to sustain the AV synchrony? Say that after 90 or 100 heart rate, it loses the AV synchrony. A patient with a high atrial kick, restrictive cardiomyopathy pattern type of feeling, then again the sensing of P gets blurred. So how much confidence do you have in AV micra of present generation?
And look, this micra came in 2020. I have an experience of having micra in our hospital around 6, around 3 or 4 outside Bengal. So it is less than 10, and it is only less than 1 year. So I won't be the best person to answer that question. But if I speak the intuitiveness, mind of mine, and so far there was no issue. But the last case, we did the micra in a patient who has got a mitral valve replacement long time ago, and this micra was sensing something, and this A wave though was perfect on the table, but later on somehow his heart rate was coming down to 44, 45, 46. So we kept it at 60. We still do not know. We have sent this report to US. They're analyzing it. So there may be a problem, as you have told me, as you have raised this issue, that A4 segment sensitivity or tracking that A4 may be an issue because of too much of distance. If you put it too much in the dilated ventricle, too far from the atrial A4 segment, A4 sensing phonocardiographically, or if you have too much of device, or if you have some amount of metallic tissue, metallic valve inside, that can produce a noise. So it is a phonocardiographic sensing. I'm sure they will have some data, may correct. And if you have too much of A or A4, like atrial tachycardia, there may be an issue. But for the time being, in all 7-8 patients, this algorithm working fine, except last patient.
Thank you, Dada. And thank you, Dr. Ranjan Sharma. But I request both of you to stay back for the last presentation, which was exchanged with Dr. Sethi. And I'm going to speak on CRT difficult cases. It will be taking around 5 to 10 minutes, quick presentation. So, and this was quite amazing to have 24 presentations with a delay of half an hour. So it is a remarkable effort. And thanks again to everyone. So see the CRT challenges. Bear with me for next 8 to 10 minutes. These basically, the point was correctly raised. RV backup pacing should be done first, followed by CS pace lead. And the hardware has to be chosen properly. Like if you're going for a normal CRT, then MB2 from left works best, provided the anatomy is proper. If there is a very large right atrium, and or you are going from right, a multi-purpose from Medtronic does good, but St. Jude has got, Abbott has got a CPS, coronary sinus positioning system, and they have got a left and right dedicated catheters. So choosing the catheters is extremely important. So this the lower one has a large anatomy and the multi-purpose does well. and then there are some extended hook catheters. And I'm not going in detail. I will show you some cases. So we have moved away from basically from steerable catheters. These are the Amplage diagnostic catheter, and the Terumo wire works well. And the first stage for any CRT implanter is to have a normal kind of anatomy system, CS anatomy, and a good posterolateral vein and favorable curve, and then it is done. But the second step is to use sub-select catheters. So once an operator starts using sub-select catheters and bringing the patient out with a successful CRT, this is the next step. And third steps happen when something like maybe a venoplasty of vein or support devices or maybe snaring is done. So these basically three evolution, as I have seen in my career, the way a CRT implanter evolves. This is a attain stability lead where it can be fixed, screwed, and then slitting. One of the important aspects is QLV, which has been emphasized by all the presenters in getting an optimized CRT. And suppose in this kind of anatomy, when you take an Amplage catheter and a wire, Terumo wire, and then your MB2 smoothly gets telescoped over this, and then you get a good fine vein with a normal curve, and then you come out with a implantation in maybe 1 hour and 1.5 hours. Similarly, someone has a kind of a dual chamber pacemaker, you are upgrading and getting a good vein, such a nice vein, and then you do it very quickly, come out. But you can encounter these kind of patients when you will have difficulty facing these kind of patients when they have got very angulation, like from right atrium to coronary sinus and up, there is a large angulation, then difficult, you have to know how to maneuver it. And sometimes the the CS tributaries are not appropriate, and then enough support is not there, then start using a sub-select catheter with a lesser threshold. Don't stress yourself, don't put 2-3 wires to take support. Take a sub-select catheter, it will do your job much easier, make your job much easier, and you can appreciate this. Sub-select will give you a very good support and lead goes in. Sometimes this gentleman had a single chamber pacemaker, and single chamber pacemaker was replaced, and finally he landed up with a pacing induced cardiomyopathy and with recurrent failure of normal coronaries, and you can appreciate left side when we're totally occluded. There was no scope of going from left, and right you see the severe angulation. So these are difficult anatomies with a 77-year gentleman and with a thin built patient. So this is the most difficult kind of patients. You have to be very, very careful in each and every step. You see the angulation, the wire is not going, and the loop which the wire is making. And even with the best of care, you see how on dilator we had to negotiate it to there in the right atrium. And even with best of precaution, we had dissected the subclavians and part of the SVC, but we had our wires down, and you can appreciate the problem. From right side, it is always a difficult curve, and this, in spite of having a multi-purpose catheter, CS catheter, we had a very severe problem in taking the catheter sheet up in the coronary sinus. So it required more of manipulation, and in fact, we had used support, hard wires like Amplage's stiff wire to take it inside. And then sometimes when you have a kind of left the vein tributary which is very close to os and going to the posterolateral aspect, then you need a support system like a wire additionally in the CS body, so that you can at your will you can position the CS catheter inside the coronary sinus, and then finally you can do it. These patients are marked very difficult, a DVR patient or MVR patient, but mind it, it is a similar kind of thing, but you can face a lot of structural anomalies in these patients. So this gentleman with DVR, we gave the patient low molecular heparin for 4 days. He was off warfarin, and then we took the patient. This patient had a severe stenosis in left subclavian, and we had it was not going. You see the dilator is not going, and then we had to do it venoplasty first, and then finally we could take our shock lead down. So these DVR patients, MVR patients, post-operated patients, I must say, they have got difficult anatomy, stenosis. You should be ready with all these, gadgets of peripheral venoplasty or, the different catheters to maneuver to weigh up in your coronary sinus. So we published this in JACC. So sometimes you get a kind of abnormal veins. So here we were getting a lumen and we were injecting it, and it was not at all a dissection, it was a definite lumen. So it was a large Thebesian vein which was confusing us. So initially we thought, what has happened to coronary sinus? How can it be so atretic and so small? Every time we're going inside that vein and we're injecting, it was filling up, and 2 to 3 minutes after that it was getting cleared, and it was something working like a ball wire. Then we finally got the normal coronary sinus, and we did the case. So it's a large Thebesian vein, creating a problem to us. So this also got published. This was a post-MVR patient. So a post-DVR, post-MVR patients are not in, kind of a ostracized patient. They can be taken, and the results can be better in these patients. And these patients have survived. He survived after 6 years after that, and unfortunately he died of a brain hemorrhage. He was on warfarin, but he was doing perfectly fine from the heart function point of view. This last case, sometimes you do around 15 punctures, 20 punctures, and you are not getting a puncture. What to do? And because the vein sometimes go in spasm, and sometimes they're underfilled vessels, difficult to puncture, sometimes difficult anatomy, and then a cut down, knowledge of cut down is also is extremely important and becomes handy. So this patient, we cut down the cephalic vein, and we introduced three wires. You can appreciate 3 wires, and then we dilated it, and we do the CRT through cephalic. This was my first case, CRT through cephalic. Until now, I have done 3 cases through cephalic approach. So these abnormal challenges will be there when we are doing large number of cases, and we have to be ready for that. So thank you so much for the patient hearing, and we can have the final comments from the chairpersons, and then we'll conclude the today's event.
Yes, this CRT, you never know how much time it will take, and you must be having innovative mind to complete the procedures. You can encounter difficulty right from the puncture to placement, even withdrawing the sheath. All these things are very difficult, and you need patience and some innovative mind. You have shown some good cases. Thank you, Dilip Kumar.
Dilip, can I come in?
Yeah.
You always tend to use a Platzer catheter to engage the CS?
Yes. AL1 or AL2, depending on the curve. And with a thermo wire.
I think you can try one thing, which is a JR5F catheter. I must have done 30 to 40 CRTs only with a JR catheter. Only once or twice I required when there was a normal origin, so a Platzer was required. The advantage of a JL5F is its maneuverability is very good. So it goes deep inside the CS. So your support becomes very good. The second advantage of a 5F JL catheter is that even if you want to proceed in a subselect vein, into a vein where you use a subselect, a JR5F is very maneuverable, especially if it's of Cordis or Medtronic is also good enough. So even you can come to the mouth of a vein and introduce your whisper wire or any wire, and subsequently you can do your procedure. So I feel
Sanjeev,
wherever
the problem with JL5, the catheter JL looks up. And
no,
the
sorry,
coronary
I'm
sinus
saying
looks
JR.
down.
No, I'm not saying JR. JR. I'm sorry, JR.
Yeah.
JR. So
JR can be an option. Yes, but Amplage is got a natural curve, and it goes and the coronary sinus. Yeah.
But with a JR, in fact, it did it today also. In the JR, I have never failed. Only once it required that the sinus origin, the CS origin was little upward directed. So the JR just couldn't hook it. One very good method of getting to your CS is that once you do your angio to know the position of the CS, always get the TPI in and then do the angio. So your curve of the TPI, the relation of the curve of the TPI to the CS ostium is a very good marker to know where your CS is. You can take that in two views, an LA view and a PA view, and then your hooking will become much simpler. In the sense, not simpler, but much more guided, because you will have a space, you will have an area where you know the CS is definitely there. But of course, whenever I have heard people have been using Implodger, but in the last conference also in Delhi about 2 years back, I just said that we have till that time we had given about 20. I have always used a GR. But after that, I had to use Implodger in one.
Any final comments from Dr. Hajra, Dr. Saxena, Dr. Anunay, Dr. Yadav?
No, I use mostly your DECA, prefixed DECA, not the reflectable tip DECA. And from right side, if I have to do, I use Amplodge. AL2 I prefer from the right side, otherwise, I think I have hardly any failure from the left side because we are EP person, so we are used to, because we put your all DECA in all EP patient from internal jugular, so we are used to handling this.
Yeah, EP catheter, but sometimes it can be traumatic. So Saxena said,
we also begin with DECA. I mean, it's not usually, because we have been placing it. So as Dr. Yadav said, we are quite comfortable with DECA, but if within 2-3 minutes or 5 minutes, if we are not able to cannulate it, then we move to JL2 or JL1 or JL3, whatever, depending on the atrial size. And that's our second best choice. And using a Terumo wire. Usually it doesn't fail.
What we have seen,
another thing,
there is a problem when there is angulation, CS angulation. Then when you are introducing sheath over that, at that time some trauma can happen. So it's not the DECA.
Yeah, definitely. Angulation is a problem. One other trick that sometimes works is that if you find that the CS is up pointing and you cannot enter it, you can try to cannulate it from below with a separate catheter, and that will make it a funnel-like structure. It pulls the opening down, and then you can cannulate it with your CS catheter.
Actually, what happens in LALV enlargement, there is hockey stick shape of your CS. So, and that easily nowadays, I trained other people where the DECA is not available. I trained them with St. Jude TPI lead, 6 French TPI lead. And that lead curve is pre-fixed, pre-made, and it goes easily into the CS. And second thing, sub-select. In case of sub-select, I use IMA catheter to hook the down-looking vein. It engages, and then you put the PTCA wire through that, and then
you need to take exchange length PTCA wire, larger PTCA wire.
No. Usual PTCA wire goes because it's enough length. It is of no concern. You take IMA catheter, 5 French, and rotate it. It will engage to the if there is a vein there. Particularly levophage.
Yes, sometimes the wire becomes shorter. So I take generally larger wire when I take a IMA or maybe a Amplodge going inside the tributary, angulated PLV, postlateral vein, and then we take the coronary wire, larger coronary wire, and then exchange it over with the lead.
I was saying what Dr. Yadav is saying. Dr. Yadav is saying about an IMA catheter. I was saying about a GR catheter. So you don't need any exchange length wire, because what I tried to emphasize was if your wire goes into the vein, through the sinusoid goes into one of the chambers, you will get a very good support. You don't need an exchange length wire at all, because you're not going to use it as a subselect. You are just making sure that your sheath reaches the mouth on the RCA or on the IMA, and then you withdraw the JR catheter or the IMA catheter, and then take the lead on the PTCA wire which you have put. So it is acting as a subselect, but it has to be taken out to put the lead, because it's not going to get cut. Normally you are able to cut. If you put a subselect, you are able to slit it, but you cannot slit this JR. So you have to take out the JR. You have to take the sheet to the mouth of the vein, take out the JR or the IMA, and then put the lead over the wire, which is now into the sinusoids and into one of the cavities.
Yeah, that is where sometimes you need a longer wire. That's what I was telling. Many times the same wire works, because you have to keep the wire there, you have to take out the JR, and then you have to take the lead over that wire. So thank you so much, Dr. Saxena sir, Dr. Yadav, Dr. Kachuria, Dr. Hajra, Dr. Ranjan Sharma, and Anunay, Dr. Biswajit Majumdar for being here so late, and thanks everyone, all the faculty members. And I'm extremely sorry for the delay. We had 24 presentations, but we could finish that, and it was a wonderful. And I didn't expect it would go that way, and it would be that better. We have got so many good feedbacks, and hope to see all of you again next year. Thank you, sir. Thank you, everyone.
Thank you, Dilip. Thank you. Nice.
Well organized.
Thank you.